Good morning, everyone. I'd like to thank you for attending our course. And apropos of the title, this is truly a comprehensive spine course, and we have a variety of experts to offer you their expertise in treating the care of the spine patient, including those from physical medicine, rehabilitation, rheumatology, neurology, anesthesia, physical therapy, and orthopedic spine, as well as neurosurgery. So take a seat back and enjoy our course. I'm going to turn it over to our distinguished colleague, Dr. Charla Fischer, who's going to moderate this section.
Great, thank you, Dr. Protopsaltis. So our first section is on clinical assessment to see how are we evaluating our patients that we see. So our first talk is with Dr. Jegede on buttock pain. This is a very challenging issue. Is it the lumbar spine or the hip?
Thank you very much, Dr. Fischer. So, good morning, guys. Today I'll be talking about buttock pain. Is it the lumbar spine or the hip? And so I'll go through and discuss differentiating hip and spine pathology through clinical exam, imaging, and interpretation of diagnostic and therapeutic intervention. So let's get started. Next slide. So, pathology involving either the hip or the spine can often localize to the buttock, thigh, or lower extremity. And this can create notable challenges for the clinician when attempting to distinguish between the two. Clinical interpretation can become further muddled in individuals presenting with pathological changes involving both the hip and spine. So the so-called hip and spine syndrome. So the hip spine syndrome was originally described in 1983 by Orthopedics and McNabb. The clinical scenario of concurrent hip osteoarthritis and degenerative lumbar spine disease associated with stenosis was essentially the definition. And its initial description, it only included discussion of osteoarthritis. But through further evaluation, further research, we found that anything that alters range of motion may lead to increased stress through the SI joint and or the lumbar spine, thus predisposing a patient to hip spine syndrome. So these diagnoses include FAI or femoral acetabular impingement and acetabular dysplasia. So they broke up their hip spine syndrome into 4 categories, which include simple, secondary, complex, and then misdiagnoses. So we break it down and define these things. Simple, despite having apparent pathological changes in both the hip and the spine, the primary source of the symptoms can be clearly attributed to either the hip or the spine. Secondary causes of hip and spine are interdependent on each other. Complex are concurrent pathologies that are both in the hip and the spine. However, there's no primary source of pain. And the misdiagnosed is exactly as it sounds. The primary source of pain is incorrectly diagnosed, leading to inappropriate treatment. So there's been a growing interest in hip and spine syndrome since it was originally described. So the anatomical location of the hip and spine with overlapping soft tissue influences have been proposed as a key factor in the development of concurrent hip and spine pathology. So logically, impairments in one region may be expected to affect the other. For example, the patient has has a flexion contracture of the hip that may cause anterior pelvic tilt and increased lumbar lordosis, leading to loading of the facet joints. Alternatively, scoliosis of the spine may lead to lateral pelvic tilt and hip instability, predisposing a patient to hip pain. And despite growing attention and research in this area, there still remains many unanswered questions. So this is a busy slide, but a thorough physical exam is important and paramount in order to further elucidate the primary pain generator, which is a goal when seeing these patients who are presenting with hip spine syndrome. In the context of hip spine syndrome, where patients are likely to demonstrate pain across multiple anatomic locations, concordant symptom reproduction cannot be overemphasized. So essentially, concordant symptoms reproduction refers to the recreation of the exact symptoms for which the patient is seeking treatment for. In my opinion, this may be easier to elucidate in patients who are presenting with hip pathology as their primary source of pain. So hip joint pathology may be suggested by the reproduction of symptoms with manipulation of the joint itself. So this includes maneuvers such as the log roll, which is essentially internal external rotation of the leg, and other maneuvers such as the Faber or flexion, adduction, turn, and rotation. We look at SI joint pain that may be reproduced with direct palpation along the SI joint, and a variety of provocation techniques have been proposed in the diagnosis of SI joint mediated pain, including the SI joint compression test, distraction, or also known as the gapping test, the Faber's test, which I recently mentioned, also known as the Patrick's test. And as a general rule, particularly for SI joint pathology, these tests are regarded to have poor sensitivity and specificity in isolation, although the compression test and thigh thrust tests have the highest or the greatest utility. So diagnostic yield is notably increased when having positive findings across 3 or more of these provocation tests, particularly when in the setting of unilateral SI joint pain and then pain with transition. So transitioning from sitting to standing or getting lying to sitting, for example. And then physical exam findings are also less predictable in persons with spinal stenosis. So you can see the radicular findings as positive straight leg raise test or femoral stretch test in higher lumbar radiculopathies. Other findings include decreased reflexes, diminished sensation, and pain in the dermatomal distribution. So other things that we should evaluate when looking at these patients are their gait. So hip patients who are coming in with hip pathology can present with antalgic gait. You can see Trendelenburg gait in a patient with L5 radiculopathy. You can see patients with a high steppage gait in the setting of a foot drop. Also, palpation of the paraspinal muscles is important, and also over the greater trochanteric region in patients who are presenting with bursitis as well. So other special tests include straight leg raise test, which we talked about, contralateral straight leg raise, which is more specific than a straight leg raise, the femoral nerve stretch test, and then hip impingement for things such as FAI and SI joint as well. You can use the Faber and the flexion, adduction, turn, and rotation test. Okay. So the patient history is paramount in establishing the correct diagnosis, and has been suggested that patients with groin pain are 7 times more likely to have a hip condition influencing their clinical picture. Another study suggested that the presence of groin pain to be 84% sensitive and 70% specific for patients with hip osteoarthritis. However, hip osteoarthritis can commonly refer to the buttock, thigh, or even to the knee, which complicates the picture. SI joint pain is commonly referred to the buttock, but also can be referred to the lateral hip or groin. Importantly, referred pain from the SI joint is typically exacerbated by transitions in movement, as I mentioned earlier. And then lumbar stenosis patients can describe symptoms consistent with either lumbar radiculopathy or neurogenic claudication. In lumbar radiculopathy, they'll have pain in the dermatomal distribution, whereas patients with neurogenic claudication will ambulate with stoop forward gait and can complain about pain in the buttocks, posterior and anterior thighs, or just the back. By definition, hip spine syndrome indicates the simultaneous radiographic presence of hip and spine disease. Therefore, imaging alone has a limited role in diagnosis, but it can definitely help. The first step is getting plain radiographs, AP and lateral views of lumbar spine. Flexion extension views can be added as well to look for instability. MRI and CT scans can be added on when indicated. And then electrodiagnostic studies such as EMG and nerve conduction studies can help parse out difficult diagnosis. So negative results, particularly for for EMG, does not preclude radiculopathy. And it also may be helpful in differentiating nerve root signatures if unsure what level the pathology is originating from. And then a patient with claudication, if there are normal imaging studies in the lumbar spine, you can think about vascular claudication. So you want to get duplex ultrasounds, angiography, or referrals to vascular surgery. So here we see measurements of the alpha angle, which can help us reveal issues with impingement and FAI and the lateral center edge angle on this image on the right. You can look at coverage, and this can be particularly helpful in patients without any overt signs of hip osteoarthritis presenting with hip and back pain. So when we get into patients who we're not sure what the diagnosis is, we can use diagnostic injections. And in terms of the hip, it's quote, literature quotes at 87% sensitivity and 100% specificity. So you can do lidocaine only injection in the hip, and if the patient has relief of their hip pain, that can point you down the road of it being a primary hip pathology. However, if the patient is in significant pain and is a candidate for a total hip arthroplasty, you have to remember that there's literature that supports that there's increased risk of infection in patients getting injections in the hip 3 months around their surgery. Doing epidural injections, whether it be transfemoral or interlaminar, are less well defined. There's uptake of steroids throughout, and hard to say that it actually helps us pinpoint that the pathology. And also patients can sometimes be worsened with injections, however, still respond to decompressive surgeries. So it's also important to have a thorough differential in these patients using history, physical exam, and diagnostic interventions to help hone down your diagnosis. So your mind only sees what the mind knows. So this is a chart looking at suggested algorithm for treating patients with hip spine syndrome. And just for the sake of time, we'll just continue moving on. So we also see postural changes on the lumbar spine alignment due to hip pathology. And so in the standing position, the lumbar spine has a lordotic curvature, the pelvis tilts anteriorly, and the hip center is shifted backward to remain centered under the spine. And we see that in the image to the left. In the image on the right, the patient is sitting, and you can see that the lumbar spine straightens and the pelvis tilts posteriorly, and the hips shift forward. So this is a patient who has concomitant hip and lower spine spondylosis. And what we can see is that in patients with hip spine syndrome, the hips and lumbar spine lose their ability to rotate and extend normally, leading to abnormal orientations in standing and also in sitting as well. So I'll go on to a patient. This is a 25-year-old patient that presented or was referred for evaluation for a spinal deformity. His chief complaint was back pain, has a past medical history significant of ankylosing spondylitis. You can see in the AP image to the left that the SI joints are completely obliterated, and the image to the right is a standing image of the gentleman. We move on to see his scoliosis films, and at a quick glance, one can assume that the patient has a spinal deformity as he is leaning forward and is unable to stand up straight. See his AP image here as well. And so when we further investigate the imaging and the patient's exam, we see that the patient has almost no pelvic tilt, so they're not compensating at all. And so there's a measure, accepted measure to look at spinal deformity, and particularly alignment, which is the sagittal vertical axis, which is a C7 plumb line dropped down to the posterior superior corner of the sacrum, and it should be within 4 centimeters. Now, this gentleman is significantly higher than that. However, he's not compensating. So what we know is that his pathology is likely not from the spine. And our division chief described a novel angle, the T1 pelvic angle, which when measured on this individual is normal. So what is his problem? He has a flexion contracture and severe hip arthritis bilaterally. You see him on the exam table, and his attempts to stand up straight here in the office. The guy was wheelchair bound. So essentially, we were able to get him over to the right. People get bilateral hip replacements. He's able to stand up straight and denies any back pain at this time. And so, should you do the hip or spine first? Questions that you ask yourself is, which is most symptomatic? Is there pre-existing sagittal spinal alignment? And you can refer to your spine colleagues to help you answer that question. And do you anticipate a change in pelvic tilt as a result of either the intervention in the setting of a fixed flexion contracture or a sagittal spine realignment? And then the clinician must understand the desired and undesired effects of hip and spine treatment and their decision-making algorithm. So here's a little chart, essentially going through it. Which is more symptomatic is the hip, then treat the hip first. If it's equal, then you want to look at malalignment and pelvic tilt. And obviously, if it's the spine that's more symptomatic, you're going to go from there. If there's issues with alignment, then and there's a major spine realignment that needs to be performed, you're going to go with the spine first. And then if there's not, you can go with the hip first. All right. Thank you guys for your time.
All right, thank you so much, Dr. Jegede. And then next up, we have Dr. Jonathan Stieber. He's going to be speaking to us about pain in the neck, evaluation of neck and arm pain.
Thank you, Dr. Fischer. Hi, good morning. My name is Jonathan Stieber. I'm an orthopedic spine surgeon. We're going to be talking about the neck and the arms. All right. So first off, epidemiology of neck pain. I've gone back and done a lit search to see if there's any more recent epidemiologic data. But the best we still have is according to this Global Burden of Disease survey from 2010 that show that neck pain is the fourth leading cause of years lost to disability, ranking only behind back pain, depression, and arthralgias. About half of us will experience a clinically important neck pain episode over the course of our lifetimes. And more women tend to experience high disability neck pain than men. A best evidence review of the current literature show that up to half of us, or 50% annual prevalence of neck pain, with upwards of 11.5% of pain being described as activity limiting. So this is a pervasive and common problem. Who gets neck pain? Well, we all get neck pain, and certainly we're going to talk about pathologies behind neck pain. But there's some literature that shows that certain variables, including psychopathology, sleep disorders, smoking, and sedentary lifestyle can be associated with neck pain. Certain occupations, such as office and computer workers, manual laborers, and healthcare workers, have been found in some studies to have a higher incidence of neck pain. And major workplace factors associated with the condition: low job satisfaction and perceived poor workplace environment. So there is some psychosocial aspect to a lot of the neck pain that we will all see in our offices and our practices. Natural history of neck pain, good news, it's generally a self-limiting condition. It often improves with little or no intervention. A lot of studies, or several studies, have reported a range of improvement between 36 and 95%. However, between 22 and 32% of patients will go on to experience persistent pain, which is clinically significant, and that's where this talk will really focus. Differential diagnosis. What I've always told the medical students and the residents is that we first rule out the bad things, the scary things, the things that need more urgent treatment, including neoplasm, discitis, and infection like epidural abscesses, meningitis, cervical myelopathy from cord compression, central nervous system disorders, trauma, and radiculopathy that's resulting in a profound or rapidly progressive neurologic deficit. So again, rule out the bad things. And then once you've done that, you don't have to worry so much. You have time to treat the less urgent causes of neck and arm pain. So here's a metastatic tumor of C5. You can see the low T2 signal, the C5 vertebral body, and some effacement of the cervical cord. There's an epidural abscess. It's seen probably better on the right axial view with that high T2 signal, which is compressing and having mass effect on the cervical cord. C6-7 fracture dislocation in the lower cervical spine. Again, among the bad things. Non-urgent, uncommon things in the differential diagnosis include cold trauma, including fractures, rheumatoid arthritis, other arthritides, ankylosing spondylitis, and diffuse idiopathic skeletal hyperostosis, or DISH, OPLL, ossification of the posterior longitudinal ligament, Paget's disease, seronegative arthritis, again, psychogenic pain, including fibromyalgia, although maybe fibromyalgia is not psychogenic per se, sternocleidomastoid tendonitis, longus coli tendonitis, hyoid bone syndrome, some things that can give anterior neck pain, polymyalgia rheumatica, and then some of the crystal deposition arthropathies can result in neck pain. Neurologic evaluation. So the two entities that we see stemming from a cervical pathology include radiculopathy and myelopathy. And these are not necessarily independent and distinct. One can have a myeloradiculopathy with features of both. But a radiculopathy is a nerve root compression, can be unilateral or bilateral, can be multiple nerve roots. These are lower motor neuron lesions. And these manifest in pain, numbness, tingling, paresthesias, and weakness. Myelopathy, on the other hand, is spinal cord compression rather than just nerve root compression. These are upper motor neuron lesions. Symptoms include loss of manual dexterity and fine motor skill, as well as gait dysfunction, clumsiness of walking, tripping, stumbling, and things of that sort. Referred pain can come from the neck, from a variety of visceral disorders. This chart it gives us a sense of where some of that pain may be located. And so when a patient does have new onset back and upper sort of cervical thoracic pain, it's important to keep in mind that it may be a hallmark of an extraspinal disorder that requires workup and management. Other non-urgent common spinal pathology, and this is where this talk is really going to focus, and where my practice and our practices focus. Intervertebral disc herniation in the neck, spondylosis, which is a inclusive term for both the arthritis of the uncovertebral joints, as well as degenerative disc disease and disc herniation, generalized degeneration of the neck. There can be isolated arthritis of the facet or zygoapophyseal joints in the neck, which will usually give posterior pain, perhaps more pain with extension in the neck, postural disorders or deformities, including kyphosis, and then soft tissue injuries, including muscle sprain strain. Here's a C6-7 disc herniation resulting in compression of the right C7 nerve root. This is traditionally going to manifest in pain down the posterior aspect of the arm to the dorsum of the hand. Weakness from this lesion would typically result in triceps weakness and wrist flexor weakness, and numbness to the dorsum of the hand and maybe the long finger. C5-6 disc herniation, also very common, actually the most common on the left side here in the proximal neural foramen. This is going to result in a left C6 radiculopathy. Traditionally, this is going to result in pain in the anterolateral aspect of the arm down to the thumb, index finger, and the radial aspect of the long finger with associated decreased sensation. It may result in weakness of the biceps and the wrist extensors. Here is a multi-level cervical spondylotic myelopathy with compression of the spinal cord. And on the right, we can see an area of spinal cord compression. And when the spinal cord is really unhappy or has suffered greater injury, we can see a T2 signal change within the spinal cord, indicative of spinal cord injury that is termed myelomalacia, and we treat this more aggressively than just cervical stenosis. There's cervical spondylosis, a degenerative spine, and then kyphosis, loss of the normal cervical lordosis or arc of the neck, a falling forward, or even a swan neck type deformity that we can see. Other non-urgent common spinal pathologies. That was a repeat slide. I don't know why that was in there. Basic elements of the physical exam, per usual, include inspection, palpation, range of motion, neurologic examination, and then special provocative testing. For the cervical spine, normal cervical flexion is going to be 50 degrees, extension 60 degrees, left-right bending to the shoulder 40 degrees, and bending to the shoulder 40 degrees, and then lateral rotation 80 degrees to the shoulder. Sometimes we'll talk about how much space there is to chin on chest in terms of breadth of fingers, or whether the occiput can extend to the spine, and whether the chin can get to the shoulder. Sensation, here's your classic Netter diagram with the various dermatomes. Referred pain from the neck can go all the way from the occipital cervical region all the way down to the periscapular region. It's extremely common for patients with especially C5-6 and C6-7 disc herniations to report concomitant pain referred to the trapezius and the medial periscapular region, C6-7 perhaps to like the medial periscapular region. And this may be in association with upper extremity pain. Sometimes this is present exclusive of true radiculopathic or classical radiculopathic pain down the arm. Strength grading goes from 0, meaning no muscular contraction identified, to 5, which is full strength against full resistance. Upper extremity motor exam, the sort of quick and dirty or the pointer muscles are going to be C5, predominantly deltoid, C6 biceps, although certainly there's some C5 contribution, C7 triceps, C8 extension of the index finger and finger abduction, and then T1 interossei. Reflexes are graded 0 to 4+, with 2+ being normal. Less than 2+, hypoactive reflexes are going to be usually indicative of a radiculopathy or a compromise of the nerve root or distally, whereas hyperactive reflexes are going to be more indicative of upper motor neuron lesion and myelopathy. Reflexes, again, most commonly associated with the major muscle groups. C5 reflex, biceps, C6 brachioradialis, C7 triceps. In the lower extremities, patellar tendon reflex, L4, ankle jerk reflex, S1. And those can be helpful confirming either a cervical level cord compression or perhaps cord compression that's occurring in the thoracic spine below the cervical spinal cord. C4 lesion can result in serratus anterior and long thoracic nerve compromise with medial scapular winging. Here's your brachial plexus, and you can see that the C4 does have a contribution to the long thoracic nerve. That would be a C3-4 disc herniation, which would be most common to affect C4. Provocative maneuvers for radiculopathy include Sperling's test, which is an extension of the head, ipsilateral rotation, and side bending to compress down the neural foramen and to inflame the already pinched nerve root. Axial compression test also compresses down the neural foramen to elicit a response. And shoulder abduction test or shoulder abduction sign, we'll have patients that come in and they're sitting in our waiting rooms with their hand on their head. And why are they doing this? They're doing this to put some slack into the brachial plexus and the nerve root and to take it off stretch. And this is fairly specific for more advanced cervical radiculopathy. Myelopathic tests and signs include Babinski tests, plantar responses, which normally would be downwards, but certainly upwards, maybe with even translation with cord compression. Hoffman's sign, flicking of the relaxed middle finger on the hand results in clasping of the index and the thumb. Finger escape sign, asking the patient to hold their hand out with their fingers adducted and the ulnar digits drifting outward. Inverted radial reflex. Scapulohumeral reflex is consistent with upper motor neuron pathology, that's cephalad to C3, generally speaking. The Hermite sign, forced flexion of the head down onto the chest results in a lightening sensation down the spine and down the arms and legs. I once had a patient with congenital stenosis who was a professional dancer, and he described that whenever he whipped his head down, he felt lightening down his spine. He ultimately required a decompressive procedure. And then ankle clonus, jerking the foot dorsally, that results in persistent beating of the foot. And this is consistent with more advanced cervical myelopathy. History red flags include advanced age, or age over 55, high energy trauma, low energy trauma in the context of underlying pathology, like known ankylosing spondylitis, for instance. History of prolonged steroid usage, so perhaps someone with pulmonary issues or Crohn's disease. Patients who have bowel bladder symptoms on presentation, unexplained weight loss, which might be consistent with neoplasm, night pain, same thing. Non-mechanical pain, a pain that's always present. History of IV drug use might result in infection. Patients with HIV or hepatitis who might be immunocompromised, and patients with systemic inflammatory diseases. Exam red flags, some of the neurologic findings that we've discussed. Obvious deformities, radiculopathic symptomatology, gait disturbance, so perhaps a wide-based myelopathic gait, documentation of unintended weight loss, serious systemic disease and illness, and then severe persistent restriction of range of motion. And these can be broken down into different categories that give us some guidance as to how aggressive we should be with imaging and management. Everything from patients who have no signs or symptoms of fracture, spinal cord injury, neurologic injury, neoplasm, no red flags whatsoever with short-term pain, who either require no further investigation and minimal intervention with self-care and reassurance, to patients with major pathology like a fracture, myelopathy, neoplasm that require possible admission to the hospital for rapid and thorough investigation, workup, and treatment. Indications for imaging. So patients who require immediate or initial imaging include those who have those red flags, patients with a history of previous spinal surgery, patients for whom delayed imaging may be appropriate are patients who have pain that persists despite treatment greater than 6 weeks, patients who have symptoms that are incapacitating, or symptoms that are progressive or worsening. Plain radiographs give us the highest yield, or the highest yield plain radiographs, I should say, are the lateral cervical radiograph. Radiographs are poor in determining early stages of infection and malignancy because there's insufficient bony destruction oftentimes to pick it up. We need more advanced cross-sectional imaging to pick up tumor or infection. They are very useful, however, for the assessment of sagittal alignment, for vertebral or facet subluxation or dislocation, for fractures, for disease of the facet joints or the uncovertebral joints, for evaluating spondylosis and disc degeneration, for evaluating the relationship of the occiput to C1 and C1 to C2, for identifying congenital deformities and congenital spinal stenosis. Other cervical views that we use, antero-posterior view is helpful for determining coronal deformity and as well as arthrosis of the uncovertebral joints and facet joints. The open mouth odontoid view allows us to visualize C1, C2 for C2 fractures as well as arthritis of the atlantoaxial joints. Oblique views allow us to see bony foraminal stenosis as well as the facet joints. And flexion extension views help us to determine the presence of instability. Advanced imaging studies include MRI. Obviously, MRI shows us the disc, it shows us the nerves, it shows us the spinal cord. It can help us diagnose the syrinx or myelomalacia. It's going to be among our best studies for identifying infection and tumor, as well as soft tissue injuries and profound soft tissue injuries like ligamentous injuries. CT scan, on the other hand, gives us our best view of the bony anatomy. It helps us with our grading and judgment of the arthritis of the facet joints or the uncovertebral joints. It shows us whether there's a calcified component of a disc herniation or ossification of the posterior longitudinal ligament. This is going to help us diagnose ankylosing spondylitis or DISH. It's going to show us congenital anomalies such as failure of formation or failure of differentiation. And post-surgically, it's going to show us whether bones have failed to heal with a pseudoarthrosis. It's going to show us if there's an issue with hardware placement, with loosening, migration, or misplaced hardware. Here's a patient who suffered an AP, who suffered a diving accident where he hit his head. Here's an AP and lateral view. Everything looks fine. However, this is a muscular young man. We don't visualize all the way down to the cervical thoracic junction. And on CT scan, we see that there's a C7 burst fracture resulting in profound canal stenosis and cord compression. And this would have been missed if we only got lateral radiographs. When we get lateral radiographs, we need to make sure that we're visualizing all the way down to T1. And if we're not, then a swimmer's view or a CT scan may be necessary. So in the event that MRI is contraindicated or there's hardware artifact, or sometimes for surgical planning purposes, a CT myelogram can be very helpful. And that's, of course, a CT scan with dye in the cerebrospinal fluid that allows us to evaluate for stenosis, cord compression, and proximal nerve root compression. MRI and CT are often both necessary for surgical planning purposes. And all this imaging needs to be taken in the context of the natural progression of cervical spine degeneration, which is age-related. And as we get older, the prevalence of asymptomatic findings on imaging grows. And so as we tell the patients we don't treat the MRI, we use the MRI to help treat the patient. Other diagnostic studies that may be helpful include injections or medial branch blocks of the facet joints, cervical epidural steroid injections or selective nerve root blocks, electrodiagnostic studies, surgical indications. Who do we actually operate on? Generally, those are patients with neurologic symptoms that are either profound, progressive, or persistent. Certainly cervical myelopathy that's clinically symptomatic or where there's a T2 signal change, those patients are usually best treated with early spinal cord decompression and surgical intervention. Patients with cervical radiculopathy, those are the patients we operate on for cervical radiculopathy, either present with a profound neurologic deficit, strength graded less than 4/5. Patients who have a progressive neurologic deficit who are growing in the wrong direction. Patients with a persistent neurologic symptoms despite at least 6 weeks of non-operative treatment, failure of non-operative treatment. And sometimes we do operate on patients who only have pain, neurologic pain, that's been recalcitrant to other non-operative treatment for greater than 6 weeks. Neck pain. We don't usually operate on isolated neck pain, but there are certain circumstances where it's reasonable and appropriate. Again, surgery for axial neck pain is rare. Usually we're operating for neurologic symptoms or other pathology. But there are patients that have markedly debilitating pain that's a failed non-operative treatment, where there's very clear cervical pathology as the pain generator, like a severe isolated disc herniation or spondylosis, severe facet arthritis that's relieved with injections and nerve blocks, instability of the cervical spine, even in the absence of neurologic findings and complaints, cervical kyphosis that's resulting in significant pain, or inability to maintain or achieve level gaze. Well, thank you for your time, and I hope you enjoy the rest of the course. We have an excellent faculty today.
Thank you, Jonathan, for that excellent talk. I just wanted to remind the audience that you can use the Slido tool and submit questions that way. So I'll be checking for any questions, and after the next talk, I can review any questions from the audience. Up next, we have Dr. Shah, and he's going to be talking about backache, evaluation of back and leg pain. So Dr. Shah, take it away.
Hi, thank you, Dr. Fischer. Good morning, everybody. I've got the privilege of talking to you guys about backache, or the evaluation of backache. Let's see. I have no financial disclosures, and today I wanted to kind of go over a couple different, areas for low back pain. So sources of low back pain, the initial evaluation, some of the imaging, which will be very similar to what we heard about the cervical spine as well, the risk assessment of different pathologies or sources of pain, as well as how we can use age as a way to evaluate or kind of differentiate different kinds of back pain as well. So structures that can cause low back pain, right? So any real structure can cause back pain if it's innervated, if it's capable of causing pain that's clinically identifiable, so has symptoms or symptomatology. If it's susceptible to injury or disease, like a herniated disc or a stretch of a ligament or a fracture of a bone. So common structures, mentioned are bone, joints, muscles, ligaments, nerves, discs, spinal pathologies, including cancerous tumors, etc. So I decided to try to make my presentation today about a case and kind of work through the case, individually and kind of go through each point. The first part, of course, is going through the history. So I generally go through the OPPQRST, which I'm sure some of you maybe learned through training. But that's going through the onset, provocation, palliation, quality, radiation, severity, timing, testing, etc., as well as going through the neuro symptoms and any red flags. So when did it start? What makes it worse? What makes it better? What does it feel like? Where does it radiate to? How bad is it? Is it constant? Does it come and go? What sort of testing or treatment has the patient already undergone? Any weakness, numbness, or tingling, any bowel or bladder issues, any weight loss, night sweats. A lot of those are indicative of cancerous pathology as well. And any past medical or surgical history, social histories, family histories, a review of systems. As Dr. Stieber has mentioned before, IV drug abuse, HIV, all of those things can really play a part in creating a differential for us. So in our case, we have a 42-year-old otherwise healthy male who presented with left radicular low back pain that began 8 weeks ago after he attempted to lift a heavy object. The pain worsens with sitting, car rides are terrible, and it's better with standing and changing positions. He describes the pain as stabbing, burning in quality, constant in nature, radiates along his lateral thigh to his big toe. He had x-rays, which were unremarkable. He had an MRI, which we'll go over, in a little bit. And his prior treatments included some of the many common things we use, which are Medrol dose pack. He had Mobic, gabapentin. He had some chiropractic care, did physical therapy. He's also noticing that when he walks, every now and then his foot will catch. He does also notice some numbness and tingling in the same distribution of his pain. But he denies a lot of the red flag symptoms that we had mentioned before. So bowel or bladder incontinence, fever, chills, night sweats, weight changes. His past medical history is pretty unremarkable other than the occasional beer. That's about it. In terms of medications, I wanted to touch base on, steroids and certain neuroleptics that we use as well. So oral steroid, this study kind of discusses PO, IM, IV steroids that have been compared with placebo, and they didn't really show any significant difference between the different options. This study was able to show improved function in the PO steroid group when compared to the placebo, but no real other significant difference in pain. I know anecdotally, despite the fact that there isn't any real major or good data to support PO steroids, we often do for lumbar radicular pain. It's certainly something I'll consider, in my clinic, as well as the possibility that it might offset the need for an epidural injection as well. I know a lot of other docs will use different kinds of formulations for it. Some will use the tapering method starting from 70 milligrams going down by 10 milligrams a day. Others might use 40 milligrams 5 times a day, or 40 milligrams twice a day for 5 days. Others might just use the basic Medrol dose pack that comes in the clinic, and that's the 24 milligrams starting and decreasing by 4 milligrams a day. So any of those formulations are often used. And there's no clear evidence or science behind it. So it turns into, what do you feel most comfortable with there? Membrane stabilizers such as gabapentin, pregabalin, topiramate, they've all been studied and demonstrate at least a minimal to moderate benefit for management of radicular low back pain. Unfortunately, side effects can often limit their use and whether patients can even tolerate the medication or not. All right, moving to physical examination. I typically examine the gait like we had talked about before. There's in the hip and spine presentation, there can be steppage gait, Trendelenburg gait. There's a whole wide variation of gaits that can be evaluated and kind of point us to a specific diagnosis. Inspecting the skin, really taking that shirt off and looking at their back or their leg, you'd be surprised how many times I've actually diagnosed a skin rash, a bruise, or a shingles infection. Spine alignment, examine the lumbar flexion, extension, side bending, rotation, as well as the oblique extensions. Palpating the spinous processes, the paraspinal muscles, the SI joint, the greater trochanter, and then performing a good neuro and musculoskeletal exam. And finally, finishing off with some of the provocative maneuvers that we'll go through. So here, for this patient, we had a very slight foot drop. He preferred standing as much as possible during the patient visit. His pain was exacerbated with lumbar flexion, with hip range of motion, hip range of motion was full and pain-free. Tenderness was over the lumbar spinous processes and paraspinal musculature. He did have subtle weakness of his ankle dorsiflexion and great toe extension. He did have some numbness over the dorsal aspect of his foot, and he did have a positive slump test and straight leg test, straight leg raise maneuver for those lower limb dural tension signs. So reflexes were normal. He didn't have any clonus. And it was negative for many of the other exams that we use for the hip as well, like FAB or FAD or Fortin fingers for the SI joint, et cetera. This is just a basic dermatomal map so that we can kind of identify or see if they follow one of these nerve roots. So the straight leg test with regard to lower limb dural tension signs, the straight leg raise maneuver has a sensitivity of 72 to 97%. And a specificity of 11 to 66%. The pain is generally caused by the stretch of the nerve by the disc herniation, which we can see on the image here. It increases the tension of the dura lining the outside of the nerve, which, as you could imagine, causes pain that patients experience from the back going down to the affected limb. The slump test is similar to the straight leg raise. However, we don't have as good data discussing the sensitivity or specificity of it, but it follows the same logic. The Eli test or femoral nerve stretch test has been found to be positive in 84 to 95% of patients with an upper lumbar disc herniation. So this can be a good test to use as well. And I know we went over some of these physical exam maneuvers in our first lecture. So for the SI joint, we have distraction, thigh thrust, compression, Faber, Ganslin. So all of these are SI joint tests. We generally want 3 out of 5 to really confirm or to validate a diagnosis of sacroiliac joint pain. So here there's a wide differential diagnosis here for spinal causes, non-spinal causes, especially for lumbar radicular pain that we have in our case. I won't go through all of these specifically for the sake of time, but these are things that you should keep in the back of your mind, while you're creating a differential for each patient. Some of them, as we had heard in our previous lecture, we want to risk stratify. So finding out what is the worst or the most, bad cases, followed by the more non-specific cases, as well as the cases that are not as dangerous, but they do have a specific cause. In general, the most common causes for radicular pain are disc herniation and stenosis. So we'll kind of focus a little more on those topics today. So prevalence, this kind of discusses just how intervertebral disc disease, facet joint pain, sacroiliac joint pain, all of these have a certain percentage to it, with the disc being the most common, but all of these can be symptomatic and cause back pain. Generally speaking, there's a prevalence of about 23% of the population will have low back pain greater than 1 month. And that's where I think our clinic and our expertise really comes into play. The average age, as I had mentioned, for these 3 topics are often 44 for the disc, 60 and 61 for the SI joint, facet joint. So generally younger patients, it's more of a disc pathology. Older patients, it's more of an arthritic or degenerative process. And I'm sure we kind of noticed that anecdotally as well. In imaging, I won't go too specifically on this. However, imaging can have a limited utility for non-specific low back pain, especially for those that have a duration of less than 4 to 6 weeks. They often don't require any extra imaging and do generally self-resolve with some conservative care like physical therapy and maybe some medication management. We can use plain radiographs. Often we'll use an AP and a lateral. We'll use a flexion extension to look at the stability of the spine, look for spondylolisthesis. And we can often use the oblique views just for grossly looking at the facet joints. They do show a lot of the arthritic changes on that view. Advanced imaging, we can look at MRIs and CTs. Often we'll use those for persistent pain despite conservative care for greater than 6 weeks. Neurologic deficits, infection, malignancy, any of those red flag symptoms that we had talked about before. I think one of the big things to talk about is education and counseling our patients regarding imaging, especially here in New York. I've noticed that a lot of patients will follow that mantra that if you can't see it, how do you know it's there? Or how do you know what the diagnosis is without seeing it? So they kind of want proof. But we do have to do our best to show that or explain to them that they may not have a real serious condition. Most of these things self-resolve. And a lot of times we'll find incidental findings that, it can play the psychological effect on you. And they might even warrant further unnecessary testing or interventions that weren't really necessary when we go down that rabbit hole. Images can become appropriate if your symptoms do continue though. And so a lot of times patients will take that as their, their olive branch, if you will. So imaging, this was basically the New England Journey study from 1994, essentially talked about 100 patients without any low back pain at all who underwent MRI. 36% had normal disc levels at discs at all levels. 52% had a bulge at least one level. 27% had a protrusion. 1% had an extrusion. 38% had an abnormality at greater than one level, 14% had annular fissures, 9% had facet arthropathy, and overall about 2/3 had at least some abnormality on the MRI, but didn't have any pain. The average age for this group was 42.3, I believe. So, basically a good study to show that patients will have findings on their MRI, but they'll be asymptomatic and they don't warrant further interventions. Here is the MRI that I talked about before for our case. So here the MRI, the spine reveals on the left a paracentral L4, L5 disc protrusion, causing some impingement of the left L5 nerve root. So we have a patient with left radicular low back pain, subtle weakness of the left ankle dorsiflexion and great toe extension, numbness of the dorsal foot, and a positive dural tension sign. So, what would be the proper diagnosis as well as the terminology for it, which we'll kind of go over here in a second. So the difference that I wanted to make here was radicular pain versus radiculopathy. Essentially, radicular pain is pain that moves from the trunk into the limb due to some sort of irritation to a spinal nerve or the DRG, whereas radiculopathy here has a motor, sensory, or reflex change that's associated with it. Does not always necessarily mean that it has pain, but quite often you will have pain with some combination of this as well. So again, in our case, we have a left L5 radiculopathy because of the weakness and the numbness, and it happens to coincide with the pain and the neurologic deficits as well. He has tried and failed, multiple more conservative options, and so we might offer something like an epidural injection here in this case. And before I jump into the treatment options here for it, I do want to go over a little bit of nomenclature. We do have some standardized terms. However, I know that that kind of varies depending on the radiologist. It depends on the university, all of those kinds of things. So here, if we look at the sagittal view, a normal disc is one where there's no disc material that extends beyond the periphery of the disc space. A disc bulge has a disc that extends beyond the edge of the vertebral body, usually less than 3 millimeters. Protrusion has a displaced disc material when the base of the herniation is larger than the apex. Extrusion is when the displaced disc material is larger than the base, and a sequestration is essentially when a chunk of the disc is broken off and is floating and wreaking havoc throughout the spine. Here's just a sagittal view of it as an axial view of it here as well. So you can see the diffuse disc bulge, the broad-based protrusion, and the extrusion and sequestration. Here is, we're just going to describe the type of herniation or the location of the herniation. Most common location is the central or paracentral, followed by the subarticular, which is a little more lateral, and then the lateral or the foraminal zone. And then finally, there's the extraforaminal or far lateral zone. Here we've got a L5S1 paracentral disc extrusion. And then here we've got a left L4, L5 foraminal extrusion. Here I just wanted to mention the biomechanics of the spine. A common question that I often get is patients will say, why do I feel so much pain when I'm sitting, but I can walk without any issues? Here, while we're sitting or leaning forward, the anterior aspects of the vertebral body come closer together and they force the nucleus pulposus posteriorly, which causes more pressure on the traversing nerve and increases their pain. Whereas when they stand up, we go into lumbar extension, which brings the posterior aspects of the surrounding vertebral bodies together and forces the nucleus pulposus anteriorly and kind of relieves pressure off of the traversing nerve roots. So natural history, often patients will ask, is this going to be like this forever? I can't live with this kind of pain forever. If it is, I'm just going to die. They can often get very dramatic here. So here, a lot of these studies will show that they will get improvement. I like to paint broad strokes and reassure the patients that even if we didn't do anything, eventually their body will start to heal and will get better. A lot of times I will say that my job here is to best decrease their pain while their body improves their function, as well as it takes care of the issue itself. Another question I commonly hear is the disc going to look like this forever? This was a study, a meta-analysis study that kind of looked at the disc herniation over across a year. I don't think this is the greatest study. However, it does belabor a point that I want to make, which is essentially that your body does have the ability to resorb that disc herniation partially or completely. And so there are cases and situations where their disc will change over time. It does kind of help push the idea of physical therapy, home exercise program, good ergonomics with the patient, showing them that if they do follow these things, it is possible for the disc to get better or repair itself to some extent. This just kind of goes further into that same study where it showed that about 2/3 of disc herniations will resorb. So this is an excellent study looking at lumbar transforaminal epidural steroid injections. I did want to touch base a little bit on the transforaminal epidural as well as some of the medications we use with it, just because I am an interventionalist and I think that might hit with a few of our of the people here today. So I won't go into too many of the details, but this study showed that there was a success rate of 50 to 90%, which was 2 to 3 times better than the placebo group. The number needed to treat was less than 3, and it's up to 70% of patients had 50 more percent benefit with it. 25 to 40% had relief for greater than 12 months. Here's just a picture of a epidural steroid injection here at the left L5 level. The needle is placed just under the pedicle, about 2/3 away from the frame here, into the frame. Here's the contrast flow for it as well. This is a retrospective study discussing kind of particulate versus non-particulate. A lot of interventionalists have talked about the use of what kind of use of medication they'll use, whether it's dexamethasone or a particulate like betamethasone or triamcinolone. And these studies, the studies that I've kind of discussed here all kind of mentioned that there was no real major difference or functional difference between particulate and non-particulate. This study kind of talks about the same thing. And the only mention here was that it did require more injections with a non-particulate versus a particulate, but both of them required between 1 and 2 injections. And so essentially, you're likely going to be doing 2 injections anyways, in which case, I don't think there's really a major difference between the two, but the risk factors associated with a particulate versus a non-particulate, may outweigh the benefit for it. Same concept here. I won't really go into too much detail here for the sake of time. And here, I'm sure you guys can guess, same kind of concept. There was no real difference between the two. And let's get to the net. And that's pretty much it. So basically, in summary, most of the patients here who present to us in clinic have non-specific low back pain. That's generally about 80-85%. And in most of those cases, their pain will resolve between 4 to 6 weeks with conservative care. Less than 10% will have a specific etiology for their low back pain. And that's where I think a lot of the interventionalists or specialists might fall into play. And that's things like disc herniations, lumbar radiculopathies, facet joint pain, SI joint pain, et cetera. And then less than 1% generally have that serious systemic etiology, which we definitely need to rule out or look into. A focused history and physical examination are sufficient for patients with low back pain, less than 4 to 6 weeks. And any patients with severe progressive neurologic symptoms should have immediate advanced imaging and urgent specialist referral. And finally, patients with persistent pain greater than 4 to 6 weeks who don't have benefit with conservative care may undergo advanced imaging or interventions. Thank you.
All right, great. Thank you, Dr. Shah, for that excellent talk. So we have Dr. Jegede, Dr. Stieber, and Dr. Shah here for some questions. If anyone has any questions, otherwise, to catch up on time, we can always move on to the next section. Based off of the Slido tool, I'm not seeing any questions there. So we can give everyone just another minute before moving on to the next section. And again, I just want to thank Dr. Jegede, Dr. Stieber, and Dr. Shah for their excellent talks. All right, great. So next section, we're going to move on to some additional topics that are very important for the treatment of spine patients. Dr. Paula Rackoff is going to be speaking about natural history, signs, and symptoms of rheumatic diseases.
Okay, can everybody hear me?
Yes, we can hear you. Thank you.
Okay, terrific. Okay. So continuing on Dr. Shah's non-operative approach, how do we figure out when someone is in pain and they don't need surgery? And this is often when the rheumatologist gets called in. And from the very beginning, when we see our patients, we try to differentiate what is inflammatory, as in rheumatoid arthritis, psoriatic arthritis, lupus, versus non-inflammatory. And the history is really the key. First, we obviously ask which joints are involved, whether it's more than one, whether it's symmetric, acute, subacute, chronic. Whether the neck or back is involved is often a key as to whether it's inflammatory or not, which I'll go into detail, and whether there's more tendinitis or enthesitis rather than actual specific joint swelling. And I always ask a complete review of symptoms from top to bottom: fevers, hair loss, sicca symptoms, oral and nasal sores, shortness of breath, chest pain, abdominal pain, rashes, photosensitivity, Raynaud's, and paresthesias. All these yes or no questions give us a hint as to whether there's an underlying connective tissue disease or inflammatory arthritis. And then before we even go to the physical exam, people often bring in their laboratory tests, and this is the big one that people always bring in. I have a positive ANA. So what is an ANA? It's an antibody against contents of the cell nucleus. And generally, the way I explain it to people is that we're not supposed to make antibodies against our own cells. You know, we make antibodies against strep, against mono, which patients clearly understand, but we're not supposed to make antibodies against our own cells. However, it's a very confusing blood test because, as you see, up to 20%, which is quite high, of normal individuals can have a low titer ANA, even at 1 to 160. High titers can even be found in 5% of healthy patients. However, everyone with lupus has a positive ANA, and that's where the confusion for patients set in, but not everyone with a positive ANA has lupus or another connective tissue disorder. However, if you have a negative ANA, it's very unlikely that you have a connective tissue disorder. However, there are a couple of exceptions, commonly Sjogren's syndrome. Some other causes of a positive ANA other than lupus are scleroderma, mixed connective tissue disease. All of those patients have a positive ANA. You can see a positive ANA in rheumatoid arthritis, Sjogren's syndrome, but people with Sjogren's syndromes can have Sjogren's antibodies and actually have a negative ANA. Here's a list of some other autoimmune disorders that have a positive ANA. And then after infections, it's not uncommon to see a positive ANA for a period of time, and that can last from a month to a couple of years, such as in hepatitis, EBV is the big one, and HIV. Inflammatory bowel disease patients often have a positive ANA, as do pulmonary fibrosis patients. The other, when would I order a positive ANA other than a patient coming in and handing me the positive ANA value? Certainly if someone has swollen joints, if they have any suspicion of Sjogren's or underlying muscle inflammation. Raynaud's is tricky. About 15% of women have Raynaud's and they're otherwise perfectly healthy. However, it is important if someone has severe Raynaud's, like that's pictured in the second slide, to assess them for any associated connective tissue disorder. If someone has facial rashes like this classic butterfly lupus rash, oral ulcers can be seen in many autoimmune disorders. When it's associated with genital ulcers, we also worry about Behçet's. We have a lot of patients at NYU with eye inflammation, and because our biologic drugs are very effective for this, the rheumatologists and the ophthalmologists work closely together. Anyone with severe sickle symptoms, it's not always Sjogren's. I mean, it could be sarcoid, it could be hepatitis, it could be thyroid disease, it could be age-related. Proximal muscle weakness. Anyone with severe leukopenia, especially when the hematologists have not found a source, are often referred to the rheumatologist. And obviously anyone with inflammation in the kidneys. What's the other blood test that's used to assess whether someone has an autoimmune disease or inflammatory arthritis? Well, obviously the rheumatoid factor. The rheumatoid factor itself is another antibody. It's an antibody to the Fc portion of IgG. Although it's mostly used for the diagnosis of rheumatoid arthritis, it can also be seen in other rheumatic diseases, actually specifically Sjogren's syndrome. And 4% of the healthy population can have a low positive rheumatoid factor, and it increases with age as far as in your 80s, 25% of patients can have a positive rheumatoid factor. To help us assess whether the rheumatoid factor is significant, we put it in the context of the patient's underlying diseases. So the most common is rheumatoid arthritis, Sjogren's, lupus, the other connective tissue diseases, but we commonly see it in Hep C. It can be a hint that someone has endocarditis or tuberculosis. Any kind of chronic infection can cause a positive rheumatoid factor. And then the pulmonary diseases listed below. I'll skip that. The more specific test for rheumatoid arthritis is the cyclic citrullinated peptide antibody. It's really strongly associated with rheumatoid arthritis, and we generally don't see it in other non-rheumatic diseases like the ones I mentioned before. So it can be helpful in differentiating rheumatoid arthritis from other kinds of arthritis. And it can be present for many years with or without a rheumatoid factor before the onset of clinical arthritis. And that's a not uncommon dilemma where someone comes in with joint pains or perfectly healthy, and for whatever reason, their PCP ordered a rheumatoid factor and CCP, whether we treat people with the laboratory test abnormality without clinical findings. And generally we don't, we just follow them with time, over time. So how do we differentiate inflammatory pain versus non-inflammatory pain? Well, inflammatory pain improves with use. So the classic like ankylosing spondylitis patient, for example, wakes up with back pain. And as the day goes on, the back pain improves. It worsens with rest or prolonged immobility. And when there's peripheral joint involvement, you obviously see synovitis. The non-inflammatory pain worsens with use. You know, the patient with a bad knee that goes for a run and the knee pain gets worse, improves with rest. You can have morning stiffness, but it doesn't last for that long, less than 20 minutes. People say it resolves by the time they're done with their shower. And the exam is very different, bony enlargement and crepitus rather than a big swollen joint. This is a classic example of inflammatory versus non-inflammatory arthritis of the hand. So the ring finger is a normal joint, and the third and second digits, you can just imagine that it's a doughy kind of feeling when you palpate it. You get decreased skin lines and loss of the defining dimples. Just another example, this is a classic rheumatoid arthritis, although psoriatic arthritis can look like that. It can mimic rheumatoid arthritis. But generally, MCP and PIP swelling it defines an inflammatory arthritis. You'll see the fifth digit has a Heberden's node. What I tell people is that we all get osteoarthritis. So just because you have an inflammatory arthritis doesn't spare you osteoarthritis. It's very important, as was mentioned in the other talks this morning, when someone has inflammatory arthritis to examine their neck. If there's any suspicion of a limited range of movement in a patient with inflammatory arthritis, I get cervical spine x-rays with flexion and extension to see whether there's any kind of abnormal spacing in flexion. And if someone's having surgery who has rheumatoid arthritis, we're obligated to get flexion and extension cervical spine films, if not an MRI. Here's another example of severe rheumatoid arthritis with nodules. We don't really see this too much anymore unless people have declined treatment or it's an immigrant coming from another country. The treatment of rheumatoid arthritis is so incredibly successful that we generally don't see rheumatoid nodules very frequently at all. So at first glance, this might look like rheumatoid arthritis with big swollen joints, but if you look closely, it's really the PIPs and DIPs that are involved. Inflammatory arthritis is actually much harder to treat than rheumatoid arthritis. So I tell people the good news is that you don't have rheumatoid arthritis. The bad news is that we actually have many drugs that can successfully treat rheumatoid arthritis, and we really don't for osteoarthritis. We can use colchicine, we can use anti-inflammatories, we can ask you guys to, or Hand Orthopedics, to inject the joints. Sometimes if someone really relies on their hands for their vocation, or they're in serious pain, we try low doses of the RA drugs like plaquenil, methotrexate, with really variable effects. But it's actually very hard to treat, and it's often hereditary. On X-rays, we see joint space narrowing without erosions. It's more common as we get older. It's more common in women. If you've injured a joint for whatever reason, a mechanical injury, you had an inflammatory arthritis in that joint, you've had a crystalline arthropathy, any of those, any injury to the joint, whether it's inflammation, mechanical, trauma, causes osteoarthritis in that joint. Where does osteoarthritis hit? It really can be anywhere, especially if there was an inflammatory arthritis let's say a patient had crystalline arthropathy of a shoulder, they'll also get osteoarthritis in that shoulder. But classically, we see DIPs, PIPs, and the CMC joints. The thumbs are the first place we actually get osteoarthritis, and I'm no surprise it's much more common with all our devices. Neck and low back. The lumbar spine is spared in rheumatoid arthritis. So whenever an RA patient complains with low back pain, I do explain to them that it's not from their rheumatoid arthritis. Hips and knees are classic, as is the first MTPs. It's not uncommon for someone to be convinced that they have gout. What they really have is osteoarthritis of the first MTP. The most helpful temporal patterns to differentiate between inflammatory, crystalline, and osteoarthritis. Certainly, if someone has acute pain within 24 hours, that's going to be trauma, a crystalline arthropathy, or infection. If it's migratory and only for a short period of time, you always have to rule out infection, especially tick-borne illnesses. This is the time when patients who have been who have had a tick bite during the summer will present in the fall with migratory joint pains or migratory inflammatory arthritis. We generally don't see acute rheumatic fever anymore, and we still see disseminated GC. If it's intermittent, always think about crystalline arthropathy or tick-borne illness. If you have one joint, presenting a patient with one joint, we're really obligated to aspirate that joint because we don't want to miss an infection. You can have a crystalline arthritis with infection. Patients often get frustrated that we need to aspirate their joints before we can inject it, but I have been burned once or twice by giving a patient an injection without first getting a culture, which takes 48 to 72 hours. Always send the fluid for a Lyme PCR. We generally don't see rheumatoid arthritis affecting one isolated joint, but you can see that with psoriatic arthritis and certainly reactive arthritis. When you aspirate the fluid, it's the 3 C's: crystal, culture, and cell count. And then blood tests for rheumatologic serologies, lime, uric acid, and sed rate. If it's one joint, I do send a rheumatoid factor and a CCP antibody, but I generally don't send an ANA. The synovial fluid analysis, if it's more than 50,000 white blood cells, it's most likely septic. However, reactive arthritis can look like it's septic between 20,000 and 50,000 white blood cells. For non-inflammatory osteoarthritis, we generally see a low cell count. This I just mentioned, actually. Symmetric polyarthritis, the classic one that I keep referring to is rheumatoid arthritis, but psoriatic arthritis can mimic rheumatoid arthritis, as can sarcoid and lupus. And then when someone has symmetric polyarthritis, they get the full array of rheumatologic serologies listed here, including hepatitis and x-rays of the affected joints. If someone has erosions on plain x-rays, it's certainly a hint that this has been going on for longer than the patient may have realized, and it precipitates an approach for more aggressive treatment. So just a quick review for rheumatoid arthritis, it affects about 1% of the population, more common in women. Besides family history and genetics, smoking is the most important risk factor. And if patients can't stop smoking, they respond less well to the medications offered. It's usually symmetric, but it can be asymmetric, and the cervical spine can be affected, but not the lower back. When we do have a positive rheumatoid factor or CCP antibody, cartilage destruction and bone erosions are more common. Patients with seronegative inflammatory arthritis generally have a better prognosis, and that's about 20% of people with RA have it not show up in their blood. Even though inflammatory osteoarthritis is harder to treat, we don't get the systemic manifestations. So we don't have to worry about interstitial lung disease, eye disease, vasculitis, kidney disease. Not surprisingly, the increased mortality from rheumatoid arthritis is actually due to cardiovascular disease. So we as rheumatologists always get a lipid profile on our patients, and we're much more likely to treat hypercholesterolemia in the inflammatory arthritis population than the internists, who often don't recognize that the RA itself is a risk factor for heart disease. So psoriatic arthritis, you probably see a fair amount of this because we have a pretty well-known psoriatic arthritis center at NYU. There are different ways that psoriatic arthritis can present. You can just have DIP involvement. You can have one joint. It can be polyarthritis, just looking like rheumatoid arthritis. Arthritis mutilans, again, we generally don't see this anymore unless it's a patient who has refused treatment or coming from a third world country because our treatments are so effective. Dactylitis, like this swollen third finger at the top slide, is basically a defining finding of psoriatic arthritis. Other than an infection, nothing else does this. Enthesitis, you can have psoriatic arthritis and just have a tendinopathy in one joint or diffusely, and axial disease, which I'll elaborate on. This is the dactylitis that I mentioned before, and if you look closely, you can see the DIP involvement and a sense that the patient has nail involvement also, and obviously psoriatic lesions. So what involves DIPs? There's really only 3 diseases. It's psoriatic arthritis, osteoarthritis, and very rarely you can have an isolated DIP joint from gout, although I don't really see that commonly. If you look closely at the nails, I mean, patients can have pitting of the nails, but anything more than 20 pits in 10 fingers in total is too many pits, and it's a tip-off that the patient has psoriasis and will have inflammatory psoriatic arthritis. The DIPs are spared in rheumatoid arthritis. Enthesitis, another defining feature. I always examine the Achilles tendons. When someone does have Achilles tendonitis and a history of back pain, I always get sacroiliac joints. Every time I give this lecture, I emphasize to the spine surgeons that no one should have surgery on their spine without getting a set of sacroiliac x-rays, because sacroiliitis is obviously treated very differently from mechanical spine disease. Axial involvement, the typical symptoms of inflammatory back pain, decreased spine mobility, obviously SI joint tenderness. Patients wake up with back pain. It lasts a long time. It can be associated with HLA-B27, but that's not necessary to have inflammatory back disease. 8 to 10% of Caucasians and 4 to 5% of African Americans are HLA-B27, and only 3 to 5% of that population will get inflammatory back disease. I keep a tape measure in my office to see the extent of the flexion ability in a patient, the Schober's test. I don't know if you can see here, the bottom is, you can see the sacroiliac joints clearly. On top, they're totally obliterated. We obviously like to get patients before the total obliteration. In the spine itself, you see squaring of the vertebral bodies with syndesmophytes and this classic Romanus lesion, which has a kind of shiny corner to it, another hint of inflammatory back disease. Let me just say one thing. It's very important to identify this because treatment is also incredibly effective and very satisfying for both the patient and the rheumatologist. So I mentioned gout a few times. We never see this anymore either. Incredibly horrible tophaceous gout. Generally, we see a swollen joint here or there, although it can look like an inflammatory arthritis with polyarthritis. A uric acid over than 6 is abnormal, although we don't just treat a uric acid. We only start people on uric acid lowering agents if they have recurrent gout or the uric acid is over 10 milligrams. Acute gout typically presents very, very rapid. Someone will tell you they can't even keep a sheet on their affected joint. In most cases, the first MTP is the first joint that gets involved, called podagra. It's strongly associated with heart disease, hypertension, and the metabolic syndrome. So it's we never think of it as just gout. Ideally, you want to aspirate the joint. This is someone with really turbid fluid, and see those monourate crystals under the microscope. The diagnostic rules for acute gout, if you want to do a point system, men are more affected. You get some points if you've had a previous attack. If it escalates within a day, if there's joint redness, if they have actual defined podagra, if they have associated heart disease and or hypertension, and if the uric acid is really above 6. So if people have 8 points on these individual factors, then 80% of the time they have gout, and you know whether you're able to aspirate a joint or not. But we really just try and aspirate a joint whenever possible to make the definitive diagnosis, because once you start in gout treatment, it's really a lifelong treatment. And we go through this a lot with patients. They think allopurinol is a PRN medicine, but it's really a permanent medicine. How do you treat acute gout? Generally, years ago, the first choice was really colchicine, but taking more than 2 or 3 tablets of colchicine in a day will definitely cause diarrhea, so people generally don't tolerate it that well. If we can use nonsteroidals, we do. Again, these people often have renal insufficiency or hypertension, so we have to be careful. If you can inject a joint, obviously first aspirate it to make sure it's not infected. If we can't use nonsteroidals and an injection doesn't work, a short course of prednisone will often work. There's another medicine not listed here for refractory chronic tophaceous gout called pegloticase. It's a polyethylene glycol conjugate of uricase that converts uric acid into a more soluble compound, easier to excrete. And for refractory cases, we have a biologic anakinra. I'm going to speed up just because we're running out of time. This is what gout can look like in other than in podagra. And I already mentioned the treatments. Allopurinol is the classic one. And for people with renal insufficiency, we use Uloric. So just to end, to take away from this, an ANA is positive in anywhere between 5 to 20% of patients. Send us those positive ANA patients and we'll help you interpret them. There are other reasons to have a positive rheumatoid factor other than rheumatoid arthritis. And for chronic gout, we want the uric acid less than 6 milligrams. Thank you.
All right, thank you, Dr. Rackoff. That was excellent. Next, we're going to have a talk on the evaluation and treatment of osteoporosis by Dr. Stephen Honig. So we'll be pulling up his slides. And again, if you have any questions or comments, please enter them into the Slido tool. And when we go to our panel discussion, we can review them.
Thank you, Dr. Fischer, and good morning to all of you. I'm going to talk about the evaluation and treatment of osteoporosis this morning, and I'm going to emphasize the spinal aspects of osteoporosis, this being a spine course. So if you look here, next slide, here we go. The woman on the left and the woman on the right are the same person, separated by decades. And this is showing you the body habitus on the left of a premenopausal woman and the effects of osteoporosis with aging. You can see the prominent dorsal kyphosis, and you can imagine that her ribs are now resting on her iliac crest. So when we think about osteoporosis, we probably want to start with a definition. Most of you are aware that there's a bone density definition, which is at or below 2.5 standard deviations below a normal peak value for young adults at age 30. It's an arbitrary number. I don't want to get into the details about that, but it doesn't really give us the information we need concerning fracture risk. In 2001, the NIH Consensus Conference came up with a clinical definition defining osteoporosis as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. So the importance of osteoporosis, of course, is that patients fracture, and we want to try to prevent those fractures. In the past few years, there's been a significant change in the approach to patients with osteoporosis, and we call this the changing paradigm. We have learned that the risk of subsequent osteoporotic fractures is particularly acute in the period of time closest to the incident fracture. We use the 2-year period of time frame from the fracture to indicate when a patient is at highest risk. The idea being that when you identify the highest risk period of time, intervening at that time would be more effective in preventing subsequent fractures. So very early intervention after a sentinel fracture with agents that have the most rapid effect on fracture reduction, and those are anabolic agents. So the approach now is often after a patient has a fracture, particularly a spinal fracture or a hip fracture, is to intervene very rapidly with an anabolic agent, and we'll go into that at the end of the talk. Who are these patients at the highest fracture risk? They are patients with a recent clinical or new radiographic vertebral fracture. When a patient has a fracture identified on X-ray or MRI or CT without clinical presentation, it's called a morphometric fracture. I'm going to go into the recurrent risk of fracture after a vertebral fracture in the next few slides, but certainly it's very high in the 1 and 2 year periods after a fracture. Who else is at risk for fracture? Patients with a history of multiple prior fractures. And our treatment goal is to improve skeletal strength and bone density rapidly to reduce the risk of both vertebral and non-vertebral fractures. We know patients with a very low bone mass T-score, less than 3, are at high long-term fracture risk, particularly if they have other factors, if they're frail, if they're falling, if there's a positive family history, if they're on medications that can affect bone strength, if they smoke, consume excessive alcohol, have low physical activity and poor nutrition. All of those factors working with a very low bone density put patients at high long-term fracture risk. Patients with low T-scores who are starting steroid therapy are at very high risk for fracture and should be treated aggressively. The goal of treatment is to improve the bone density and to prevent fracture risk. We know that if you improve the bone density and in fact able to get it into the osteopenic range, a score better than -2.5, you have a significant impact on long-term fracture risk. So to emphasize the idea of a fracture risk after a fracture, this is some Medicare data. And since we're talking about the spine, if you look here, if the index fracture is a vertebral fracture or a hip fracture, you can see that the incidence of another fracture of any type, any fragility fracture, in the 1 year period of time after that fracture is very high, particularly in the older patient population. So if a patient has a spinal fracture, they are going to have another fracture 15% of the time within the year following that fracture. Another study that emphasized this is a recent Swedish study that looked at 35,000 plus Swedish women with a mean age of 73.8 years. They were then looked for in terms of what's called an index fracture. They had a fracture. After that fracture, they were followed for 2 years. The index fractures included over 7,000 hip and 2,800 clinical fractures and over 25,000 non-hip, non-vertebral fractures. Interestingly, almost 40% of the women with hip and vertebral fractures had one or more prior fractures before the index fracture in this study. So if the patients had a fracture, they were then followed for 2 years. And you can see that the index fracture, if it was a clinical vertebral fracture, over a 2-year period of time, there was an 18% likelihood of another fracture and a 25% likelihood of a hip fracture. Osteoporosis treatment rates were low in patients with and without a previous fracture from 2001 until 2013. So these are patients that had a prior fracture, as I indicated above, many of them, and they had a low incidence of treatment, and then they were more likely to have a fracture. This slide shows you, if you look at the index fracture being a vertebral fracture, over the next 2 years, you see that almost 18% of these patients had a fracture, and 14% of patients had another fracture after a hip fracture in the 2-year period from that fracture. So what is the incidence of osteoporosis in the United States? Well, obviously it goes up with aging, and you see here the prevalence of osteoporosis. In the first decade of menopause, it's about 7%. And as patients get over the age of 80, it reaches 35%. There's always about 50% of the population with some degree of low bone density, the term osteopenia. And obviously, the more effective or the more impacted a patient is by osteopenia, in other words, those that are closer to osteoporosis are more likely to be at higher fracture risk than those with osteopenia who may have a near normal bone densities. So that really emphasizes that the fact that the term osteopenia is really not helpful. And we have substituted with the idea of defining fracture risk. What kinds of fractures increase with age? Well, here you see, you start to see issues with vertebral fractures and so on going up at about the time of menopause. So these are the fractures that we think are identified more closely with low bone density. Distal radius and ulnar fracture, certainly femur and hip fractures, which occur later in life than the vertebral fractures. Pelvic fractures mimic hip fractures. So these are all fractures that some component of age and bone loss interact with one another. If you look at the annual incidence of fracture by age, you can see that as patients get over the age of 75, the annual incidence of fracture is around 5%, contrasting that with about a 2% rate in patients who are 50 to 64. So age is clearly an important issue, and that corresponds certainly with the increased incidence of falling with age. So you have decreasing bone density, you have increasing age, frailty, and an increase in falls. Here, because this is a spine fracture conference, you can see what a spine fracture or vertebral fracture can do to the body habitus. You can see here on the X-ray a significant compression fracture. A vertebral compression fracture is the truest osteoporotic fracture because most vertebral fractures do not require trauma, unlike hip or other fracture sites, which are usually a consequence of some traumatic event. As I indicated before, morphometric fractures are just diagnosed when the vertebral heights is found to be reduced on radiographs. And about 20 or 25% of postmenopausal women will have at least one fracture. 1% of women at age 65 have a morphometric fracture, and about 3% of women from ages 75 to 80 have a new vertebral fracture each year. The lifetime risk of a vertebral fracture, a clinical fracture presenting with back pain at the age of 50 and onward, is about 18%. Vertebral fractures increase morbidity and mortality, and that is greatest for clinical fractures and patients with fractures that require hospitalization. And as we indicated earlier, people with a vertebral fracture are at 5 times the risk of sustaining a second compression fracture. So how do we diagnose a compression fracture? Well, a plain radiograph is the initial modality of choice. It's defined as a 20% loss of height or more from the anterior, middle, or posterior vertebral heights. Most occur in mid-thoracic or thoracolumbar spine. Vertebral compression fractures are described as either wedged, crushed, or biconcave. Biconcave are more common in the lumbar spine, wedge are more common in the thoracic spine, and we grade these as mild, moderate, or severe, depending upon the amount of loss of height. Here you see a wedge fracture and indicated on X-ray, a biconcave fracture, again indicated on X-ray, and a crush fracture, again indicated on X-ray. MRIs are useful when you suspect a fracture, but you cannot identify it definitively on an X-ray. An MRI can distinguish between acute and a healed fracture because edema is present. In non-acute fractures, you may see height loss, but no edema indicating healing of the fracture. And edema can be seen on T1 and T2 weighted sequences, most obvious on fat-suppressed short tau inversion recovery sequences, as I will show you. Here you see an MRI, and you see that on the weighted and the stir-weighted images, you see edema here and here, indicating acute compression fracture. A CT scan can help determine acute versus chronic to a certain extent by the sharpness of the fracture line, but is not as sensitive as an MRI. And if you don't have fracture lines or cleavage, it's not very helpful. It can be useful in planning a kyphoplasty or vertebroplasty. Here you see a CT scan. Here's a fracture line, and here you see another compression fracture on CT. When we see a patient with osteoporosis, I indicated that we pay less attention to the bone density finding as we do the fracture risk. So we try to estimate a patient's fracture risk. Here you see what the bone density tells us. A normal bone density is anything with a T-score from 0 to -1 or to the right, in other words, in plus category. Then you have this gray zone, which I indicated of osteopenia, which may be near normal or near osteoporosis. So this doesn't really help you just defining the term osteopenia. We look for more information. What is the actual T-score? And of course, anything below -2.5 is considered osteoporosis. This is how we derive the T-score. You take the value that you get from the bone density, and then you're able to plug in this formula and come up with a T-score. So you have the patient's bone density subtracted by the young adult mean, in this case, 1 gram per square centimeters, over one standard deviation, which would be 1/10 of a gram, and then you get your T-score. What does that indicate? Well, T-score basically tells you that for each T-score below normal, there's about a 10% loss of bone. So a -3 T-score would be indicating around 30 or 35% less bone than a normal bone density. We use FRAX, which is a computer-based tool to estimate the 10-year risk of a major fracture and a hip fracture. We also now adjust the FRAX with something called a trabecular bone score, which gives us information on the lumbar spine bone quality. FRAX has these 12 inputs, which include age, sex, height, weight, previous fracture, a history of parental hip fracture, current smoking, steroids, rheumatoid arthritis, whether a patient has secondary osteoporosis. In some cases, patients on an aromatase inhibitor for breast cancer treatment may be considered to have secondary issues for low bone density. In any event, you plug all these things into the computer and you get a 10-year risk of a fracture, and we can modify that as indicated here with the trabecular bone score. So this is an advanced trabecular bone score, basically gives us an idea of the bone microarchitecture. Here you see a patient with good lumbar spine bone microarchitecture. Here is one with poor microarchitecture. Even though they have the same bone mineral density report, their trabecular bone score is widely different. And here you see this is a normal, this is indicating degraded microarchitecture. You look for color changes here, and you come up with a computer-based measurement. So the more red you have, the worse your bone microarchitecture is. When we see a patient with osteoporosis, we have a medical workup that we initiate, which includes these kinds of tests. Depending upon how severe it is, we may do additional testing, including celiac testing, serum immunofixation, or protein electrophoresis. In men, certainly we look for testosterone, parathyroid hormone, IGF-1, again, particularly in younger men who present with osteoporosis. We do a bone density. You want to do a vertebral fracture assessment. Many of these are included in the DEXA, but we get x-rays of the lumbar and thoracic spine if a patient has had significant height loss, defined as either 1.5 or 2 inches of height loss from their peak height. The treatment obviously is to prevent fractures, and by improving the bone density, we're able to reduce the incidence of fractures and increase bone strength. Non-pharmacologic treatment includes calcium, vitamin, high impact Exercise can be very helpful. We have a variety of medications with varying degrees of efficacy in terms of fracture reduction. Here you see what these drugs are able to do to prevent vertebral fractures in patients at higher risk. These are the treatments. These are placebo, and you can see that the relative risk reduction of fracture goes from about 30 or 40% in hormone-based treatment all the way up to 80, 85% in our anabolic drugs. Again, emphasizing the efficacy of anabolic drugs, particularly for those patients at highest risk of fracture. So I thank you for your attention, and I hope this talk was of some use to you. Thank you.
Okay, thank you. So we're going to be loading up the next talk, Neurophysiology Overview with Dr. Lolis. Because of time, we're just going to have to skip some questions, and we'll take a short break, like a 2-minute break after this talk, so everyone can use the restroom if needed, and then we'll start up again, which I'll remind you in just a few moments. So Dr. Lolis, go ahead.
Hi, good morning, everyone. Thank you for having me speak today. I'm just going to give you a very brief overview of neurophysiology, a rather complicated subject. Let me just see if I can control. Okay. All right. So I personally have no disclosures, but I do have a significant other who does. So we're going to just jump in and start talking about electrodiagnostics. What does this term mean? It is a very broad term, and it encompasses sensory nerve conduction studies, motor nerve conduction studies, electromyography. You might also read it. It also discusses repetitive nerve stimulation and single fiber electromyography, which we're not going to discuss today because of the scope of what we're discussing. I'm going to jump right in and start off with sensory nerve conduction studies. So they are the most basic and the most uniformly performed aspect of electrodiagnostic testing. They essentially are a quantitative measure of all the sensory fibers in an action potential. They require lower stimulation thresholds than when you're getting your CMAPs, which you'll see in a later on slide, and they do require supramaximal stimulation in order to obtain. They are more susceptible to technical factors, which we'll discuss shortly. And when I'm performing these types of testing, I always do bilateral studies and try to compare to the ineffective side if applicable. So what you see on the bottom right is the schematic of what a normal or typical sensory nerve action potential, or SNAPs, as I like to call them. And what are we measuring? We're looking at our latency, which is this measurement over here, which essentially is a measurement of from your stimulation onset to the first negative deflection. We're looking at the peak latency, which is the midpoint of the first negative peak. Amplitude is a big measurement, and that is essentially the size of your response measured from the baseline to the negative peak. We're looking at our duration, which is the onset to the first baseline crossing over here. And we're looking at our conduction velocity, which we calculate by measuring the distance over the onset latency. So something to note is that the SNAPs will be normal in a lesion proximal to the dorsal root ganglia. So if you look at the picture on the bottom over here, schematic A is giving you a picture of a sensory nerve. So a sensory nerve is derived from the dorsal root ganglia, which you see over here. And the dorsal root ganglia are bipolar cells whose central processes form the sensory roots, and the distal processes continue on as the peripheral sensory fibers. What you see down here is a motor nerve. So a motor nerve is derived from the anterior horn cells. The anterior horn cells live in the ventral gray matter of the spinal cord. So what happens when you lesion your motor nerve, as you see right over here, is that you're disrupting the nerve from its neuron. And as a result, you're going to have degeneration of the motor fibers, and you're going to get abnormalities in not only your electromyography, but also in your CMAPs. Whereas the main reason why we sort of order these types of testings is really for neck pain, back pain, numbness, for radiculopathy. So that's why in a radiculopathy, because where the lesion is, which is proximal to the DRG, you will have a normal SNAP. Technical considerations include temperature. So Your SNAPs are more susceptible to temperature than your CMAPs. And again, that's probably because of their distal and they're farthest from the heart. We like to keep the ideal limb temperature anywhere between 33 to 34 degrees Celsius. I have heating lamps in the room. I have a little heating blow dryer as well, which I will keep on the limb while I'm doing the study to keep it at the optimal temperature. So if your temperature falls below these parameters, what you'll see is a falsely increased amplitude and a falsely decreased conduction velocity. And usually they say about dropping the temperature by 1 centigrade results in dropping the conduction velocity by 2 meters per second. Other technical factors to consider are age. So newborns will have 50% of the adult values. Between the ages, by the time you turn 1, you're going to have 75% of what we like to call the adult normative values are. And really, it's honestly between the age of 3 and 5 where you start to see the values of the typical adult population. As you get older, typically over the age of 60, you will also sometimes see decreases in the conduction velocity and the amplitude, and those are age-related changes. Other technical factors that you should really take a look at are the skin. Is patient wearing lotion? Because that can definitely affect how you're performing the study for multiple reasons. Number one, the electrodes can fall off. You want to also use a special type of conductive gel. When you're stimulating, if you're not getting the proper response, you want to make sure that your recording electrode hasn't fallen off the skin, for example. And you also want to take a look at where you put your ground, because the ground placement really should be between your two recordings, your stimulation and your recording site, in order to have a really clear baseline. So what are the routine sensory studies that I like to do? So in the lower extremity, I will always do a sural nerve and a superficial perineal nerve snap. If I have a patient that I suspect of a plexopathy, I'll add on the saphenous nerve. In the upper extremities, my routine protocol is studying the median nerve, the ulnar nerve, and the radial nerve. If I suspect an issue with the ulnar nerve, I will add on the dorsal ulnar nerve cutaneous snap, and that usually helps me distinguish between a lesion at the Guyon's canal or versus a lesion at the elbow. If I suspect that the patient has a lower trunk plexopathy, I will add on the medial antebrachial cutaneous nerve snap. And if I suspect an upper trunk plexopathy, I'll add on the lateral antebrachial cutaneous nerve snap. I'm going to move on to CMAPs. So CMAPs are compound muscle action potentials. And remember that those are a summation of all the underlying individual muscle fiber action potentials. So what you see on the bottom is 2 different CMAPs. One is from a site of distal stimulation, and the bottom one is a site of proximal stimulation. And again, these are the different measuring parameters that we're looking at. So our latency is going to be a measurement of the time that it takes from the stimulus to the neuromuscular junction, the delay over the neuromuscular junction to muscle polarization. Your amplitude is the distance from your baseline to your negative peak. Your area, as well, is this your area, your distal area over here, it also is a measurement of the baseline to the negative peak. Duration is a measurement of synchronicity, and your conduction velocity you calculate by looking at the distance between the proximal and the distal site of stimulation over the proximal latency subtracted by the distal latency. And it's just the speed of the fastest fibers. So again, it's just some routine studies in the upper extremity. In terms of CMAPs, I do the median nerve and I record it from the APB or abductor pollicis brevis. The ulnar nerve I record from the adductor digit and mini-me. I do multiple points of stimulation. So I stimulate at the wrist and at the antecubital fossa for the median nerve. For the ulnar nerve, I do at the wrist and then above and below the elbow. If I suspect that the patient has an ulnar neuropathy, I will also add on to that and do intricate inching throughout the ulnar groove as well. In the lower extremity, we look at the perineal nerve. We record from the extensor digitorum brevis, and again, stimulating at the fibular head and at the popliteal fossa. If for whatever reason the amplitudes of your CMAP when you're recording from the extensor digitorum brevis are small, and they can be small because that muscle can often be atrophied, and it doesn't mean that there is a problem within the nerve itself. I'll add on recording from the tibialis anterior muscle. The tibial nerve, I record from the abductor hallucis brevis. I stimulate the medial malleolus and then at the popliteal fossa. A word about stimulating it at the popliteal fossa: it is extremely painful for patients. There is a lot of tissue to conduct in order to find the nerve there. You really have to warn your patients about the discomfort that they're going to feel. What are the clinical applications of the first part of our testing, our nerve conduction studies? So in an axonal neuropathy, you're going to typically see decreasing amplitudes of your snaps and your CMAPs, and that's again because of axonal loss. And you will also have in these axonal neuropathies, typically, if your fast axons are preserved, you'll see the distal latencies and conduction velocities are normal. Now, if you switch thinking and over to demyelinating neuropathies, you will essentially see really slowing of the conduction velocity with an increase in the distal latency and the F waves, which I really haven't gone into for the purposes of this talk. You will also see what we discuss, what we call temporal dispersion and conduction block. So conduction block is defined as a decrease in your CMAP area by at least 50% between the distal and the proximal sites of stimulation. And that's what you see in this picture over here. So on the top over here, you're looking at temporal dispersion, but there's no conduction block. And when you do the measurements over here, the change in amplitude from distal to proximal stimulation is not over 50%. And the small drop in amplitude is, again, because of the wave, how it's dispersed in this direction. This schematic over here on the bottom, it's showing you conduction block with temporal dispersion. And you can see that the amplitude is over 50% dropped across multiple sites of stimulation. And this bottom figure over here, when you see temporal dispersion with conduction block, it is always a hallmark of an acquired demyelination. And by that, I mean your Guillain-Barrés, your CIDPs, and your those types of neuropathies. I'm going to move on to electromyography. So I like to view the electromyography as an extension of the neuro exam. When I have a patient come in for this type of testing, I always say that there are 3 questions to be answered. The first question is always the question of the referring physician, which is, it could be rule out carpal tunnel, rule out radiculopathy. The second question is the question that the patient has, because oftentimes patients have different questions and different concerns than the referring provider. And then the third question that I want to answer is the questions that come into my mind after having spoken to the patient, gotten the timeline of their symptoms, performed the nerve conduction study. So, and again, I tailor the electromyography based on those 3 things, those 3 questions. So timing of the nerve conduction study and your electromyographies. You don't necessarily have to delay them, although they do say optimally it should be between 2 and 3 weeks of the onset of your symptoms. The reason for that is that denervation does take time to develop. It is a lower motor neuron lesion, and you really do want to see signs of denervation in the forms of fibs and positive sharp waves, which I'll show you later on. The major take-home point, if you're referring someone for this study for an acute radiculopathy, you don't want to send the patient in too early, because that test can really be normal in the beginning. So in nerve conduction studies acutely, and if you're going to perform the testing acutely, you will actually see normal conduction. And then as time goes on with Wallerian degeneration, if the lesion is complete, you'll get no response. And obviously, if it's a partial lesion, you'll see changes in the amplitude of your CMAPs. And in your electromyography, acutely, you'll actually won't see any change, or you might see some loss, and that loss is because of weakness. Subacute, you'll see some changes in insertional activity, and subacute is just abnormal spontaneous activity, which I'll show you shortly. Elements of a successful electromyography. Number 1, get your patient's attention and trust. You are going to be putting needles in people. It is not fun. It is not comfortable. I always explain what I'm about to do in detail. I always explain the potential discomfort. I tell them what to do when they feel uncomfortable and what the plan will be to make them feel better. I tell them the goals of the test, why we're doing this. And I always practice a dry run of the targeted muscle. So I don't stick a needle into anybody without telling them which muscle I'm putting it in, how I want them to move the muscle after I put the needle in, and I practice that movement as well, because when you put a needle in someone, they really do get quite nervous and it's uncomfortable. I have my display on 3 different, the EMG usually has 3 different displays. You put it at 50 microvolts per division to look at rest activity. At 200 microvolts per division, you're actually looking at the actual motor unit, and you want the patient to give you mild to moderate activity. And at 1 millivolt, you're looking at the full interference pattern during the maximum voluntary contraction. These are the different types of needles that we use for electromyography. On the top is a concentric needle, on the bottom is a monopolar. So your concentric needle can usually typically goes anywhere from 24 to 26 gauge. It is a hollow needle, and the fine wire is down the center. There's a bevel tip, and as a result of this bevel tip over here, you'll see that the recording surface is oval. The electrode is actually referenced to the shaft of the needle, and that's important because it really helps cancel out the noise from the distant muscles. But as a result of this oval recording surface, you will have a smaller recording area. I do find that the concentric needles, albeit more expensive, do give you better quantitative values. Some of the pitfalls of using a concentric needle are that you can see some decreased amplitudes and shorter duration of the motor units. Now, the other side of this is the monopolar needle, which again is a Teflon needle. It's got a bare tip, and as a result of that, it does have a larger recording area. But because the active recording tip is referenced to a separate surface electrode, you will sometimes have a more noisy recording, which I find is sometimes a barrier to getting better quantitative values. I always say that concentric needles, in my opinion, are suited for better motor unit quantification, and that's the type of needle that I like to use. I also find that when you're using monopolar needles and you have the separate surface ground, it's a little bit more complex with the wires crossing each other and the patient movement, and you have to move that recording with each muscle that you're going to stick, and it's just a few more steps that I like to eliminate in my own practice. So, again, you want to put the needle where it's going to be the least amount of discomfort. You don't want to put it in the middle of a blood vessel. Large needles, I usually pierce at a perpendicular surface. Smaller needles, especially smaller muscles in the hand, especially, I kind of go out at a 30 to 45 degree angle. Again, the goals are to look at insertional activity, which I'll show you in a second, some spontaneous firing, and then you want to actually look at what the motor units are doing during voluntary contraction. So this is what needle insertion sounds like. If you can hear it. I hope everyone can hear this, but essentially what you're hearing in the beginning is a hissing, and that sound is the piercing of the subcutaneous fat. When you get into the muscle, you get a crisper, high-pitched sound, and that's how you know that you're in the muscle. You really want to hear this high-pitched motor unit. And if you hear something that sounds dull or distant, then you haven't gotten to the muscle yet. Here's another. Okay, so this next slide over here is showing you initial needle insertion. It's showing you insertional activity. So what is insertional activity? Insertional activity occurs because you are mechanically depolarizing the muscle fibers by putting the needle into it. So this is what a typical needle insertion should sound like. These are the different types of needle insertional activities that we're going to discuss. This is on top is just a simple motor unit potential. Fibrillation potentials, complex repetitive discharges or CRDs. I'm going to play for you a little bit more in the following slides. Those are signs of denervation. And then myotonic discharges, myokymia, are seen more in disorders of muscle. And lastly, end plate spikes are just when you've from frequent depolarization of the end plate, mini end plate potentials. So this is normal insertional activity. I'm going to play for you one more time. Let me see. This is what a complex repetitive discharge sounds like. So what is a CRD? A CRD is an action potential of a group of individual muscle fibers that are arising from several different neighboring motor units, and they're all firing spontaneously. So that's what you're hearing over here. This is what fibrillations and positive sharp waves sound on electromyography. Fibs and positive sharp fibrillation potentials, positive sharp waves are single muscle fibers that are firing spontaneously. And these muscle fibers fire spontaneously because they're actively being denervated, they're severed, or they're regenerating. Those are typically the reasons that you can see that. And this is just an overall what an abnormal insertional activity would sound like. So kind of a hodgepodge of fibs, positive sharp waves, the occasional fasciculation potential, which is that popcorn sound that comes out. Okay, we'll pop out again in a second. And again, abnormal insertional activity can actually be seen in signs of neurogenic issues to the nerve, such as, having a radiculopathy, having a median nerve neuropathy can be seen in end-stage myopathies, and it can also be seen in signs of in disorders of the motor ALS, for example. So what are our motor units? So, which is what the next step of this is. So motor unit potentials are the electrical responses that are recorded from the motor units within the muscle. They they consist of the motor fibers that are innervated by the single anterior horn cell, which I showed you earlier, that are located in the needle electrodes recording area. And we look at, what you'll see next is, we're looking at the amplitude, the turns, the rise time, and the duration. So these motor unit potentials really depend on, again, the number of motor units in the muscle, the diameter of the muscle, and the synchronicity of these muscle fibers. And what I mean by synchronicity is the arrangement of these fibers within the motor unit themselves. This is another schematic of what voluntary motor unit potentials look at. Picture A just shows you what a normal motor unit would look like. Picture B, as you can see over here with the increased number of terms, is what a regenerating motor unit should look like. Picture C is what a neurogenic motor unit would look like. So you can see the duration is long, the amplitude is much larger. And picture D is what we typically see in myopathy. Really small amplitudes, really small duration. Here's an example of myopathy. So again, you see small units with what we call a pattern of early recruitment, meaning that because the muscle itself is diseased, when you put the needle in, you'll get this full firing, full burst and full firing of this pattern again, because the muscle is there, it's just diseased. This is what a neurogenic motor unit sounds like. And again, they're increased in their amplitude, and there's a long duration between the motor units. So we're going to just lastly briefly touch about recruitment patterns. So what is our recruitment pattern? It really refers to the relationship between the motor units that are activated and the firing rates that are activated by these motor units relative to the force of muscle contraction. And we can look at recruitment essentially by looking at what the ratio, which is looking at the rate of firing of a single unit with the total motor units that are firing, and that, or looking at the recruitment frequency. So a recruitment frequency normal should be between 7 and 10 hertz. And what that is the rate of firing of the first motor unit compared to when the second motor unit is generated. So reduced recruitment, as I mentioned before, happens really in neuropathic processes from a loss of a unit or a block. You get fewer motor units with increasing forces of contraction. And early recruitment we define as an increased number of motor units relative to the force of contraction. So what that means is that you get a large number of these motor units firing with minimal patient effort. And again, that's because the muscle itself is diseased. This is normal recruitment. This is early recruitment. Again, this is what you typically see in these myopathic type processes. And I like to end the talk just briefly about radiculopathy, which is really the most common reason for referrals that I see in my EMG lab. What I do when I do electromyography for radiculopathies, I'm really looking to identify a myotomal pattern of abnormalities. So I'm looking for denervation, renervation, and at least two muscles that are innervated by the same nerve root and different peripheral muscles. So what I mean by that is when I'm doing a routine screen of the upper extremity, my typical routine screens are, I cover muscles C5 to T1, and these are the basic muscles that I look at: the deltoid, the biceps, the triceps, the EDC, and the FDI. So I usually get a sense of what is going on with those muscles. And then if I suspect, for example, that the patient has a C6 radiculopathy, after seeing what findings I see in the biceps, I will then probably add on a brachioradialis, for example. And the same kind of goes in with the lower extremity. I always add on a paraspinal if I am looking to rule out an acute radiculopathy as well. And again, these are just the muscles that I'll typically add on to rule out a specific dysfunction at each nerve root. Thank you.
All right, great. Thank you so much for that. So there were some questions from the audience in regards to the rheumatic diseases, and I tried to reply to those specific questions with Dr. Rackoff's email. I apologize that she left prior to being able to go over those questions. In the interest of time, we're just going to keep marching forwards, and we'll go on to our next section, non-operative treatment and interventional pain management. So we're very lucky to have an excellent talk on the use of modern pain theory in the management of patients with lumbar pain with Hiroshi Kiyota. Go ahead and take it away. You may just need to unmute yourself.
Yeah, can you hear me now?
Perfect. Awesome.
Hi,
thank you.
Thank you for Dr. Fischer. Hi, my name is Hiroshi, and thank you for joining me for this lecture. I'm presenting the use of modern pain theory in the management of patients with low back pain. And I have no disclosure. And these are the learning objectives. So let's start this presentation by looking at the most recent definition of pain. International Association of Study of Pain published the revised pain definition in 2020. And this is a new definition. And they define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It has many nuances which may puzzle some of you, isn't it? But this definition is a truly reflective of years of pain research and the new discoveries. So what needs to be emphasized here is that the pain is both sensory and emotional experience, and it is associated with actual or potential tissue damage. So this new definition makes it clear that the pain is no longer considered as a solely sensory experience, and the pain may be experienced without actual tissue damage. This new definition also came with additional notes to supplement the definition. The first four notes are particularly relevant to this presentation, and they are: the pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in the sensory neurons. Through their life experiences, individuals learn the concept of pain. So now let's take a look at the theories that inform the definition. So this slide shows the general development of pain theories from Descartes' philosophy to the most recent pain theories called neuromatrix theory. We focus on the neuromatrix theory in this presentation, and that the pain definition is largely based on this theory and associated research findings. The neuromatrix theory was proposed by renowned psychologist Dr. Ronald Melzerk after having carefully studied the phantom limb pain syndrome. This condition had puzzled many pain researchers for many decades because the existing pain theories at that time required the peripheral nociceptive inputs for pain perception. Well, obviously, there is no peripheral nociceptive inputs in this phantom limb pain syndrome, yet the patient suffered from the relenting pain. So Dr. Melzik proposed that the brain plays a central role in receiving nociceptive stimuli, appraising it, and producing a number of responses, and one of which includes a pain perception. Dr. Melzik also gave a new meaning to the pain. So before he proposed the neurometric theory, pain was mostly regarded as a sense, just like a pleasure, temperature, smell, and so on. And his quote here paints much different pictures about pain. It says, when we respond to pain, we respond to an experience that has a sensory qualities, effect, and a meaning as a dangerous or potentially dangerous event to the body. So he viewed the pain as danger signal to which wide ranges of psychological and physiological responses are initiated to protect the body and maintain homeostasis. Well, there isn't enough time to review the neurometric theory in detail within this presentation, because that's a lot. So my goal is to discuss the key elements of the theory in a sufficient detail to inform the rest of this presentation. Okay, we start from the body self matrix, as you see in the slide. He postulated that since the patient with a phantom limb pain syndrome feel their amputated limbs so real, there must be a perceptual representation of the body in the brain. He called it body self. The body self neuromatrix is a wide network of neurons, and it comprises mainly of three networks: the cognitive, sensory, and affective networks. In response to the injury or the event that threatens the body homeostasis, the neuromatrix received all the inputs from all networks, and I praise them to ask this simple question: how dangerous is it? So depending on assessment of the danger, a number of responses or outputs, as he called it, may be produced. The pain perception is one of the outputs from the neuromatrix. Other outputs include action program and a stress regulation system response. The outputs in turn affect the inputs, and this cyclical process eventually leads to the formation of what Dr. Melzer called neurosignature within the neuromatrix. Now, all the input signals are processed through the neurosignatures, and it produces a predictable output or pattern of responses. So what is the neuromatrix then? So this systematic review by Abkarian et al. And found that 6 brain regions are consistently defined across studies that they reviewed. Also, many other brain regions were also observed during the pain experiments, and it all depends on how the experiments conducted and the type of pain that's studied. However, overall, this review provided robust evidence on the brain's involvement in the brain experience. This review also identified connectivity or the network of brain regions activated for distinct inputs. Anterior cingulate cortex and the prefrontal cortex were highly involved in cognitive inputs, such as the memories and emotional response. So they were called cognitive network. Similarly, the sensory network is comprised of the thalamus, primary and secondary somatosensory cortex. Affective network includes thalamus, insular cortex, and anterior cingulate cortex. So here we have the body self neuromatrix for the pain experience. So when we talk about pain management based on the neurometric theory, we really are talking about managing all these outputs that may be produced in response to nociceptive or non-nociceptive inputs. And the traditional pain management strategy has placed a heavy emphasis on a sensory experience of pain, but more recent research have reported that the significant cortical reorganization was seen in affective and cognitive networks in patients with persistent pain compared to people who recover from low back pain. The research also has shown that the sensory network remained relatively stable over time, regardless of pain chronicity. So the importance of a cognitive and affective aspect of pain cannot be overemphasized. So pain appraisal is a cognitive function, but highly influenced by emotional states. The cortical structures shown in this slide are consistently identified in patients with pain-related emotional and psychological distress, such as pain-related fear, pain catastrophizing, grief, depression, and anxiety. Also, the cognitive impairments such as impaired executive functions and impaired short and long-term memory have been shown in patients with chronic pain. These brain regions are also highly involved in the learning process. Now, chronic pain theories such as the fear avoidance theory do suggest that the classical conditioning, which is a form of associative learning, is involved in the development of pain-related disabilities in patients with chronic pain. Well, if you recall, that one of the additional notes that accompany the pain definition states that through their life experience, individuals learn the concept of pain. So the key concept here is that the learning is a powerful process for pain perception, and a maladaptive learning is likely involved in the persistence of pain-related disabilities. So pain education is a new educational intervention technique based on the modern pain theory. Pain education is known in several different names or brands, if you will. For example, therapeutic neuroscience education, explain pain, pain neuroscience education, and so on. But regardless of which schools you go to, the core objective of pain education is always to shift one's conceptualization of pain from that of a marker of a tissue damage or disease to that of a marker of a perceived need to protect the body tissue. The primary aim of pain education intervention is to address pain-related psychological distress or maladaptive belief by providing more evidence-informed neurobiology of pain based on the modern pain theory. If patients can learn to fear or catastrophize pain, then they can also learn to confront with pain and adapt active coping strategy. Now, ultimately, that is a goal of a pain education. So here are some of the key concepts in the pain education, and they are pretty much in line with the pain definition and accompanying additional notes as we reviewed already. Clinically, though, a challenge in the pain education is how we deliver the education as meaningful to each individual patient. Ultimately, the pain education is aimed to bring about behavioral changes to facilitate active coping. So the knowledge is one thing, but the knowledge translation is another thing. Education systems that are introduced in the beginning all have a different knowledge translation method. Regardless of the knowledge translation method they use, one-size-fits-for-all approach probably wouldn't work. Most importantly, the healthcare providers must have a thorough knowledge and understanding of the modern pain theory so that the education can be tailor-made for each individual patient. At the end of the day, there's no better education than actually using the patient's own pain-related experience and turning into the educational opportunities for them. So what about the evidence on the pain education for patients with low back pain? So this is the most recent systematic reviews, and it has demonstrated that the pain education has clinically meaningful effect on a kinesiophobia in short term and a pain catastrophizing in midterm. But the pain education alone was found to have no clinically meaningful effect on the pain intensity and disability. And clinically meaningful effect on the pain and disability was reported only in studies where the pain education was combined with exercise-based interventions. Now, this result may substantiate what I have discussed in the previous slide, that knowledge alone may not bring about meaningful behavioral changes. When the pain education is combined with exercise or the movements, patients may get an opportunity to apply the knowledge into action, which I believe produce more meaningful behavioral changes, and it will probably lead to the better outcomes. Then the question is, can pain education be combined with any exercise? Well, there's no definite answer to the questions thus far, at least from the evidentiary point of view. Nijis and his colleagues at the physical therapy space in Belgium, and they are international experts in chronic pain management. They propose a cognition-targeted exercise that combines with pain education. So they propose a stepwise program starting from pain education, and they stress the importance of pain education to prepare patients for exercise program. They also stress that the concept of exercise needs to be reconceptualized. Exercise is is an active tissue loading or loading to the physiological system. The stress associated with exercise need to be reconceptualized as an essential part of the human physiology to maintain health, rather than as something that needs to be avoided at all costs. So patient must understand that it is that stress that helps them achieve their goals. So once the first phase is completed, the next phase is a cognition-targeted exercise. They propose the graded activity and or graded exposure because they are both based on the cognitive behavioral principle. And the goal of the second phase is to alter the pain-related memories about the movements that they're so fearful of. For example, if a patient avoids bending forward out of the fear of low back pain, you can take them through from safe positions such as a supine, from sitting, eventually to standing. So the goal of this program is to restore the healthy and normal movement patterns. And in summary, I'd like to present a quote from the renowned pain researcher, Dr. Mosey. And he says, pain is a biopsychosocial experience and requires biopsychosocial approach to treat the pain problem. Now, traditional rehabilitative approach places heavy emphasis on the biomechanical or biomedical principles, very little regards to psychosocial factors. And the pain neuroscience research have shown that the pain isn't a biopsychosocial experience. Also, the robust research evidence has shown us that the more chronic the pain is, more psychological pain becomes. So I think it's a time for us to rethink about a pain in accordance with modern pain theory and research evidence. And thank you.
Thank you very much. That was very interesting. Just a reminder to use the app for asking questions, and please try to ask your questions as soon as possible so that we can review them. If we're unable to review them, I will be happy to send the question to the presenter by email or give you the presenter's email. Next up, we have Dr. Stephen Calvino. He's going to go over the medical management of spinal disorders.
Good morning. Thank you, Dr. Fischer. We'll get started. Relevant disclosures to this talk. This is the current climate, more pre-pandemic. As you can see, many articles from one particular periodical that discussed the issues surrounding opioid abuse and misuse. The issue here is that the problem was on both sides of the prescription pad. So we have to ask ourselves, can we continue to prescribe opioid medications for neck and back pain? I think the answer is yes. But how do we do so safely and with the best interest of our patients at heart? I'm going to try to address that question. And how do we incorporate other alternate therapies into the mix so that we can also better treat our patients and not overly rely on one particular class of medication? So it got a little worse from there. In 2020, the CDC's Health Alert Network identified 81,230 deaths for the year, starting June 2019 and ending May 2020. After declining about 4.1% from 2017 to 2018, the number of overdose deaths increased actually 18.2% from that 12-month period ending in June 2019. So some of it was attributed to the illicit fentanyl trade, but I think that there is more to it than that. Locally, COVID-19 and the pandemic had an impact on overdose deaths locally. In fact, in just 5 months, Queens noted a 56% increase in overdose deaths compared to 2019. And this can have many reasons as to why it happened. Perhaps access to physicians' addiction treatment centers were limited during that time. People's work and livelihood were strongly impacted by the pandemic. Worsening of underlying psychological illnesses and diseases due to isolation and other social stigmas. And of course, you can never rule out boredom for some individuals' risky behavior at times. So today we're focused on pharmacologic management. I will try to touch on some major classes of therapies and try to focus a little bit on how and if we should incorporate opioid analgesics into our treatment algorithm. Pain is inevitable, suffering is optional. We're all going to experience neck and back pain. The vast majority of us are, at least to some degree. This does recognize in this ancient Buddhist proverb, as was noted earlier in the there is an emotional component, and that takes you into that IASP definition, which was already put to you in the previous lecture. So the one point I'd like to make is that since there is an emotional experience to pain, we have to be aware of that. And if we identify that, we may not rely on opioid analgesics. We may consider initiating alternate therapy, adjunctive therapy, such as an antidepressant or something else, so that we don't rely on that opioid, because opioids can have unique effects as anxiolytics as well, which we don't want to use them as such. We have to understand the type of pain we're treating, nociceptive versus neuropathic. Nociceptive pain tends to be more responsive to opioids, neuropathic pain less so. But we also do have to identify those patients that have mixed pain presentations. So it's important to really familiarize yourself with the identification of these different types of pain. Many societies, medical societies, will put forth the multimodal pain management theory. And this is just combining different medications of different classes at lower doses, hopefully achieving better results, but also limiting adverse effects by utilizing lower dosages. And you can target these medications centrally, but also peripherally as well. You can additionally combine that with all the physical therapy modalities, cognitive therapies, intervention, even surgeries to enhance that multimodal approach. As prescribers for medications, we're always trying to balance function, analgesia, safety, tolerability versus the side effects, and of course, the unwanted issues that occur like abuse and diversion. And I always explain to patients that we're always trying to strike a balance and that we may not be able to escalate certain medications because of that. So let's look at certain classes. Non-steroidal anti-inflammatory medications, N-acetaminophen, typically are both recommended in the treatment of acute, subacute, and chronic back pain treatment protocols, as they tend to be safe, have limited adverse effects, as long as there are clinicians that are monitoring these patients and doing so on a regular follow-up basis. While NSAIDs are effective in reducing both pain and disability in patients with pain of spinal origin, that effect can be small and limited of placebo, but certainly can play a role, especially, I think, more in the acute setting. In a 2016 Cochrane review, unfortunately, acetaminophen really didn't provide any significant benefit over placebo for the treatment of acute low back pain. And of course, even though it is these are recommended for subacute, chronic, and even acute treatment, the data for subacute and chronic is relatively limited. There is some evidence to support the combination of nonsteroidals with acetaminophen in the acute post-op period, but that doesn't necessarily relate to this talk today, but that also just speaks to the multimodal analgesic protocol. Keep in mind that certain medications that were not necessarily classified or hit the market as a COX-2 selective medication. There are certain medications that you can utilize that do have more COX-2 selectivity, so you can limit some of the gastric adverse effects of these medications. We do need to be familiar with some of the adverse effects associated with these medications. NSAIDs can have significant adverse effects, gastrointestinal effects, as we are all well aware of, renal, hepatic, hematologic, and even cardiac. So we have to use them with caution. We have to monitor our patients and educate our patients about these adverse effects. There was a stepwise fashion approach from the FDA, started about 2011. The warnings got more and more significant. So most recently, as of 2015, they commented that NSAIDs can increase the risk of heart attack or stroke in patients with or without heart disease or risk factors for heart disease. They've gone further to say that it can occur even within the first week or two of use of these medications. So it's important to keep in mind these patients should be monitored. And it's not just limited to certain classes of NSAIDs, like it's not just the COX-2 selective inhibitors that are known to cause these cardiovascular risks. It can be any of the anti-inflammatories. This is really a class effect, and this study just brings that out. Skeletal muscle relaxants. There is evidence for short-term, but no significant evidence for the long-term benefit. I always recommend considering the individual mechanism of the agent. Medications like tizanidine, given its central alpha-2 agonist effects, can potentiate neuropathic pain relief. Even medications like baclofen with its GABA agonist activity. We also must be aware of potential adverse effects. These medications can be very sedating as a class, so combining them with other sedating medications can cause complications, but individually medications like cyclobenzaprine can have a tricyclic antidepressant-like effect, so it can cause some QT prolongation and also potentially cause some anticholinergic effects that are unwanted as well. The one reason why we don't often recommend the combination of benzodiazepine as a muscle relaxant with opioids is this slide, really, because you could see that over time, benzos alone don't often result in excess adverse effects or overdose issues. But as soon as you combine them with the increasing rates of opioid prescribing, you could see that translation into overdose does become more significant. So please do not try not to combine benzodiazepines with opioids. This slide and the next slide are basically summary slides of the different classes of medications. Given time constraints, I can't get into everything in such detail, but hopefully you can review this at your leisure. I will touch on some of the I'd just like to at least comment here about the anticonvulsants, gabapentin, pregabalin. These are likely more first line for neuropathic pain. The issue is that they take time to have some effect. They could take several days to a week to have some benefit. They also need to be started at lower doses and titrated with close monitoring of patients. And they're not without side effects, and they're also not without the potential for misuse and abuse. But I think that they may be playing a bigger role, again, as first-line agents for neuropathic pain conditions. How did we get into the situation with the opioid prescribing? This particular one-paragraph theoretical reported as a study where they reviewed over 11,000 charts came out in about 1980, and it has been cited over 1,000 times, probably even more since 2017 when this was noted. It was used as evidence for people and prescribers to give opioid medications for pain. Soon after that, in the early 90s, JCO brought more recognition to pain being monitored as the fifth vital sign. And of course, as we know, Purdue Pharma brought OxyContin to the market in 1996. And you could see just from 1996 up until the early 2000s, how that prescribing escalated. And we still remain relatively high, even though we're recognizing the issues with opioids now. As prescribers, we have cut back to a degree and limited patients getting these medications. But what that has caused is now patients turning to illicit substances. So opioid-related deaths due to heroin and other illicit substances, including the illicit fentanyl trade, have certainly increased over the recent years. What is the evidence for the use of opioid analgesics? Well, the evidence is scant and inclusive, not because there haven't been minimal studies. It's because that the studies that were conducted were of short duration, typically 3 to 4 weeks up to about 4 months. So there are also issues with dropout rates because of the adverse effects associated with these medications. But overall, there can be evidence for short-term benefit, especially with patient-reported improvement in pain. The evidence for function is also limited, but that's why it brings me to my next slide. So we talk about the short duration of these studies. This particular study, which was published in 2018 in JAMA, actually patients out over 1 year, and they actually compared opioid versus non-opioid medications. There are about 240 patients that enrolled in this study, the vast majority with back pain, actually. So it is applicable to this talk today. And what they found were that treatment with opioids was not necessarily superior to the treatment with non-opioid medications for improving pain-related function for 12 months. That's significant because we more and more look at function to evaluate our outcomes with using medications rather than solely relying on patient report, which is so subjective. If you're going To prescribe opioid pain medications, we all need to be familiar with the CDC guidelines. On the next slide, and this is despite the fact that it's really targeted towards primary care clinicians, the federal government may look at our individual practices, whether specialists or not, and use that as evidence as to monitor what we're prescribing. So what they try to point out is non-pharmacologic, non-opioid therapies preferred always for pain and function. What's always important is to establish realistic treatment goals for patients. Medications are not the be-all and end-all. Patients need to take an active role in their treatment, but we need to educate them about that. Hopefully, medications can help patients become more active participants in their treatment. We must always discuss the risk benefits of opioids before and during treatment, initiate with immediate release opioids, use the lowest doses as much as possible. As providers, we must assess our patients and use precautions when we're about 50 morphine milligram equivalents and avoid or justify once you're hit 90 morphine milligram equivalents, no more than 3 days and such. And note that not all medications are created equal, so it doesn't take much for oxycodone to reach that 50 morphine milligram equivalents daily. These are the adverse effects associated with opioids that you should discuss with your patients: sedation, dizziness. Sedation usually precedes the respiratory depressant effects. Constipation, we always should discuss with our patients about these effects and how to manage that if we start opioids. But there are also long-term effects like endocrine dysfunction, immune system dysfunction. So often we have to consider that the long-term risk may outweigh the potential benefits for the use of opioids. Always be familiarized with potential medical issues that could place patients at a higher risk for oversedation, respiratory depression, age, anything that relates to sleep apnea, such as snoring, morbid obesity can play factors, types of surgery, respiratory issues, psychiatric history, as well as previous use disorders with substances or opioids. How can we reduce misuse and abuse? Basically using risk assessment tools. Probably the easiest one, as seen here, is the opioid risk tool, which is easy to implement and utilize. Urine drug screening, reviewing the prescription drug monitoring program information, educating ourselves and our patients, and rotating opioids. If you're escalating opioids to a degree, you may consider switching to a different one. The patient's body is not used to that. They may have a response to a lower dose of a different medication. In summary, I would say chronic opioid therapy is not necessarily indicated for chronic low back pain, but we can use it acutely in certain instances. Try to minimize dose escalations, keeping pill counts low and duration of treatment short, just to get these patients to become more active participants in their treatment. If you're ever going to take someone off of a opioid pain medication, as prescribers, we're not detoxing. So we're not a detox facility. You're going to wean or taper these patients. That's how you would document that in your medical chart. Become familiar with local detox facilities in case that becomes an issue. Make opioid agreements. These are not legally binding documents, but they can help to justify your justification for your treatment plans. Again, combining NSAIDs and acetaminophen in the short term with other adjunctive medications will be beneficial, and utilizing that multimodal analgesic approach is always recommended. And I thank you for your time.
Thank you. That was great. So up next, we have Dr. Fahad Khan talking about medical marijuana for spine problems. So we can move on. And if we have time at the end of this section, we'll review some questions. Otherwise, we'll have to move on to the next section.
So about 2 years ago, I had an 80-year-old female come to see me in the pain clinic, and she had neuropathic leg pain secondary to spine issues. She was on increasing doses of opioids, and she was starting to get side effects from them. She was referred to me for an epidural steroid injection. Unfortunately, at that time, she was on anticoagulation, so she could not have an injection for the next 6 months. She came to the clinic and she asked me, "Hey, doc, what do you know about medical marijuana?" I started to think back to all my lectures in medical school and 4 years of anesthesiology residency and 12 months of pain fellowship. And I realized that I had basically 0 lectures on that subject. So I had to respectfully, humbly tell her that, I just don't know. She came back to me 6 months after that, came back for the epidural. She was off the anticoagulation. She was now on medical marijuana and had gotten off of her opioids. So medical marijuana had not only helped her pain, but it had also allowed her to regain control of her life by getting off the opioids. Medical marijuana can help restore power, autonomy, and control back for patients who are suffering from pain. I want to thank the course directors for inviting me. Thank Dr. Fischer as well for the introduction, the digital team and the NYU CME team. Everyone does such a great job behind the scenes. And finally, I want to thank you out there. It's hard enough to pay attention to lectures when we're all in person, when we're actually gathering. And on some level, I think it's actually even harder to pay attention virtually. So thank you. My background, my academic background, I went to school at Johns Hopkins for undergrad. I did my master's in public health there before coming up to NYU for medical school. Then I did a residency in anesthesiology. I did an interventional pain fellowship here as well. I went back, got another master's in clinical research after that. Some of my non-traditional background, I have a license in medical acupuncture from Harvard Medical School. I have a 500-hour yoga teacher meditation certification from an institution called Kripalu, which is a former ashram up in the Berkshire Mountains. I've studied sound meditation with an ethnomusicologist, and most recently during the pandemic, I did a 1-year-long therapy training program for psychedelic therapies out in California. And I actually thought to give a bold teaser / prediction at the start of this talk, which is that I think in the next 12 to 24 months, MDMA will likely gain FDA approval for PTSD. And in a few years, I think that this course, the spine course, may actually feature a talk on the pain relieving properties of not only medical marijuana, but also of psychedelics. Early research is suggesting that there is an anti-inflammatory role for microdosing certain compounds. So what do I do? On a daily basis, I'm taking care of patients here at NYU. My bread and butter is doing spinal injections, epidural injections, facet injections, and some minimally invasive procedures such as radiofrequency ablation and spinal cord stimulation. On top of the pandemic, we're also in the midst of an ongoing opioid crisis. Over 115 people per day die every single day from an opioid overdose in the United States. Estimates during the pandemic have suggested that that number has gone significantly higher. In 2017, 2,000 people died from an opioid overdose in New York State. And then that same year, 2017, 72,000 people died from an opioid overdose in the United States. Just a few months ago over the summer, they came in with the estimates of 2020 to basically see how many people had died of an opioid overdose in the United States during that year. And that number was close to 100,000 people. To put that into context, 300,000 people died of COVID in 2020. So that's a huge, huge number. The CDC estimates that there's close to about 3 million Americans that are addicted to opioids. Things have gotten so bad that it's actually dragging down the life expectancy. And this was happening even before the pandemic. It was the first time that we saw that statistic since the 1960s, a drop in life expectancy. So before the pandemic, in the summer of 2018, New York State actually took a pretty drastic step to address this problem. Back that summer, effective immediately, they decided that a doctor could prescribe medical marijuana as a replacement for opioids. This move allowed basically any patients that had severe pain that did not meet the criteria or the definition for chronic pain to basically use medical marijuana instead of an opioid. It even included post-op surgical patients. It's a pretty dramatic move. And what it did was basically opened Pandora's box even further. Can medical marijuana actually cure pain? That's the question. And if you look at some older studies, which are now over 10 years ago, the answer was actually yes, it can. What about the newer studies? This is a 2015 meta-analysis that also suggested, yes, there is pretty good evidence for medical marijuana being able to cure pain. Despite some positive studies and despite legalization across many states, many researchers have cautioned and suggested, whoa, wait. We need a little bit more research here. And they're not wrong. Shown here on this slide are two recent studies that actually question the use of medical marijuana for certain chronic pain conditions. There's even examples of medical marijuana actually worsening pain symptoms. This was shown in a study that used an experimental model of pain. And what they did was they tested 23 healthy volunteers, and they noted a significant increase in an electrical form of hyperalgesia that was brought upon by introducing medical marijuana into these healthy people. Now, despite these questions, pain remains the #1 diagnosis for medical marijuana treatment. Patients say that it helps. States across the United States have continued to not only decriminalize it, but also legalize it. Currently in the state of New York, we have over 150,000 registered patients. There's also well over 2,000 registered prescribers. As medical marijuana treatment becomes more widely accepted and widely used, we have the question, what types of pain patients can we actually help? There's two ways that we can actually study this. The first is we can study it in actual patients that have various chronic pain conditions. The problem with that becomes, how do you deal with all the covariant confounding factors? So there's a second way in which we can study this. And how we do that is in experimental models of pain. So we create these models in healthy adult volunteers. Basically, we recreate pain, we give these healthy volunteers medical marijuana, and we test the results. Recently published in JAMA was a systematic review and a meta-analysis of 18 placebo-controlled studies. It studied the effects of medical marijuana on experimentally created pain in healthy volunteers. And what they found was 4 main things. First, medical marijuana produced a small increase in the pain threshold. Second, medical marijuana was not associated with a reduced intensity of ongoing experimental pain. This suggests that once someone is in pain, medical marijuana is not going to reduce their pain. Third, medical marijuana is associated with a decreased perceived unpleasantness of ongoing experimental pain. This suggests to us that it's likely working on the affective component of pain. And finally, fourth, medical marijuana is not associated with a decrease in mechanical hyperalgesia. Therefore, we can surmise that it's not associated with the process of central sensitization. So that's what the experimental pain studies basically showed us. The clinical studies with actual pain patients showed us that neuropathic pain is the primary type of pain for which moderate evidence supporting the use of medical marijuana exists. If you combine the findings of experimental pain studies and clinical pain studies, we basically realized that medical marijuana helps with neuropathic pain, not by treating or affecting the actual pain, but rather by decreasing the unpleasantness of the neuropathic pain experience. So, what can you say when you're counseling patients? Basically, what I try to tell them is that medical marijuana can help with neuropathic pain. It's not going to cure your pain, but rather it can make your pain less bothersome and less disruptive to your mood. Overall, the development of medical marijuana as a treatment is really exciting. It's exciting to doctors because it gives us a new tool. It's exciting to patients because patients get to take back some control over their own care. And I think that's a really interesting concept. And to understand that concept, you need to understand how medical marijuana treatment is administered. It's a different paradigm than most treatments spine patients get. If you need surgery, you go to a spine surgeon. The surgeon decides how many levels to fuse, what types of screws and hardware they're going to use. Let's say you need an injection. You end up with an office like mine, where you see an interventional pain doc. That doctor decides whether the approach is going to be a transforaminal or an interlaminar, what level is going to get injected, what type of particulate or non-particulate steroid will be injected. Let's say you need a medication. You go to a different type of pain doctor, and that doctor decides, okay, you're going to take gabapentin at X milligrams, Y times per day. Medical marijuana is very, very different. To illustrate that, let's consider how a patient gets medical marijuana treatment. It's a fairly straightforward process. First, you contact the prescriber. Second, you obtain your certification. Third, you get registered online. And finally, fourth, you purchase the product. With regard to dosing, there is no mandate in the law here in New York State for the prescriber to give a certain dose. You can recommend, but it's not required. Really, it's up to the patient to decide. There's two main components of medical marijuana. One is THC, the other is CBD. They come in various mixtures that are available through the dispensaries. There are high THC, low CBD formulations. There are high CBD, low THC formulations. And then there's formulations that are equally mixed. In addition to selecting the dose, the patient also picks the preferred route of administration, whether it's capsule or liquid or plant or topicals. The only forms that are outlawed by New York State are smoked and edibles. Dispensaries are currently not allowed to dispense any of these types. There is something that is very, very brand new. Just earlier this week, on October 5th, the Cannabis Control Board, in conjunction with the New York State Department of Health, basically stated that whole flower cannabis for the use of vaporization is going to be allowed. So that's currently allowed. It's not currently available at the dispensaries, but what that means is that they're creating the framework that these dispensaries are now actually going to be able to sell the whole flower as well too, and that's something brand new. When patients are suffering from severe pain, they have anatomical problems and they have physiological problems. On top of that, they can also suffer from the psychological problem of feeling a lack of control. Medical marijuana works not only by producing changes within the body, but also by giving power, autonomy, and control back to patients suffering from pain. Thank you.
Thank you, Dr. Khan, for that excellent talk. And if you have any questions, please put them in the Slido tool now so that we can review them in a little bit. Next up, we have Dr. Christopher Pageant, and he's going to talk about sticking a needle in it. Interventional pain management for back and leg pain, such as ESI, Facet injections, RFA, and SI joint injections.
Dr. Fischer, thank you very much. So yeah, interventional options on the management of spinal pain. And so I've got a lot of slides here. I'm going to try to, in the interest of time, I'm going to try to tighten this up. So it's a big field to cover in a big short period of time, but we'll get started. So I have no disclosures. So most common areas of chronic pain, right? So neck and back pain, 55%, low back pain, 42%. They're very, very common, right? I mean, if you don't have back or neck pain, that's great for you, but it's sort of waiting out there for you in the future. Most of these things, as we've already been told here, will self-resolve. But for many people, these become chronic problems. And for the others that aren't chronic problems, they're acute or at least subacute problems that are, very intense and need some sort of medical intervention, at least at some point during their life. So sources of neck and back pain. I'm not going to belabor this, but obviously, as was mentioned before, you have to rule out the dangerous things, right? Your cancers, your abscess, your osteomyelitis, discitis, some sort of systemic problem. But for the purpose of this talk, we're talking about the sources of neck and back pain that are really amenable to these kind of interventional treatments. And normally you're talking about things like degenerative diseases, disc herniations, radicular impingements, and sacroiliac joint dysfunction. So I feel like, at least, and maybe this isn't the case as much anymore, but I feel like when people think of pain medicine, they think of the analgesic ladder, right? So here, this is out of the World Health Organization. And this is really like an opioid-centric thing, right? So this came out of initially the palliative care literature and the literature about end of life and how there was really poor pain care for a lot of these people. And I think there was a move towards more compassionate care and more pharmacologic care for these type of patients. They have step 1, step 2, step 3. Right, but all the steps basically are adjuvants, opioids, non-opioids. These are medication-based steps. And so I think pain medicine looks to a lot of people kind of like this, like there's pain medicine, right? What the field does is right in the name. So, but really, you can think of pain treatment as, you can also think of it as a ladder, right? You can think of it as, instead of just, there's a little more complex way to think about it. Instead of thinking just about pills, you can think about, well, okay, the first thing to do is non-surgical, non-interventional, non-medication-based treatments. So you've got encouragement and time, and then maybe you go to over-the-counter analgesics, and then you're going to maybe some physical therapy, and then there's, as things progress, and either the patient is in very severe pain, or they're, even more important, their function is impaired, or perhaps nothing you're doing is working. You go to things like interventional pain management and surgery, and maybe chronic opioids, spinal cord stimulators. So you can think of pain treatment as a ladder. I think the best way to think of it is in this sort of multimodal concept, right? Where you've got, sort of in my mind, you've got, sort of multiple buckets to put pain medicine or pain management in. And there's a sort of pharmacologic pain management. You got your physical rehabilitation pain, tools. You've got your psychological and psychiatric therapy, and then you've got your interventional pain management, right? And so, using those together, ideally, you can get the best outcome for the patient with the least harm, right? And ultimately, that's the goal. So, what I'm talking about today is intervention. So injection techniques for spinal pain, there are many of them, and covering them all in the course of a 10 to 15 minute talk is impossible. But I think, normally the sort of bread and butter of what we do tends to be epidural steroid injections, techniques to denervate or treat pain from the facet joints in the lumbar spine, and then also there's sacroiliac joint injections. And so that'll be the primary focus of my talk today, will be those 3 overall subjects. So what are the interventional pain management? What are the indications for this? I mean, putting a needle in the spine, why would you ever do that kind of thing? Well, so failure of oral medications and physical therapy, right? That's one thing, right? I mean, obviously, in my mind, and I think this is generally agreed upon by multiple sort of governing societies, when people initially come to me, you're going to talk about over-the-counter medications if necessary, but ideally you're going to talk about physical therapy. You're going to talk about activity modification. You're going to talk about transition to a home exercise program. If the patient can do that, then that's really all they need, and that's great. As long as they don't have any red flags and there's no numbness, there's no weakness, there's no reason to send to a surgeon. Then that's great. That's a great scenario. But oftentimes you'll have a patient that has uncontrollable severe pain, which really precludes PT or precludes really them participating in it. You have them where they're in a non-functional state. So, maybe it's not where they have, progressive radiculopathy where you really need to, send them to a spine surgeon, but you've got, a patient that's non-functional, can't go to work, needs something to be done. And there are times where there's an unclear pain generator. And so these interventions can have, a diagnostic utility. So what does it mean? There we go. So, what is the, so really one thing you could ask is what is the differential diagnosis of cervical lumbar pain and what are the treatments indicated for these diagnoses? So when you're thinking about intervention, right, again, outside of the red flags, you're talking about muscular myofascial pain, lumbar radicular and nerve root pain, facet pain and arthropathy, and sacroiliac joint pain. So we'll start with radicular pain, right? So again, not to belabor this because we've gone over this in detail already, but this is thought to be caused by inflammation around or impingement around a spinal nerve root, right? So if you've got direct pressure from a disc, or you've got inflammation and pressure from a disc or from compromise of the outside of the disc and leakage of the nucleus into the area of the spinal nerve. Radicular pain usually begins the back and radiates in a dermatomal pattern, often below the knee. And oftentimes, these dermatomal patterns are very helpful because obviously the diagnosis of neck and back pain can be very difficult. And, the dermatomal patterns are going to help you in the diagnosis of these conditions. So lumbar radicular pain, the typical history will be pain radiating from the spine to the extremities, maybe burning or electric in nature, maybe associated with neurological complaints, and you might have radiculopathy with your numbness and weakness. And then exam imaging, again, as was mentioned before, you have your straight and contralateral straight leg raise, and the imaging may show nerve impingement. And the reason I put that in there is that, again, as we went through before, you have to have multiple lines of evidence to get to a conclusion, right? Because a patient may come in and say, my back hurts and it shoots down my leg and this and that is going on. But, you need to have the history and the exam, with the MRI to back you up to really justify an intervention. I think what we want to do is treat the patient again, not the imaging, because obviously as the years goes on, we can get to a point where, degenerative disc disease and potential nerve impingement and facet arthropathy and spondylosis is really in very nearly every patient. And so you have to take care using your history and physical so you can delineate the correct intervention to do. Because really the goal, right, is to do the least amount of interventions to the patient to minimize the risk of harm, and then to give them the maximum amount of pain benefit and then move on to the next patient. So epidural steroid injections. So there are numerous ways to do these, but the two I'm going to focus on are intralaminar and transforaminal. So what are the structural basis of epidural steroid injections? So structural changes in the spine can result in an inflammatory response in the epidural space. This can be caused by leakage of the nucleus pulposus due to tears or herniations, and that can provoke an inflammatory reaction. And there are models in rats and other animals showing that if you have inflammation, you can create pain without actual impingement, or depending on where the impingement is, you require inflammation to actually have pain. And so this gives really a somewhat robust idea as to how these injections might work. So, but of course, given that you can't really do these experiments in humans like you can in animals, there's a wide variety of proposed mechanisms of action. So an anti-inflammatory result of the nerve roots is the primary proposed mechanism of action, but obviously just simply irrigation out of inflammatory mediators, and various changes in levels of sodium channels. I mean, there's a wide variety of proposed mechanisms of action. So what are the benefits and indications of these things? Right, so they're high in the algorithm for the management of radicular pain. Transforaminals may provide diagnostic information, and pain relief may decrease the patient's need for medication use. And they may send the patient back to physical therapy. And really, these are sort of some of the ideal things. Risk contraindications, obviously the evidence is mixed and it's highly variable depending on the literature source. I mean, that's just the case. The evidence for transforaminals being selective to nerve roots is equivocal at best. And again, if there's, you're being asked to do something for surgical planning purposes, obviously multiple lines of evidence need to be used. And severe complications are rare, but they're certainly of significant concern. So again, approaches to the epidural space and lumbar sacral radiculopathy. Let's talk about the intralaminar epidural steroid injection. So I think, at least for those of us from an anesthesia background, right, this is initially the most approachable injection, right? This is similar to in the lumbar spine, this is similar to a labor epidural, right? These were initially done blind without fluoroscopic technique, although I think, fluoroscopy is standard of care at this point. There's posterior epidural placement, There's a large volume of medication and fluid that is injected. These are mostly therapeutic, meaning they really have minimal diagnostic value in my mind. And that's, but that's sort of a double-edged sword, because although they have minimal diagnostic value, you really get a very good spread of medication. So if you can do one of these injections, you know, you don't need to precisely target the exact nerve root that you need to inject in order to get the patient pain relief. You can really get one injection, you can get both sides, you can get multiple levels. And so, you know, and they also have a proven safety record. You know, obviously, you know, they have their own risks, but, you know, which would you rather do? One interlaminar epidural steroid injection, you can get both sides, you can get multiple levels, or a whole series of transferamals. And I think the risk to the patient, risk-benefit balance is usually fairly clear. So cervical epidural steroid injections obviously have their own risks, but again, it's a well-established technique. This is just a riskier area due to the fact that, you know, obviously the spinal cord has ended at L1, and, you know, it's there in the cervical spine. But again, you know, this is a well-established technique, and I think in the cervical spine, interlaminar injections are the preferred method because of safety, for safety reasons. So transfemoral epidural steroid injections. So these require fluoroscopy. So it's not just standard of care. There's really no such thing as a blind transfemoral epidural steroid injection. At least there shouldn't be. So these have confirmed spinal level and laterality. They theoretically have improved steroid placement. You know, they're anterior. They have better nerve root coverage. You know, they have the steroid placement is placed anterior laterally, where theoretically the source of the problem should be, and they can be diagnostic and therapeutic. And there definitely is some evidence, although it's not conclusive, but there's definitely some evidence that they can, in some cases, be more effective than interlaminars. Cervical transfemoral epidural steroid injections. So just briefly, you know, these injections are controversial because it's a busy area. And so that, you know, of all these sort of very severe consequences that are associated with epidural steroid injections, a large number of them, certainly a majority or a plurality, are from cervical transfemoral epidural steroid injections. You're at a very high risk of becoming intravascular and damaging structures, or leading to infarction in structures that can cause severe downstream consequences to the patients. And so in general, unless there's a very specific reason to do these injections, cervical epidurals are typically done. That's certainly not always the case. I'll just skip that. So facet pain. So, you know, the facet joints are a frequently diagnosed source of pain. Each facet joint is innervated by two medial branches of the dorsal ramus. Facet joint pain is typically worsened by extension and twisting of the back, and typically does not radiate below the knee. Cervical facet pain can be associated with axial neck pain and occipital headache, and can also be associated with things like motor vehicle accidents. There's actually one of the, you know, cervical facet pain is one of the, and its treatment are one of the most evidence-based parts of pain medicine. So history can be secondary to whiplash injury in the neck. It can result in headaches. Cervical facets have defined but very variable radiation patterns. We've actually already seen those, but I'll go through them again very briefly. You know, and again, there are certain physical exam findings that are found, and you can find facet arthropathy on imaging. But unfortunately, and this has been fairly well shown, the physical exam is really very poorly correlated, and MRI, CT is really very poorly correlated with whether or not people have pain. I mean, especially as people get older. Once you get into your 60s, 70s, 80s, everyone has facet arthropathy. It's almost as abnormal not to have it, and not all these people have facet pain. And certainly, when someone has severe back pain, you know, do they have stenosis? Do they have a herniated disc? You know, if the pain is acute enough, you'll often have an exam where, frankly, the patient has pain no matter what you do with their back. You know, they have pain with range of motion in all planes, and facet loading in that context is usually less useful. So here you have the cervical facet radiation patterns, and you have sort of the classic there on the left, and then on the right, a little more detailed, updated study. As you might expect, you know, the facet pattern, the facet patterns you know, they overlap, and there's some variation based on patients, which is really just to be expected. I mean, you know, people are not built like automobiles, you know, they're organisms. And so much like the dermatomes, these sort of sclerotonal pain patterns are not perfectly consistent from patient to patient. So again, facet pain theoretically associated with arthritic changes in the lumbar spine or with injury. Pain with extension, long periods of standing, and they do have variable but defined radiation patterns to some extent. And so here's sort of your lumbar facet pain pattern. Although, you know, you'll notice that very easily overlaps with things like myofascial pain, pain with trigger points, You could have radicular pain that could radiate in this area, even sort of sacroiliac joint pain. I mean, ultimately what you need to do to show someone has facet pain is to do lumbar medial branch blocks, right? So the involved joints are duly innervated. This is a relatively straightforward procedure. You can denervate these joints temporarily using either lidocaine or bupivacaine. And when this is done, if the patient, the patient usually has profound relief, 80% relief is the goal, but the patient usually has some level of obvious relief of pain. And ideally, 2 successful medial branch blocks would be followed by RFA. Now, in real life, in an ideal patient, this would be something like you'd have 1 medial branch block with local anesthetic, and then 1 medial branch block, say with saline, and the patient would be able to easily tell the difference between these 2 things, one serving to placebo. Or perhaps, this is done in research studies too, 1 medial branch block with lidocaine, and they should have, pain relief for an hour, and then 1 medial branch block with bupivacaine, and the patient can have pain relief for 4 to 6 hours. This is done in the literature. In the real clinic, it does not work out that way. Oftentimes, having patients distinguish very clearly between differential local anesthetic blocks is often challenging in the real clinic. Also, what makes this more difficult is that although insurance companies don't generally admit these exist, there's literature showing, and there's a lot of clinical experience with therapeutic medial branch blocks. These do seem to be a thing, and there are a lot of reasons why that might be, but even giving a half cc of medication in this area, there's a lot of spread of that medication, and there's a lot of neurologic structures in that area, and you're going to get spread, and oftentimes the patient will come back and they'll have pain relief for several months, and your local anesthetic is certainly gone in several hours. But if you do get successful medial branch blocks, the next step is a radiofrequency ablation, which is similar, is a very similar procedure. Basically, there are 2 types of this. There's thermal radiofrequency, where you heat the end of the probe up to 80 degrees, and you basically form a lesion for 60 to 90 seconds, then have dieback of the nerve. Or there's something called pulse radiofrequency, which is where you have an electric current that does not produce temperatures above 45 degrees, and it's a neuromodulatory step that takes place, although that is less well defined. Sensory loss may be transient. Pain relief can extend for much longer periods. Obviously the risk of RFA, ultimately it's, radiofrequency ablation and medial branch blocks are probably a lower risk procedure than the epidural steroid injection, although care has to be taken not to damage the spinal nerve itself. And finally, just very briefly, so we'll finish up, sacroiliac pain can often confuse the picture. It's often associated with people who have spinal pathology, people who have previous fusions. It often radiates from the area overlying the sacroiliac joint to the buttocks and posterior thigh, although people with sacroiliac pain can easily overlap with presentation of hip pain, myofascial pain, and often, honestly, as people, you get older populations, many people have pain from many different sources. Osteoarthritis is the most common cause, but especially in younger patients, you have to look for things like sacroiliitis. Is this a young female? They need to be referred to rheumatologist colleagues. And also, any change in the walking pattern can, in theory, cause this type of pain. And basically, to summarize this, usually the approach to this is an injection of steroids in the joint. It's a very straightforward procedure. If effective, will usually give 3 to 6 months of pain relief. But there are also RFA procedures where you can actually perform ablation of the lateral branches of the nerves going to this joint. I personally have found those to be effective in sort of refractory cases of this, although the literature for this is really very limited. With that, I'm going to end. I'm going to skip the literature. There's a lot of it. And thank you very much.
All right, thank you so much. That was excellent. Okay, so we are over on this section. And so I have responded to some of the few questions for Hiroshi. And those people can follow up with him with email. If there are any additional questions based off of this section, please go ahead and put them in the Slido tool, and then I can send you the presenter's email so you can follow up with that. So I want to thank everyone for talking on the non-operative treatment of interventional or non-operative treatment and interventional pain management. Next, we're going to move on to our section on degenerative cervical conditions. And Dr. Young Kim is going to talk about the evaluation and treatment of neck pain and radiculopathy.
Thank you, Charla. Good morning, everyone. This morning, I'm going to be talking about evaluation and treatment of neck pain and radiculopathy. Excuse me. We can't really talk about neck pain without discussing the definition of cervical spondylosis. The cervical spondylosis leads to neck pain, development of radiculopathy, and myelopathy. The definition of cervical spondylosis is that of spinal condition resulting from degeneration of the spine due to basically aging and wear and tear of the disc between the vertebrae. When someone is born, when a person is born, the disc is comprised mostly of water. It's 90% water, and the remaining is collagen fiber matrix. But as we get older, we lose the water content, and the discs begin to look more desiccated and becomes more friable, which then leads to degeneration of the disc. Degenerative disc is related to aging, your genetic composition, history of repetitive trauma, work history, and whatnot. And that leads to annular tear, loss of disc space. That in turn leads to somewhat we call micro instability of the segment. And that leads to radiculopathy, nerve irritation, and sometimes myelopathy. And body's response to that starts to form osteophytes. So the person may become more stiffer, and yet it's kind of a protective mechanism whereby forming osteophytes and thickening the facet joints, the spine stops irritating the nerve so much. But that in and of itself can lead to further compression of nerve roots or the spinal cord. So when the spine goes through an aging process, it could lead to what we call axial neck pain. And when it involves nerve root compression, then one can develop radiculopathy. If the compression results in compression of the spinal cord, then one can develop myelopathy, or sometimes, and many times, one can develop combination of both radiculopathy and myelopathy. So the C5-6 disc is most commonly involved, followed by C6-7, and C2-3 tends to be the least involved segment. The axial, we'll talk about the axial neck pain first and the evaluation and treatment of the axial neck pain. They tend to be episodic, oftentimes related to some of the activities one might have been involved. One may complain of occipital headaches, stiffness, and muscle spasm. There may be a history of trauma, sports injuries. However, if someone has a history of a systemic illness such as cancer, inflammatory arthropathy, or if there are constitutional symptoms, you may want to image them right away rather than waiting for the symptoms to subside. So the AP and lateral views of the cervical spine, what you want to look for is you want to look for any evidence of chronic changes. And one may say, hey, looking at the AP, I can't really tell anything. It just shows alignment overall, but you could get a pretty good idea as to the chronicity of the symptoms and the issues. One can look at the uncovertebral joint, which in someone with spondylotic changes doesn't look so sharp. They look rounded because of the formation of the disc osteophyte complex. But you could obtain a lot more information from the lateral views where you look for loss of disc space, a loss of normal alignment, listhesis, and also look for arthritic changes in the facet joints as well. Oblique views used to be much more commonly ordered, not so much anymore, but the oblique views are used to assess the foraminal status. Flexion extension x-rays are indicating someone with a history of trauma, or someone with history of instability, or someone with inflammatory arthropathy, where one can, for example, rheumatoid arthritis can lead to C1, C2 instability. So you want to get flexion extension views to look to rule in or rule out the presence of such. Open mouth view is often indicated in a trauma setting, but in patients with C1, C2 instability as a result of spondylotic changes or rheumatoid arthritis, you could look for the arthritic changes in the C1, C2 lateral mass, the facet joint. CT scan is indicated. CT is much better than X-ray and oftentimes better than the MRI when delineating the bony anatomy, especially when you're suspecting possible presence of ossified posterior longitudinal ligament. One can also better assess the presence or absence of facet arthritis with CT scan better than the MRI. CT myelogram is indicated in cases where one cannot undergo MRI studies. The old pacemakers, the new ones are oftentimes MRI compatible. Same goes with patients with spinal cord stimulators. But the old pacemakers and the spinal cord stimulator, the battery packs, were not MRI compatibles. And if someone has metal in their head, those patients are not allowed to have MRIs, and CT myelogram may be an alternative to the MRI in those situations. But the MRI, the cervical spine, is the gold standard. The problem with the MRI is that it's too sensitive. And if one is not really good at reading the actual MRI, him or herself, oftentimes one can be kind of fooled into reading the report and think that the patient may have significant issues when in turn, the radiologist interpreting the MRI may be overly exaggerating or may tend to be a little too thorough in reading the MRI. So one has to take the reading and take it with a grain of salt, and also has to assume that certain changes are expected as we get older. But the MRI is great for ruling out other causes for axial neck pain or other radiculopathy. Spinal cord is well visualized. If there's a tumor or a cancer, you'll see that. Infection can be ruled out as well. Briefly touching on CT discographies, it is much more of a historical perspective. The problem with discography is that it has a very high false positive rate and often can lead to falsely diagnosing the pain generator and can often lead to unnecessary surgery. So again, when certainly faced with someone presenting with axial neck pain, sometimes as Dr. Pageant covered before, one can use injection techniques to somewhat treat the symptom, but at the same time confirm the diagnostic suspicions of where the pain may be coming from. And again, one has to be concerned that these type of injections also may have a high false positive rate. The medications, the combinations of steroid and lidocaine can have especially the steroid can have systemic effect. Lidocaine can spread next to the adjacent levels and can lead to the rate of high false positive. So you can't really rely on one diagnostic injection to really sort out where the pain may be coming from. You have to rely on your clinical suspicion, radiographic studies, and perhaps, as Dr. Pageant indicated before, different pharmacologic agents in these injections when making the diagnosis. So what can cause axial neck pain? One that we're interested and one that we're talking about is spondylotic arthritic neck pain, but other problems can cause axial neck pain, such as fractures, inflammatory arthropathy, infections, tumors, and another big one is non-spine related issues. Secondary gain is a big one, unfortunately, and fibromyalgia may be another. So how do we treat axial neck pain? Most of them will settle down. Non-surgical treatment is a treatment of choice. As others have indicated, you want to start out with non-opioids, anti-inflammatories, and physical therapy. But in those patients with severe pain or ones that are not responding to the injections, you may want to refer them to your pain management colleagues for therapeutic and diagnostic injections. When do we ever operate on axial neck pain? We try not to operate on patients with axial neck pain because, number one, it is hard to really pinpoint where the pain may be coming from. But there are specific exceptions, such as C1, C2 arthritis, and in patients with no other secondary gains and clearly have a single level or two-level disease that can be isolated with clinical and radiographic presentations. But someone comes in with a pain diagram as such, operating on that person is not going to be the best thing for them, and it is highly unlikely that person will benefit from the surgery. As I've explained a little bit before, C1, C2 fusion is a fairly unknown entity. It is indicated in patients with specific C1, C2 arthritis, and the pain is often generated by turning their head left and right. That's where C1, C2's motion is. And when that causes pain, and sometimes that pain can be quite severe and debilitating, that patient may benefit from isolated C1, C2 fusion. So what type of surgery options are there? It is usually a form of anterior cervical discectomy and fusion, or more recently, a total disc replacement. What's the clinical success? It is all over the place, and the reason is that the literatures are all over the place with not so good evidence-based studies. But in very isolated study, in the isolated patients, cervical fusion or the disc replacement can be quite helpful. Moving on to the cervical radiculopathy, as the disease become more spondylotic, you may develop osteoarthritis, disc osteophytes, or soft disc herniation leading to radiculopathy. The disc herniation, when it's soft, can have mechanical irritation and chemical irritation, whereas hard discs tend to be more of a mechanical. And in my experience, ones with soft disc herniation tend to respond better to epidural steroid injections. Patients present usually with a very specific complaints of neck pain and radiating symptom that follows a dermatomal distribution. Oftentimes, physical findings will be present, especially Sperling signs, and the shoulder abduction relief test is a good sign for someone mostly with soft disc herniations. X-ray studies tend to be non-diagnostic. What you look for is evidence of any spondylotic changes. But the reality is that when you're suspecting someone with cervical radiculopathy, then the MRI is the test of choice. What you look for is presence of disc osteophyte, nerve compression, or soft disc herniations. When someone has mixed presenting symptoms, oftentimes we'll send our patients to our either neurologist or a PM&R specialist for electrodiagnostic tests to confirm our suspicion and also to rule out peripheral nerve compressions. Differential diagnosis, one can get really burned, is Parsonage Turner syndrome. Oftentimes they come with symptoms that are consistent with cervical radiculopathy, and yet it may involve multiple nerve roots. Then you have to always be suspicious of these possibilities. Most patients with cervical radiculopathy will get better without surgery, with physical therapy, anti-inflammatories, and medications, and possibly injections, but some of them do not. If they have progressive weakness or persistent pain, profound weakness, then we indicate them for surgery. The goal of the surgery is to eliminate the pressure on the nerve root so that the pain goes away and to keep that pain from coming back. And the best way to do this would be with anterior cervical discectomy and fusion. It is the mainstay of our surgical treatment for patients with cervical radiculopathy. It has minimal tissue disruption. The disc is right there. Once you find the right plane, get to the cervical space, which takes about 5 minutes to do, and you're removing the disc and the osteophytes or the disc fragment without touching the nerve root. So it is safe and a very effective way to treat the cervical radiculopathy. The outcome of cervical radiculopathy is great. Pseudoarthrosis rate is small, but it increases as you operate on more levels. But even in patients with pseudoarthrosis, many patients are quite asymptomatic and doing very well. So patients postoperatively, 1 or 2 levels, many of these patients are sent home the same day with just a soft collar or hard collar just for comfort. And when their return to work day depends on the type of work that they do and depends on their discomfort level. But many patients are returned to work within a week or 2. Complications are rare, but it can be quite severe. The most devastating injury may be injury to the trachea or esophagus. Thankfully, those incidents are extremely rare. But so if the anterior cervical discectomy infusion works great, what's the problem? The bottom line is it's a great procedure, but because you're fusing the segment, you're transferring the stress to the next segment, which can potentially lead to increased stress to the next level, increasing the rate of breakdown in the next level, and possibly causing patients to come back in 10, 15 years for another surgery. That's why disc arthroplasty was developed over 10 years ago to try to take away that problem with Jason level disease. And so far that 1 or 2 level disc replacement surgery has been equal or superior in treating patients with cervical radiculopathy. And more surgeons are recommending this procedure in the appropriate patients for the treatment of cervical radiculopathy. I'm sorry, I'm rushing through this because I'm trying to make up for the time. Complication, again, can happen with disc arthroplasty, but again, complications of disc arthroplasties are rare. So posterior foraminotomy is indicated in very few instances where the soft disc herniation can be accessed from posteriorly. Is technically much more demanding than the anterior cervical discectomy infusion. And one of the downsides to the surgery is that oftentimes patients can complain of residual neck pain. So the conclusion is that the majority of neck pain and radiculopathy will get better without surgery, but surgery is recommended in patients with persistent pain and or neurologic deficits. And when properly indicated, surgical procedure for cervical spine has excellent outcomes. Thank you.
Thank you so much. We have a quick question that we can address right now since it's very on topic and on time from one of the participants. What about minimally invasive posterior cervical foraminotomy and laminoplasty for unilateral single or 2-level cervical radiculopathy instead of ACDF? So if you want to, Dr. Kim, if you want to comment on that really quick, and then we'll move on to cervical myelopathy.
Sure. So minimally invasive posterior cervical foraminotomy is an excellent option. It minimizes the soft tissue disruption. And when dealing with a very isolated 1 or 2 level unilateral symptoms, then it is a good alternative to open procedure or anterior cervical discectomy infusion, provided that the patient has no malalignment or no significant axial neck pain. The second question of cervical laminoplasty. Cervical laminoplasty requires, basically it is a surgery that is performed for myelopathy, and Dr. Bendo, I'm sure will touch upon this more. It's not really a procedure that is designed to help with radiculopathy, as the goal of that procedure is to open up the canal for the spinal cord compression patients.
All right, great. Thank you. So that was kind of a nice segue question for us. Up next, we have Dr. John Bendo. He's going to be talking to us about evaluation and treatment of cervical myelopathy. And if you could just unmute yourself, John, then I think we will be good. Are you
okay? Can you hear me now? Okay,
Yes.
thanks. Okay, guys, we're going to switch gears and we're going to move on to cervical myelopathy, more cord issues here versus what Dr. Kim was just talking about, more radiculopathic or nerve root issues. So the bottom line is the prognosis for cervical nerve root issue is very favorable, but the prognosis for cord issues or cord compression is very unfavorable. So this talk will be about the evaluation and treatment of cervical myelopathy. These are my disclosures. Cervical myelopathy can be defined as dysfunction of the spinal cord in its simplest form. And once again, the natural history, if you leave this alone, is very, very poor. Untreated cervical myelopathy or cord compression can lead to gait disturbance, upper and low extremity weakness, numbness and tingling in both arms, and ultimately bladder dysfunction. Early bladder dysfunction being urgency and frequency, and ultimately, if it goes untreated, can lead to frank incontinence. Symptoms of myelopathy, well, typically these patients do not have pain, right? A lumbar case typically has pain. A cervical nerve root issue typically has pain. If it's just cord compression, these patients most commonly do not have pain. So that's why the diagnosis is often missed. They may have numbness and tingling arms and or legs, as I said before, weakness in arms and legs. They lose dexterity. They'll tell you they can't button their shirt. They'll tell you they can't discern between a quarter, nickel, and dime anymore. Their handwriting is off. Loss of balance is an early sign of myelopathy. Their legs can get stiff and spastic. And of course, urinary dysfunction in the way, once again, of urgency, frequency, or frank incontinence can settle in long term. What are the signs that we look for when we're examining these patients in the office? Well, their upper and lower extremities below the level of the lesion will become hyperreflexic. 2+ being normal, 3+ being hyperreflexic. Hoffman's sign, as you see in the upper picture there, when you flick the middle phalanx DIP, you flick it into flexion, and you'll get a reflex response of a pincer mechanism of the index and the thumb. That's an abnormal long track finding that's consistent with spinal cord dysfunction. Lermite's sign was first described with MS, but typically you can see it with spinal cord compression. You have the patient flex and extend the neck very quickly, and you're basically moving the osteophytes along the cord, and that will irritate the spinal cord, causing this shock-like sensation in your arms and your legs. You want to record if there's any clonus, number of beats of clonus on each foot, and you want to record if it's sustained or unsustained. You want to look for a Babinski, as shown in the lower picture there. You take the back of your reflex hammer, you start at the heel, you go along the lateral aspect of the foot and all the way around to the big toe. A Babinski that's present, the toes, as you know, will flare out, and the big toe will extend. That's an abnormal long tract finding consistent with spinal cord compression. If you do that maneuver and the patient flexes the hip, flexes the knee, and dorsiflexes the ankle suddenly, picks up the whole leg in response, that's called the triple flexor response. Differential diagnosis of myelopathy. We can break it up into extradural compression or intradural compression. The most common causes of extradural compression, as you know, is a herniated disc, as shown in the upper left picture here, large soft disc herniation causing dysfunction of the spinal cord. These people need urgent surgical attention. You don't wait for the disc to shrink. At that point, it's too late, and their dysfunction could be permanent. So remember, spinal cord, very unforgiving. Most of these patients need surgery. Cervical spinalotic myelopathy, just the progressive narrowing of the spinal canal, as you see in the second picture on the bottom here, can often lead to myelacia or discoloration of the spinal cord. That's a very bad prognostic sign. Those people need surgery. Of course, OPLL, as seen on the picture on the right here, calcification of the PLL can lead to severe stenosis, cord compression. These people often need surgery. Then we have the intrinsic compression. You can have a tumor in the spinal cord causing issues, a syrinx or a fluid expanding lesion in the spinal cord. And of course, there's non-compressive causes of cervical myelopathy. Viral cause could be HIV myelopathy or HTLV1. It's also known as spastic tropical paraparesis. Pretty unlikely, but if people travel to really far away, exotic places, always possible. Transverse myelitis can present with myelopathic symptoms also. So what are the surgical indications? Well, we have a pretty low threshold for indicating these people because we know if they come to us impaired, they're only going to get worse. We don't sit on these people. You jump on these with surgery pretty commonly and pretty aggressively, and that's the appropriate treatment. So if somebody has clinical signs of myelopathy, they'll tell you they have numbness and tingling in their hands. Their balance is progressively altered. They feel like they've had 5 or 6 drinks and they're having trouble walking. They're losing function of their arms. They're becoming more spastic. Their leg is stiff. It's giving way. These are all very critical neurologic signs. People need surgery. Any progression of a significant neurologic deficit, obviously, will push the patient into surgery. This is the controversial indication. What happens if somebody comes to the office and they have a picture like this? It's a really bad-looking MRI, severe cord compression, and they're relatively asymptomatic. I will tell you that this is a relatively uncommon scenario. If they have this picture, more than likely they're going to be impaired. But let's just say picture's not quite this bad, significant stenosis. You find just a unilateral Hoffman on exam, no other long track finding. Does that person really need surgery? My opinion, no. If they're asymptomatic, you can follow those people very carefully. I'm not saying stick your head in the sand and ignore it, but I tell these patients to get a serial neurological evaluation every 6 months. If you're that concerned, it could be every 3 months, and see your neurologist and or myself for another visit. And at the first sign that your patient's going downhill and losing more function, you jump in and operate. The chance of that person being in a very bad car wreck after they leave your office and paralyzing them is really, really, really unlikely. So you can follow these people very carefully. The first sign of progression, jump in and do something. What's the operative goal? The clinical goal, relieve pain, which we said before is relatively uncommon, but most of the time we're looking to stabilize their neurologic deterioration. We tell people, if I operate on you, I will prevent the condition from getting worse. I can't promise how much of the stuff that you've lost you're going to get back, but you will not get worse. The analogy I use, this is a down-going elevator. You press the button, you get off at that floor, you're not getting worse, right? Otherwise, if you don't have surgery, you're heading to the basement, you're heading for a bad place. We want to maximize neurologic function and recovery. We want to minimize the risk of late recurrence of progressive neurologic dysfunction. Structural goals: decompress all the compressed neural elements, maintain or achieve stability, improve or maintain spinal alignment, and minimize the risk of late failure or recurrence. What are the prognostic factors? Well, if a patient comes to us with less compression of the cord, that's a better prognostic factor for surgery. The less severe the myelopathy is at the time of surgery, the better the prognosis. The younger the patient, the more chance of recovery. The shorter duration of symptoms, 1 year seems to be a critical time period. If you have symptoms less than a year, better prognosis. Greater than a year, poor prognosis. And if you have single rather than multiple levels of involvement in terms of cord compression, better prognosis with surgery. What are the surgical options? Well, we keep it kind of simple, right? Most people know that we could either go in the front anterior and decompress and fuse, or decompress and replace the disc. The other option is posterior, and the two options posterior are laminectomy and fusion or laminoplasty. Laminectomy alone is basically fallen out of favor because of issues such as post-laminectomy membrane, which can be compressive, and post-laminectomy kyphosis, which is a big concern. For more complex cases, if we have to do a multiple corpectomy, or the patient has a very severe osteoporosis where the spine is very deformed, we may have to consider combined anterior and posterior fusion. Anatomic, what do we think of anatomic considerations when we're scheduling the surgery? Well, we need to know how many levels, how many cord levels are compressed, how many discs are compressed. Where is the compression? Is it retrodiscal, where we just take out the disc, or is it retrovertebral, which means we have to take out the whole vertebral body? What's the alignment of the spine? That's very, very important. What's the alignment of the cervical spine in the neutral position? How flexible is the cervical spine? Is it really kind of loosey-goosey flexible, or is it extremely rigid and stiff? These issues play a role in surgical mapping. And we assess stability with lateral flexion extension x-rays. General rules of surgical approach. Well, as Dr. Kim said before, generally speaking, as in radiculopathy, 1 and 2 level will typically go in the front anteriorly with fusion or disc replacement. But if it's 3 or more levels, very advanced, will typically go in the back. And once again, the back will do laminectomy and fusion or laminoplasty. And of course, we have to assess the flexibility of the spine depending which surgery we're going to do. So for anterior surgery, we know there are benefits and limitations. The benefits of anterior surgery, it's a direct decompression because most of the compression is usually from the disc in the front, so we take it off directly. There's less axial neck pain for anterior surgery, expedited recovery. The limitations, when you can have difficulty swallowing, usually short term. You can have painful swallowing, usually short term. You can have pseudoarthrosis or failed fusion, which may require another operation if it's a fusion. And of course, with OPLL, we always are concerned about dural atresia, where the dura gets really thin and sometimes it's absent. So when you take off the PLL, you're staring at a spinal cord with fluid pouring out of the sac, which is not pleasant. So most of us try to avoid OPLL anteriorly, with few exceptions. We do most of those cases posteriorly. Posterior surgery, the benefits are I can do a multi-level decompression, 3, 4, 5-level decompression in 2 hours, which I will not be able to do if I do an anterior surgery. So it's a shorter operative time, especially for elderly patients that may not be very healthy. And who gets this problem? Elderly patients. And the benefit of laminoplasty, remember, it's motion sparing. So you can decompress the spinal cord, maintain stability, and not fuse it in many patients if you do laminoplasty. So that's always my preferred go-to if I can. If not, laminectomy and fusion. The limitations of posterior surgery are it's indirect decompression. There could be more axial neck pain because now we're cutting through the muscle in the back of the neck. Everybody's familiar with the concept of a postoperative C5 palsy. The C5 nerve root is the most fickle nerve in the spine. And if it could have issues post-op, such as a drop shoulder, it's much more common with posterior surgery than anterior surgery. Of course, if you fuse, we're concerned about pseudoarthrosis, junctional kyphosis, and with laminoplasty, if it's not a very stable spine, if the spine is not in a lordotic position preoperatively, these people can end up with postoperative instability and kyphosis. So we need to be concerned about that. The other issue is wound infections, much higher rate of wound infections posterior versus anterior. So as I said before, laminoplasty, nice alternative for multi-level cord compression with a stable spine that you're not worried about instability post-op. It's motion sparing. Now, if you do have one level of instability, it doesn't mean that the whole spine has to be fused. You may want to do a laminoplasty and consider a posterior fusion just at one level in the back. So that's a combination of a laminoplasty and a limited fusion. So what are the, just to briefly sum up, what are the outcomes of fusion versus TDR surgery for myelopathy? Remember, we're talking about cord dysfunction, not radiculopathy. Even though the results are kind of the same for both diagnoses. They're both excellent outcomes is the bottom line. The clinical outcomes are comparable at 7 to 8 years at this point for fusion, anterior fusion versus total disc replacement. The difference is there seems to be a lower rate of revision surgery for disc replacement for obvious reasons because you're maintaining motion. And there appears to be a lower incidence of adjacent level radiographic degeneration with disc replacement. How about, is there a difference in surgical outcome? Is my patient going to recover neurologically any different if you do an anterior versus a posterior surgery? Well, if it's well indicated, and today we talk about, it's all about the indication for surgery, but if the surgery is well indicated, then the surgical outcomes and the neurologic recovery are comparable for anterior and posterior procedures. Just remember that anterior surgery typically has, more throat issues, dysphagia and dysphonia, and posterior surgery has higher rates of C5 palsy and wound infection. So you need to weigh both procedures, risks before making a decision. Thanks.
Great. That was an excellent summary of evaluation and treatment of cervical myelopathy. So if you have any questions, please enter them in the chat now. We did have a question during the talk in relation to the last talk. Is there a concern for wear debris, disc replacement as occurs in hips and knee replacement? Young, you want to answer that?
Sure. It is a theoretical consideration, but unlike the hips and the knees, where there's a tremendous amount of shearing force across the junction, between the plastic and the metal, or the metal and metal, the shearing force across the cervical disc is very, very small. And as a result, the metal or the wear debris is more of a theoretical consideration or concern, but really hasn't been of a significant clinical issues.
Okay, thank you. So this concludes the morning session, so we can take a break for lunch. And then everyone, if you could come back by 12:45, we'll start our degenerative lumbar intervention sections.
Hello, everyone. Welcome back. I hope you had a good lunch. We have an exciting second half of our spine comprehensive course. This section is going to be on degenerative lumbar interventions. We're going to get started with Dr. Tina Rahman discussing operative and non-operative treatment of disc herniations.
Okay, good afternoon, guys. Thanks, Kola, for the introduction, Dr. Jegede for the introduction. Welcome to our course and thank you for attending. I'm going to talk about surgical and non-surgical treatment of lumbar disc herniations. So as we probably all know, one of the most common clinical diagnoses encountered in a spine surgery practice is lumbar disc herniations. And there's a 1 to 2% yearly incidence of symptomatic disc herniations, and this accounts for 200,000 lumbar microdiscectomies that are performed annually. And there still remains great variability in how patients respond to non-operative treatment, the timeline with which they respond, and the application of surgical criteria to this diagnosis. So I think even the most experienced spine surgeons see a case and often wonder, do I wait? Should I send them for therapy? Is this the time that maybe we should intervene surgically? So my attempt is to go through some of the data that supports the treatment algorithms and to talk about some of the gray areas as well. So we'll go through relevant anatomy of lumbar disc herniations, evaluation of the patient, both with regards to history and physical and imaging that's helpful. And we'll talk about non-surgical treatment options as well as surgical treatment options. So when we talk about the anatomy of the disc, there's essentially three components. The annulus fibrosus is put together in sort of a crisscross pattern that actually apparently car manufacturers try to mimic when they make tires, and it's 30 to 60 overlapping layers of type 1 collagen. Within this is the nucleus pulposus, which is a gel-like structure, provides resistance to axial compression, and sits within the annulus fibrosus. And then there are the end plates, which are lined by cartilage, and these are the cephalad and caudal end plates of the vertebra that are above and below the intervertebral disc. The intervertebral disc is the largest avascular structure in the body, so it does not have direct blood supply, which probably explains a lot of the pain and delayed healing associated with disc degeneration and disc herniations in particular. The disc does derive nutrition through diffusion across the end plates. The posterior longitudinal ligament, which is the dorsal aspect of the disc, is innervated by the sinovertebral nerve, which is thought to be one mediator of the low back pain component associated with lumbar disc herniation. So we commonly think of patients who have radiculopathy and pain and weakness related to the nerve root that's compressed, but they can also have back pain, and we believe that that's explained by this nerve that innervates the PLL. And when the PLL and the annulus, more importantly, when the annulus is ruptured, we think that can contribute to the low back pain. We like to talk about disc herniations in terms of whether they're contained or uncontained by the annulus. And we also look pretty specifically at the location, and I'll go through how, whether it's central or lateral recess, meaning a little off to the to the side of the thecal sac, and foraminal plays a role in what nerve root we think is compressed. But we use terms like protrusion, which refers to a focal bulging of the nuclear material still contained by the annulus, and that refers to a disc herniation where the base is wider medial lateral than the edges. Subannular extrusion refers to a disc herniation where the annulus remains intact, but the fragment has migrated either above or below, cephalad or caudal, to the disc and remains in continuity with the disc. So these descriptions come into play when we talk about outcomes, and we'll talk about that shortly. Transannular extrusion is a disc fragment that is ruptured through the annulus, so the annulus is no longer intact, and the fragment is migrated cephalad or caudal to the disc, but still remains in continuity with the disc. A sequestered disc herniation, you can see that in the bottom right image, is when the disc material has broken through the annulus, has migrated away from the disc space of origin, and is no longer in continuity. So these are the disc herniations that we probably are thinking about when we want repeat MRIs within a month or two before surgical intervention, because if you've gone 6 months since the last MRI, you don't know if a disc fragment has turned from a protruded disc fragment to something that's broken off and is now sequestered somewhere that you can't get to surgically and wouldn't be in the patient's best interest to try and get to surgically. So that category is something that we want to rule in or out on our preoperative imaging. We think that the nerve root in general, and we think this based on anatomic studies and physiologic studies that have been done both in vitro and in vivo, we think that the nerve root doesn't respond well to mechanical compression. It's not well insulated to compressive forces, and this is true not only of spinal nerves, but of peripheral nerves and nerves throughout our body. Nerve roots from the spine are tethered at their takeoff, so they don't have a lot of leeway as far as motion. Within the foramen where they exit, they also often have ligamentous and vascular attachments, which just render them relatively immobile, and they're not able to escape a compressive offending force. With chronic nerve compression, we know that there's reduced blood supply and nutrient delivery to the nerve. There are changes within the nerve as well, including intraneural edema and fibrosis. So these play a role in patients who have nerve compression for over a year, and perhaps you get an MRI and it shows a calcified disc fragment, and you're counseling the patient on outcomes after decompression. And it's important to say that it's maybe less predictable how the nerve is going to recover, because there may be intrinsic changes already that can't necessarily be addressed with the decompression alone. Studies have also shown that nerve roots that are perhaps already sensitized, so perhaps a patient who has baseline lateral recess stenosis or congenital stenosis from ligamentum flavum hypertrophy or a degenerated disc, maybe that nerve at baseline is somewhat sensitized to not having the blood supply and nutrient supply that a normal nerve root would. So these nerves may be at greater risk if a patient gets a second hit with the disc herniation than someone who had a completely normal nerve root before that event. We also know that it's not only the mechanical compression that affects the nerve, but also the inflammatory cascade that's triggered by nerve compression and disc herniation. So the nucleus pulposus, when it has a change, such as a herniation, or it shifts or bulges, it does release molecules, including TNF-alpha and interleukins, and all of these kind of spur on more of an inflammatory cascade that ends up irritating the nerve root. So it's both the mechanical compression as well as the inflammatory component that probably leads to the symptoms. So important points in history taking, even before you get imaging and a patient comes in with some sort of leg or back pain and describes some neurologic symptoms, you want to inquire about history of urinary or fecal incontinence, saddle anesthesia, any past history of or an ongoing malignant process, and that includes treatment that they've had for it or treatment that they're currently undergoing. Inflammatory conditions, lupus, ankylosing spondylitis, any history of infections throughout the body, and in particular systemic infections. You want to find out if they're immunosuppressed for any reason, and all of this is to understand, is there some mass effect in the thecal sac or mass effect on the nerve that may be more than disc herniation that maybe you can anticipate before you order the MRI and bump up the urgency of it. And if you're really concerned, send the patient to an ER to be evaluated. And you also want to inquire about drug use, and that goes along with the idea of some mass occupying lesion that could be compressing a nerve root or the thecal sac. In terms of physical exam, so obviously you want to do a thorough physical exam looking at any weakness or sensory deficits related to a specific nerve root distribution. We talk about the straight leg raise and crossed straight leg raise test. Straight leg raise is performed with the patient lying supine, and they extend the leg so the knee is locked and you lift up the leg by the ankle. And we consider the test positive when at 30 to 60 degrees of hip flexion, they have reproduction of the same symptoms in that ipsilateral leg. So it shouldn't be back pain or different symptoms. It should be the same radiating pain that they feel, that they associate with whatever this may be, a disc herniation or compression in general. Crossed straight leg raise is the same, except it's the contralateral leg that's tested. I think going through all of the dermatomes is probably a different exercise, but just to give a quick example, L4, L5, if you had a paracentral disc herniation, so central, but perhaps a little off to the side, it's the traversing nerve root that would be affected. So at L4, 5, that would be the L5 nerve root, and the patient should or would have symptoms of an L5 radiculopathy. In the case of L5, which is something that we see commonly, that would be pain perhaps over the sacroiliac joint, radiating over the lateral aspect of the thigh, lateral aspect of the leg, and usually the medial dorsal aspect of the foot, so maybe the first 3 toes. And they might also have weakness in dorsiflexion of the great toe and the ankle, and usually reflexes are not significantly affected with an L5 radiculopathy. I just touched on L5, but important always to review all the dermatomal distributions of the nerves and have a sense of that when you see a patient who could potentially have a radiculopathy. In terms of imaging, lumbar radiographs are always the best first option when we go back to other things on the differential before you get your MRI. And as you start to counsel a patient before you see them again with advanced imaging, you can pick up on things like infection, malignancy, sclerotic lesions, lytic lesions, alignment, in particular instability that may relate to the nerve that you think may be affected. So I think lumbar radiographs are always the first step, and they usually should be obtained when you see the patient the first time or relatively soon after. MRI is the gold standard study for confirming a lumbar disc herniation with a diagnostic accuracy of 97%. And then there are patients with older pacemakers or vagal nerve stimulators for whom you have to get a CT myelogram. And those are also strong imaging. It's a strong imaging modality to visualize a herniated disc. And you or the radiologist performing the procedure should counsel the patient. There may be risks like a post-spinal headache, meningeal infection, which is extremely rare, but you just let them know. But sometimes that's the only study that they can get. In terms of epidemiology, 10% of all episodes of low back pain are associated with radiculopathy. The at-risk group is individuals between 45 and 65 years of age, males more commonly. Risk factors are a little soft. We see patients with a wide range of risk factors, but what's been shown in the literature is perhaps a sedentary lifestyle, history of heavy lifting, maybe a D1 football player who took a lot of hits or a lacrosse player, pregnancy, and current smoking. The natural history. So when we see these patients, we do know that symptoms commonly improve without therapeutic intervention, and I mainly mean surgical intervention. So large studies have shown that at 6 weeks, 80% of patients are improved, at 12 weeks, 90%, and at 6 months, about 93% of patients are improved. What does improved mean though? So patients are improved in terms of their sensory and motor deficit in terms of their pain, but at the same time at 1 year, that all of these patients included 30% of patients with any history of a disc herniation and a radiculopathy continue to have pain and continue to often employ work restrictions. So these are patients who did not undergo surgery. So we know that patients, for the most part, improve, but we always talk about what is the real clinical benefit. And at 1 year, 30% of patients are still dealing with some of the after effects. We know that these disc herniations do regress with time. So at 1 year, 80% of patients we see with disc herniations have a reduction in the size by at least 50%, and the disc material is resorbed. And we know that if we see an MRI where there is resorption of the disc fragment, that tends to correlate well with symptom improvement and a good prognosis for recovery without surgery. Indications for non-operative treatment include absence of a neurologic deficit. It's the default pathway for most patients. And there are really no good randomized controlled studies examining the efficacy of non-operative treatment. So what is accepted is that a course of non-operative treatment is certainly recommended for anywhere between 6 weeks and 3 months, but there's no specific data supporting what non-operative treatment may work best. So physical therapy, medications, traction, manipulation, immobilization, which is essentially bed rest, and injections have all been looked at. We'll go through what the data is for those. Predictors of potentially favorable outcome with non-operative treatment include on exam, not having a positive straight leg raise test, not having a non-contained disc herniation on imaging, absence of central stenosis. If a patient responds well early to steroids, so you give them a prednisone or a Medrol dose pack and they respond well, that tends to prognosticate well for them. If their neurologic deficit resolves by 12 weeks, that's a good predictor that perhaps they don't need surgery. And greater than 12 years of education and a non-workers' comp patient tend to correlate well with improvement and resolution of symptoms without surgery. And just to run through what we know about medical management, NSAIDs have been shown to be helpful for low back pain, but no evidence supports their treatment in radiculopathy. I think we know that patients feel better, but I just want to highlight that there's no large study that's really shown improved patient outcomes, whether you prescribe an NSAID or not. Steroids may be helpful for patients who have a positive straight leg raise test, and I think this just accounts for these patients have more symptoms probably because of more compression and the nerve has more tension at baseline. So the steroids tend to work a little better for them. No benefit seen from opioids in this setting. Muscle relaxants have shown to be effective for acute low back pain, but not for radiculopathy. And no study has shown that symptoms related to radiculopathy improve with gabapentin or TCAs like amitriptyline. Immobilization, we talked about maybe, bed rest, braces or corsets. I think we really never want to prescribe bed rest for a patient because it leads to a lot of other types of decline, but there's no literature to support it anyway in this setting. A Cochrane review from somewhat long time ago showed that traction was ineffective. There hasn't really been a study looking at it since then. And we don't really know that patients improve with physical therapy or McKenzie, although we prescribe it. And there's actually a few studies that show that patients who perhaps simply just continue activities of daily living, short walks a few times a day, may do just as well as patients with physical therapy prescriptions who undergo 3 months. So I think it should be part of the algorithm. Not all patients will stay active. Physical therapy is a reminder for them to do so. But I just want to highlight again that there's no study that really shows that it makes a difference. There's also been no study showing the efficacy of acupuncture. Epidural steroid injections have been found to be more beneficial than the control, which is not receiving an injection. Over a 3-month time period, patients' outcomes are a little better, not in the long term. So at a year, it doesn't seem to matter whether you had an epidural steroid injection or not. If you didn't undergo surgery, you're no different at a year. Interlaminar epidural steroid injections seem to not work as well as a transforaminal, and there are more studies that support that a transforaminal epidural steroid injection leads to less pain and improved resolution of the motor deficit at 3 months compared to an interlaminar. So something to share with the pain management physician that you send a patient to. And I think most of us look to them for transforaminals anyway in this setting. Presumably there's just more direct delivery of the steroid and the lidocaine to the nerve root with a transforaminal. In terms of surgical management, patients who have extruded disc fragments with an intact annulus and those who have extruded fragments, same group, patients who have an extruded disc fragment with an intact annulus had the best postoperative outcome scores. Patients who had a massive annular tear or patients who had an intact annulus and no identifiable fragment intraoperatively have the poorest outcome scores at 3 months, 6 months, and a year. Intervention for herniations at 2, 3, and 3, 4 demonstrate the greatest clinical improvement. Probably these nerves have even less mobility than the lower lumbar nerves, and so releasing the mass effect on these nerves gives greater yield to the patient. Other variables predicting lower outcome scores after surgical management include a patient's self-reported poor health preoperatively, work and disability status preoperatively. So if they're not working, and particularly if they are enrolled with disability, their body mass index and smoking. I didn't find a great cutoff for body mass index, so I didn't include it here, but higher body mass index is correlated with poorer outcomes after microdiscectomy or open discectomy or any sort of intervention for a disc herniation. A few studies also support evaluating a patient for psychological distress or depression prior to surgery, as this may also affect their outcomes and they may need to be counseled as such. I didn't go too much into surgical techniques because I know we have a wide audience today, but what I did want to highlight is that there's really no difference in outcomes in the technique the root was decompressed, at least in the current literature. And I'm sure there's going to be more literature coming up for MIS and tubes and open and microdisc, and a lot of new techniques are still evolving. So in terms of what's out there, as long as the root is decompressed, it seems like the outcomes are equivalent. And there's no benefit to doing a less aggressive disc removal. So if you go in and you do an annulotomy and you just take a little bit versus really exploring that annular tear and taking out whatever seems loose, there seems to be no difference in recurrence rates. Obviously, these technical studies are always a little murky because you can't always quantify and clarify the technique used, but these are kind of the broad strokes of the technique used. And just comparing surgical versus non-surgical management. Earlier surgery within 6 months to a year is associated with faster recovery, improved long-term outcomes. Patients who had less than 6 months of symptoms before you intervene surgically had greater improvement in SF-36 scores and ODI scores as well, compared with those who had over 6 months of symptoms before they underwent the discectomy. Surgical decompression has better results in the 1 to 4 year follow-up. This is from the SPORT trial, and that's compared with patients who didn't undergo surgery, and that's assuming both herniations had severe and equal symptoms prior to whichever intervention they underwent. So at 2 years, patients who elected surgery had better improvement in pain, physical function, ODI scores compared to those who didn't undergo surgery, and we saw those same trends and significant differences at 4 and 8 years. So the take-homes are earlier intervention within 6 months tends to give you better outcomes after surgery, and it seems as if all things being equal, surgery versus non-surgery at 1, 2, 4, and 8 years, the patients who undergo surgery seem to have less pain related to that initial issue that they had. Briefly on cost effectiveness, average total cost, surgical patient, $27,000, non-surgical, $13,000. The QALYs at 2 years, so this is using outcome scores and looking at 2 year costs. For surgery is $69,000 non-Medicare, $34,000 Medicare. And at 4 years, this drops down to $20,600. To give you some sense of where this falls, anything under $35,000, $35,000 to $50,000 using the Medicare schedule is considered highly cost effective. So at 2 years, a discectomy using the Medicare data, which is what we tend to look at, is highly cost effective. And that cost effectiveness increases as time goes on and patients' symptom, their quality of life improves, and the costs drop to almost nothing because we often don't see them in follow-up past a couple of years. Unplanned reoperation, so the rate of reherniation is 3 to 18%, and this is after undergoing intervention for a microdiscectomy. The SPORT study looked at 810 patients at 8 year follow-up. They found a 15% rate of reherniation, so a little on the higher end of that range. Most experience the reherniation within 1 year of the index surgery, so about 40%. We talk about that 3-month window after surgery as the most at risk, but clearly even up until 1 year, you still have a 40% chance of incurring a reherniation. So still good to counsel patients to be careful. Of those patients, though, only 9% had to go back for surgery. So I think, again, another point to tell patients, just because they have a recurrence of symptoms and maybe an MRI shows a reherniation, they could still undergo conservative management. And there's a good chance that perhaps the symptoms improve and only a 9% chance that they'll have to go back for surgery. Okay, so in summary, disc herniations usually have a favorable natural history over time, but it may take 1 to 2 years to see that full improvement in a patient that perhaps you're treating non-operatively. The best indication for surgical management is radicular pain that is unrelenting and the patient's miserable and you've tried everything and it really doesn't work. And when that is the indication, surgery tends to produce better outcomes, more rapid pain relief than not performing surgery. 6 months seems to be the good window to intervene if you're going to intervene. And finally, the technique that's used to decompress the disc, the nerve root, seems to have little to do with the overall success of the procedure. Thank you, and we can move on to questions if there are any.
Thank you, Dr. Rahman, for that wonderful evidence-based talk. So we're going to save the questions to the end.
Okay.
We actually have a few from the audience. That was great. So again, just to remind the audience, you can ask any of the questions through the app, and we will go through them at the end of the session. And so we're going to move on to our next talk in this session, which is the evaluation and treatment of spinal stenosis. This talk will be given to us by Dr. Jeffrey Goldstein.
Thank you, Kolawole. Are my slides up? There we go. Thanks, everybody, for joining us today. The lumbar spinal stenosis and lumbar disc herniations are the two most common compressive pathologies that we see in the lumbar spine. And there'll be some overlap between the talk given by Dr. Rahman and myself, so I'll try not to be too repetitive. We'll start off by going over some nomenclature, the pathoanatomy, the natural history and treatment, both non-surgical and surgical treatment, and then summarize. So 80% of the population will experience episodic low back pain throughout their life. Most of these patients, as you all know, will respond to non-operative treatments and get good resolution just with rest and time. But the annual cost of low back pain in the United States is well over $100 billion. The most common source of low back pain in our population is degenerative disc disease and lumbar disc herniation, as well as spinal stenosis. Dr. Rahman covered this in her talk. As we know, the annulus fibrosis is type 1 collagen, and that contains the nucleus. The nucleus pulposus is type 2 collagen and contains proteoglycans, and these proteoglycans will facilitate water retention and also provide hydrostatic pressure to resist the axial compression of the spine. So what happens over time with reduced water content of the nucleus and degeneration, you have an increase in type 1 collagen within the nucleus and also the inner annulus. And this leads to collagen degradation and upregulation of degradation over time. We found that there's a genetic predisposition. Many of our patients will say, geez, my father, brother had the same problem. And this genetic predisposition over time leads to dehydration and axial overloading of the spine. So lumbar spinal stenosis is, as I mentioned, one of the two most common compressive pathologies we see in the lumbar spine. I generally will tell my patients that a lumbar disc herniation is a young person's problem. I mean, there's many times you'll have patients come to your office who are in their 20s and 30s and say, well, I'm too young to have this problem. But we see different problems in different segments of our population. Lumbar disc herniation is certainly much more common than spinal stenosis in our younger patients. So lumbar spinal stenosis is a progression which implies narrowing of the spinal canal. Remember that the spinal cord stops at the upper lumbar spine after the level of the conus branches off into the cauda equina. And so you see in the sagittal MRI, the nerves of the cauda equina and the sac. In this patient, you see neurologic compression that's caused by a lumbar disc herniation, as well as hypertrophy of the ligamentum flavum and posterior compression. And this is the most common reason for lumbar spine surgery in my practice in patients who are over 65. Lumbar spinal stenosis can often be associated with a degenerative spondylolisthesis and degenerative scoliosis. So looking at this is really a continuum of degeneration. We start off with disc degeneration, which I tell my patients really is from the onset, from the time we're born to the time we die, the disc will degenerate. And as I mentioned, the discs in the lower back will lose water content, and they ultimately will lose height, and they'll collapse, and that increases pressure on the facet joints. Ultimately, you get arthritis of the facet joints, which increases pressure on the joint and the nerve that passes through the joint. This leads to an abnormal motion of the disc space, and you can get bony spurring, which is another contributor of spinal stenosis. Spinal stenosis is really a multifactorial disease, which is a combination of disc protrusions, disc herniations, osteophytes, bone spurs, hypertrophic ligamentum flavum. There are some patients who have congenital spinal stenosis, which means they have congenital foreshortening of the pedicles and a small spinal canal. So you can imagine how the addition of these arthritic joints, disc degeneration, and disc herniations can further compromise an already susceptible spine with congenital stenosis. Ultimately, this leads to compression and less blood supply in the area. And when the nerves get compressed and have vascular insufficiency, you can get pain in the lower limbs. And this pain is classically induced by walking. The clinical presentation is often non-specific. The most common thing I'll see in my patients is they'll complain of difficulty walking and stand in a forward stoop position. And this allows them some potentially increased room within the spinal canal to alleviate some of the pressure on the nerve roots. But as opposed to what Dr. Rahman was mentioning about radicular and dermatomal distribution of pain, we see this less often than in patients with lumbar disc herniations. So as I mentioned, it's a degenerative process that begins in the disc. The cells, water and proteoglycans diminish. The nucleus degenerates and ultimately leads to diminished disc height. You have bulging and buckling of the annulus, and this abnormal load transfer to the posterior elements puts increased stress on the facet joints and can cause some degeneration of the facet joints and potentially a spondylolisthesis, which is a shifting of the spine or at the disc space. Ultimately, from the osteophytes that you can see here, the ligamentum flavum hypertrophy, which is posteriorly, disc protrusions and herniations protruding through the annulus. Each of these can contribute to compression on the nerves and the elements as they exit exit the spinal canal. So I talked about the patients presenting stooping forward. We call this classically a shopping cart sign. Many patients will come in, and you'll see in your office, in your clinics, that patients say, well, I feel better when I'm walking through the grocery store. And classically, they'll have symptoms where there's bending forward, that pain is relieved with forward flexion. This can actually diminish the disc pressure by greater than 100 to 400%. We also talk about the bicycle test. Your patients who have one of your differential in patients with neurogenic claudication is vascular claudication. Patients who have neurogenic claudication will classically have pain when they walk, get relief when they sit down. Patients on a bicycle test, patients with spinal stenosis feel good on a bicycle. They can forward flex, and patients with vascular claudication will find that their legs give out and they have pain on the bicycle. Generally, we find this is something we see in our older age patients, and it's really an insidious onset. Imaging, as was mentioned in the previous talk, we generally start off with our x-rays. The reason we get x-rays is primarily because we're orthopedists, but also we don't want to miss instability. And this is a patient who has a mobile spondylolisthesis at L4-5. You can see in forward flexion, the spondylolisthesis is exacerbated and reduced somewhat in extension. And this is because you have diminished integrity of the facet joint. Here's increased T2 signal within the facet joint, and that comes from degradation. This patient actually has a synovial cyst, and also a sign of instability in the facet joint. And you can see how this cyst is compressing the nerves within the cauda equina in the lateral recess. You can see it also on the sagittal view. So the cyst is another source of compression. So what about treatment? Generally, we separate our non-operative treatment most commonly into three categories: pharmaceutical treatment, medications, physical therapy, and epidural injections. Well, I tell my patients that we generally will try these things for symptomatic treatment. Ultimately, we don't treat X-rays, we don't treat MRIs, we treat patients. And if patient symptoms will improve with non-operative treatment, then that's great. That's our goal. We know from our long-term studies that it doesn't really change the natural history, but we'll try it even without necessarily great evidence to try to relieve patient symptoms. And some patients will find that it takes the edge off and is really able to help them long-term. So I use each of these treatments, medications, generally anti-inflammatories, physical therapy, and epidural injections for just about all of my patients who present with lumbar spinal stenosis. And they do, and many find good relief from it. So at least for the short term. What about surgical decompression? Surgical treatment. Just like disc herniations, the goal of surgery is to decompress the neural elements. The common procedure for this is a laminectomy or a spinal decompression. And this generally includes decompressing all of the things that we spoke about as compressing. We'll do partial facetectomies, take off part of the overgrown facet. And this is done with a direct decompression. Typically, if a patient has a broad-based disc protrusion, we don't need to violate the disc because that can unnecessarily increase the degradation of the disc and lead to further disc-based degeneration over time. We can do this directly. There are also other procedures that we can add interspinous spacers without entering the spinal canal. And instrumentation for spinal fusion is generally for patients who have a unstable spondylolisthesis or deformities, including scoliosis. This is a patient who's undergoing surgery. A patient has a apian lateral view. There is no spondylolisthesis at L4-5, which is the most common level of the spondylolisthesis. You can see on the sagittal view, there's compression at L4-5 and spinal stenosis. And this patient had flexion extension X-rays, which actually do show an instability at L4-5. And this is why it's really important to have X-rays, especially prior to going to surgery, because this is a patient who, in addition to a decompression of the lateral recess, where we remove this part of the facet, will excise the synovial cyst and make more room for the neural elements. That patient would also have a fusion. And let's talk about fusion. This is a difficult slide to read, but these are two commonly cited studies which look at similar patient populations. This is the Swedish spine study and the SLIP study. And as many things in what we do, patients, we have similar groups of, similar cohorts of patients and similar treatment, but two different findings. This compared the results of adding fusion for a patient with spinal stenosis and spondylolisthesis. And the Swedish study found no additional benefit of fusion or added instrumentation to the spine, whereas the SLIP study did show improvements in ODI and better outcomes for patients who did have a spinal fusion for spondylolisthesis. Many of us, especially with an unstable spondylolisthesis, will include spinal fusion because we know that through the SPORT study, which also showed improvement long-term for a one-level spinal fusion with addition of instrumentation and fusion for spondylolisthesis, that patients do better long-term. If patients have recurrent spinal stenosis and instability, doing a revision operation is not as good as doing the right operation the first time. So if a patient like that, we will include decompression and instrumented spinal fusion. Today, we can also do these fusions with robotic assist through a less invasive approach. And this is something we've been doing for several years now at NYU Langone. The other treatment options for lumbar spinal stenosis include interspinous spacers. This allows an indirect decompression by opening up the neuroforamen in the area for the cauda equina by distracting the spinous processes and doing a limited decompression. So in summary, for symptomatic treatment of lumbar spinal stenosis, this generally includes over-the-counter meds, physical therapy, and epidural injections. This treatment is Surgical treatment is effective in patients, like most spinal patients, who have concordant symptoms, physical examination, and imaging. Decompressive surgery alone for patients with spinal stenosis without instability is very effective, and fusion for patients with instability is also very effective. Minimally invasive surgery is something we try to achieve in our practices, but I generally tell my patients that minimally invasive surgery needs to be maximally effective, or patients are minimally understanding. So having said that, I want to thank you all for your time and move on to our next talk. Thank you.
Thank you very much, Dr. Goldstein, for that great and informative talk. So keep the questions coming. We see the ones that have come through so far, and we're gonna go to the last talk of this section, which is gonna be given by Dr. Charla Fischer. She's gonna talk to us about spinal fusion, when and how we fuse.
Okay, great. Thank you. So I'm going to be focusing on the lumbar spine, when and how we fuse. And we've had some really excellent talks on different surgical indications. So I'm going to just quickly go through a few of the indications, and I'll get into the surgical technique a little bit more in depth. So one that has been reviewed previously is lumbar spondylolisthesis. And, this is due to degeneration of the joint or a Parge defect leading to instability and slip. A little more common in women, and it can be due to either a defect in the pars, most often congenital, related to something that patient was born with, or you can have advanced degeneration of the facet joint and disc space. Patients have a lot of back pain, worse with transitions, and they get a lot of pain radiating into the legs, either radicular pain from pinched nerves at the level being tight, or you can get central stenosis. And we try to treat it conservatively, but if that doesn't work, in 10 to 15% of patients, conservative management will not be helpful. So that's when we start to think about surgery. Absolute indications include progressive weakness or cauda equina syndrome. And a lot of the reasons why patients decide to proceed with surgery is related to the leg pain. Many patients can deal with the back pain, but the leg pain is significant. And so then we can see the radiographic instability. Another reason for lumbar fusion would be degenerative disc disease. This presents a significant back pain as the disc space starts to degenerate and the facet joints wear down. You can start to get collapse of the neuroforamen, as well as osteophytes starting to crowd the neuroforamen, and that can lead to some radicular or claudogenic type pain. Again, we refer patients for conservative treatment. But if that isn't helpful in the long run, then we can consider surgery. So indications for fusion include intractable back pain when conservative measures fail. And does this lead to functional recovery is a really important question. So you want to talk to patients about their goals. If they want to walk more and play with their grandchildren, that's great. If they think that they're going to get back to playing basketball with their friends, on the weekends, that may not be as realistic a goal. So we want to make sure our goals are maintained. And then another reason for fusion is a lumbar disc herniation, and Dr. Rahman went over this very much in depth. So I'll just quickly go to some of the indications for fusion when you have a disc herniation, because most of the time we're treating this with a microdiscectomy. So if you have a recurrent disc herniation, you may consider a fusion. So some patients will have 1 or 2 microdiscectomies, and then if they keep herniating the third time, you may consider a fusion because that disc has proven itself to be incompetent. It's just not doing what it's supposed to do. It's not holding in the nucleus pulposus, and you want to prevent further surgery, further disc herniation, so you do a fusion. The other instance in which you might consider doing a fusion is if you have a foraminal disc herniation that's partially calcified. So the location of the herniation makes it such that you have to take a lot of the facet joint off. And so if you take more than 50% of the facet joint, you're destabilizing that joint in that area, and they would be at risk for further pain and instability. So you want to take a look at where's the disc herniation and if it's really calcified. If it's really calcified, then there may not be a discrete piece that you can pull out to help alleviate the leg pain. And you may need to take the whole back wall of the neuroforamen off by doing a complete radical facetectomy in order to make more room for the nerve root and alleviate the symptoms. So I'm going to go over some fusion techniques. And the first is a posterior interbody fusion. So you may so this is doing surgery all from the posterior approach, including removing the disc and putting a spacer in there. You may want to need to do this for reducing a spondylolisthesis. There may be a small posterolateral fusions bed, so you may consider doing an interbody fusion to help augment that. You may need to jack open the disc space to reopen the neuroforamen. So if you have a lot of degeneration and a lot of stenosis, both due to up-down stenosis as well as osteophytes crowding the neuroforamen, you may want to consider doing an interbody fusion of some kind. If they have significant neurologic symptoms and radiculopathy, and you really want to completely unroof that foramen and do a facetectomy, or if you have a herniated disc in a setting of spondylolisthesis that really needs to be opened up. So there's many different approaches. So this is why I say a posterior interbody fusion. So there's the TLIF, which is the transforaminal lumbar interbody fusion, and then there's PLIF, the posterior lumbar interbody fusion. The TLIF involves removing the facet joint completely. The PLIF involves doing a laminectomy and going in more directly posteriorly. So they're a little bit different, but they get to the disc space from a posterior approach. And then you can do these surgeries either open, traditional open, or through using minimally invasive techniques such as a tube retractor or a small midline incision. But both techniques involve removing the disc, putting bone and a spacer into disc space, and stabilizing with pedicle screws. So the posterior interbody fusion has really good outcomes. If you have a spondylolisthesis with a lot of back and leg pain, you're going to have 85% improvement in symptoms. Again, not 100%, but you're going to have a much more functional and a much less painful patient, or a patient in much less pain. They may still be painful. Complications related to a posterior interbody fusion, you may get some sort of neuropraxia, meaning tension on the nerve root leading to a neurologic deficit. And this is very rare. And if you do have it, it's very rare that it lasts more than 4 months. Only 4% of these last more than 4 months. You may get an incidental durotomy, about 4% per level. And these really are treated in the hospital and don't have any long-term consequences. There's a low rate of infections, hematoma. You may have some sort of irritation of the GI tract just due to the opioid use afterwards. And then very, very rarely, if you can get irritation of dorsal root ganglion in the foramen in that area, and that can lead to a complex regional pain syndrome. So I'm a big fan of minimally invasive techniques, particularly a minimally invasive tubular TLIF. But again, there's lots of ways of doing this surgery. So you can do a tubular TLIF, you can do with percutaneous pedicle screws, you can do a pedicle-based retractor, you can do a midline PLIF with traditional exposure, or a mini open procedure where you're using a cortical screw trajectory. So it's important to remember that we're still taking the disc out and we're still doing a fusion through that disc space. So the pedicle screws can be placed paramedian approach, where you're directly looking at it freehand. You can do X-ray guidance, you can do navigation assisted, and you can do robotic assisted. So there's lots of ways of placing minimally invasive pedicle screws. Additionally, if you're doing a midline approach, instead of dissecting laterally where there are a lot of pain generators, you can stay medial and do cortical screws. And these are done either under X-ray or with a robotic assistant. And then based off of how you're doing your approach, if you do a TLIF, you can use either a tubular retractor or a pedicle-based retractor. Here is shown a pedicle-based retractor, and you can see that you're still having a very minimum muscle disruption. And then this is the view through a tubular retractor. And so you don't need, and I do a lot of training of fellows as well as other surgeons trying to go from open to minimally invasive. And once they see that you don't need to see everything, you just need to see certain structures, they become really big fans of this a tubular retractor. And then here's another view of the midline laminectomy with cortical screw placement. And then and this is just showing that you can do bilateral small cages as opposed to one sort of larger midline cage. Next, I'm going to talk about anterior lumbar interbody fusion. And same indications as a posterior fusion. You may want to consider an anterior interbody fusion if there's been prior posterior surgery, such as a laminectomy or significant scarring, either related to prior surgery or infection or other instances in where you would get some epidural scarring. And so you don't want to really tug on those nerve roots from the back, but you want to sort of indirectly fuse from the front or directly fuse from the front. So the technique is the anterior approach is a lot of us use a vascular surgeon to do the retroperitoneal exposure. And once you get to the anterior aspect of the disc, you're looking directly at your disc space. And so you just incise the disc and remove, curette the end plates, do a careful discectomy, make sure you expose enough of the end plates so that you can get posterior and get lateral enough to put in a large cage, enough to fill the entire disc space. And then you can secure with a screw through the cage or put a plate and screw on front to sort of buttress it and prevent it from coming out. And so previously there was a lot of discussion about comparing ALIF or anterior fusion to posterior fusion. And there's been some systematic reviews that show that there's really no difference between an ALIF and posterior instrumentation compared to a posterolateral fusion and interbody. So it turns out that if you're doing screws and rods and something in the disc space to get a fusion across there, you're going to have good outcomes with your patients. Another question that some patients ask is, if you're going in through the front, why do you need to go in through the back? And prior instrumentation techniques were much better when you went in through the front and also augmented in the back with screws and rods to provide the maximal stability. There are some more recent designs that allow for increased stability through the ALIF only. And a lot of patients were doing a direct facet fusion in the back. And so we want to use that as an additional surface area to get a really solid fusion through the inner body and the facet joints sort of as a posterolateral fusion. So in those cases, it may be better to augment with some screws and rods to stabilize posteriorly. But there are some surgeons out there who do a standalone anterior lumbar interbodies. Complications associated with anterior lumbar interbody fusion relate to the approach. So we have to gently retract the vessels to get to the front of the spine. And so there's a small rate of vascular injury. And then there's a small rate of DVT. So a lot of patients who undergo ALIF, we recommend starting on Lovenox post-op day 1 to prevent this a DVT, since we are manipulating the great vessel, the larger vessels. There is the pre-aortic sympathetic plexus, and so in some men, you can get a development of retrograde ejaculation. You can see that the rate is very, very small. It does not lead to sexual dysfunction. It can lead to infertility because basically the sperm are going into the bladder as opposed to out, and so then you can get some low rates of infertility. So if you have a young man, this is some who may want to have children. Actually, I've had older patients, 60-year-old men who don't like the idea of infertility. So this is just a conversation that is worth having with patients. And then again, going in through the front, you may feel the patients may have a little more GI upset and then are at higher risk for a full-on ileus, their whole GI tract just shutting down, which is quite miserable for them. So just things to talk to patients about to go over the risks and benefits of going in through the front. And then finally, I'm going to talk about lateral interbody fusion. And so similar indications for posterior and ALIF, degenerative disc disease, spondylolisthesis. This technique really sort of took off with the using this for coronal correction, as well as some sagittal plane correction for degenerative scoliosis. And so this can apply to the lumbar segments above L5S1. Why not L5S1? Because the ilium is usually in the way. And these are called X lifts, D lifts, and L lifts. So this is really great for coronal plane alignment, as well as with the advent of more lordotic cage and expandable lordotic cages, we can get really good sagittal plane reconstruction. And then the levels above L5S1 are accessible. Based off of the patient's anatomy, you may be able to do the 4 or 5 level, but it's really important to check and see where those nerve roots are. If they're being pulled very anteriorly, then they may not be a good candidate for a lateral at L4-5. So, you know, some of the surgeons who have done a lot of these procedures have been looking at complications. Basically, it's a very safe procedure. The biggest complaint patients have with this is some sort of side pain, as well as that can radiate down the psoas into the lateral aspect of the thigh. So they may have some sort of, side area pain related to the approach. But true complications are very, very limited. Again, on the MRI preoperatively, you want to make sure you evaluate the locations of the vessels, the bowel, the kidneys, and the liver, and then the location of the psoas as it relates to the exiting nerve roots to make sure it's not too anterior, already putting tension on the nerves at those levels. The technique is done with using free running EMG and checking the location of the nerves. And so if you have a nerve response at a low level of stimulation, then you're probably pretty close to a nerve and need to do some work to move that nerve away, or maybe consider a different approach. This is the view for the lateral interbody fusion. So we're looking directly at the disc space through the side. And then a lot of the technique is really done through X-ray and indirect visualization. Nowadays, with the robotic and navigation, we can directly navigate. So using image guidance, we can directly navigate these screws and minimize intraoperative X-ray use. So this is kind of just a merging of different minimally invasive technologies. We can see here the significant amount of coronal plane improvement, realignment, as well as through a lateral, as well as doing an MIST lift from the back, and really trying to minimize the number of fusion levels to allow for a good curve correction in these degenerative scoliosis cases. So in summary, indications for lumbar fusion include spondylolisthesis, degenerative disc disease, scoliosis, and foraminal disc herniation. And our techniques include posterior lateral fusion, posterior inner body, open or MIS, anterior inner body, and lateral inner body. Thank you.
Thank you very much, Dr. Fischer, for that thorough review of when we fuse in lumbar degenerative situations. So we're going to quickly go through questions with our panelists, Dr. Rahman, Dr. Goldstein, and Dr. Fischer, and then we'll move on to our next session, spinal tumor. So first question was, what is the role of topical NSAIDs in the management of disc disease back pain? No problem.
So yeah, I can respond to that. In terms of degenerative disc disease, topical NSAIDs in my practice have not found them to be extremely effective, and that's due to the location of the pain generators. So if you have a lot of degenerative arthritis in the facet joints or the disc base, it's a little too deep to really be affected by topical NSAIDs. That being said, patients with a lot of paraspinal muscle pain can sometimes report improvement with some topical NSAIDs. So depending on what you're treating, if you're trying to get to the real degenerative areas in a degenerative disc disease, probably not going to be effective. But if those degenerative areas are referring pain to the muscles and the patient has a lot of muscle pain and spasm, then you could have some improvement with that.
Perfect. Next question, please explore the role of chiropractic intervention in acute herniated disc treatment.
This is Tina Rahman. I didn't have that in my slides. There are studies that have shown some benefit of chiropractic treatment, specifically, I guess they call it SMT, some sort of spinal manipulation treatment, but those are from journals of chiropractic medicine. So I'm not entirely sure about the terminology and the methodology. There was one study from the European Spine Journal that showed that chiropractic treatment at least didn't seem to have any effect on the outcome and didn't lead to adverse risk. So I would say that the data is still out on whether or not it improves symptoms or has a role, but maybe providers can at least be assured that it doesn't seem to confer additional neurologic risk or risk that the symptoms could progress due to that treatment.
Thank you, Dr. Rahman. And can there be a loss of knee reflex after decompression surgery?
I think there can be a loss of the knee reflex prior to the decompressive surgery. Reflex changes aren't something that, there's sort of plus minus on patients with spinal stenosis. And, quite frankly, are more helpful when I see patients who have spinal stenosis and I'm concerned about a concurrent cervical stenosis and myelopathy when they're hyperreflexic. So I become less concerned about a patient with a diminished reflex and spinal stenosis than I am about a hyperreflexive patient.
All right. Thank you very much, guys. There are more questions, but we're going to keep it moving. It was an excellent session talking about lumbar degenerative interventions. Thank you guys again. So we're going to move on to the next session, which is primary spinal tumors. And Dr. Frempong-Boadu will be giving us the first talk in this session.
Okay, everyone hear me well? All right, so I was asked to give a talk about intermedullary spinal cord tumors in the tumor section. To kind of move it on, we'll do intermedullary first, and then the next talk will be on metastatic and spinal column tumors. So just in the, let's see, I'm not advancing. Here we go. Just in the time, we'll kind of move through these 5 areas and really just introduce the topic and talk about the common tumors, indications, a little bit about the surgical management of it. So they're very uncommon entities. Only about 5% of spinal tumors. So there's only about 1,000 to 2,000 every year in North America. And generally, most neurosurgeons would only see, 1 tumor for every 2 to 3 neurosurgeons. So it's not common at all. The clinical presentation is really related to the location of most tumors, and most of them are centrally located. They invade, they destroy white matter, they destroy the tracts, and they destroy gray matter. So the most common initial presentation, depending on the location, will be neck or back pain. That's worse with Valsalva. You'll have nocturnal recumbency pain. That's very suggestive of intermedullary spinal cord tumors. So if you have a child and they say they have pain when they're sleeping, it's something you should really think about. Medullary pain is very common, very similar to symptoms like a syringomyelia, where you have burning, dysaesthetic, non-radicular pains, often bilateral, and that pain is not necessarily affected by Valsalva. So the presentation, you have sensory disturbances, which are non-painful, and you get what we call syringomyelic syndrome type pain. So you have dissociated sensory loss, so pain and temperature dissociated. You have preservation of light touch. People complain of having a cape-like sensation of reduction in symptoms. The paresthesias can be either radicular, depending on the location of the tumor, or medullary, like we described above with syringomyelic syndrome. The presentation, motor symptoms are usually preceded by sensory complaints. You have all those sensory complaints I just talked about long before you get motor symptoms. Children will often present with gait disturbances, and adults will present with long track signs. So they'll present with clumsiness, ataxia, and it's oftentimes confused with run-of-the-mill cervical degenerative disease, as we talked about earlier. Depending on the location, you'll either get cervical myelopathy or you get thoracic myelopathy, and so you'll either have upper extremity symptoms and hand intrinsic muscle dysfunction with cervical lesions, and you'll have the paralysis and gait disturbances with the thoracic lesions. Symptom disturbance can be very early in conus lesions, but it's generally very late presenting symptom in most other locations for spinal tumors. You can get scoliosis and torticollis in adolescents and children. So you have a patient present with scoliosis, you get an MRI to see if it's neurogenic in nature versus just idiopathic scoliosis. If you have an ependymoma, you can get a subarachnoid hemorrhage. If you look at the mean duration of symptoms, they're about 9 years. So these things go on for a long time and they kind of linger. Low-grade tumors can have very, very long presentations. You see with a grade 1, it can be upwards of 15 years. Imaging study of choice, MRI with or without contrast. In some cases, spinal angiography, especially with vascular lesions, can help distinguish from other vascular lesions that present similarly, like a dural AV fistula or dural AVM. Differential diagnosis includes all the differential for myelopathy that we've kind of gone over in some of the earlier talks, and you can read those there. And to kind of quickly run through some of the differentials, with syringomyelia, you oftentimes will see big syrinx in the cord. You won't see any mural nodule enhancement, and you should really get an MRI to look for Chiari malformation. These are non-neoplastic, non-post-traumatic syrinxes are very rare without a Chiari malformation. So if you don't see Chiari, then be a little bit more careful looking for a tumor in a history of no trauma. Demyelinating disease is also another thing that can present very much like a tumor, and it's very important to distinguish that. One of the most frustrating things or scary things is to send a specimen from a spinal cord and it comes back to demyelinating disease. So all the presenting symptoms for MS, you have to be very careful about that. If you get an MRI in multiple sclerosis, the cord can be widened, so it's also similar with a tumor, but the T2 change is very quadrantic, whereas a lot of the tumors, as we said earlier, present in a central location. So this is very typical, imaging for a spinal cord demyelinating disease. You should also get a brain sequence looking for what we call UBOs, so unidentified bright objects, and then you do the standard workup. You can have some oddities, spinal cord abscesses, neuroenteric cyst. Did not advancing. This is just it was going to be a quick video about it, just schistosomiasis, but I'm actually going to move on just for the sake of time. But this looks very much like a tumor. Turned out to be schistosomiasis. Under the microscope, you actually saw little eggs, a patient endemic patient from Yemen. But let's move on. So with intramedullary spinal cord tumors in particular, the major actors are astrocytomas and ependymomas. You can also have myxopapillary ependymomas, lipomas, and miscellaneous tumors, as you see here. So astrocytomas are 30% of all intramedullary spinal cord tumors. They're the most common intramedullary spinal cord tumor outside of the phylum, and they occur at all levels of the spine, but there's thoracic predominance. You see where the peak is, there's a male to female predominance. They're infiltrating lesions. So I describe spinal cord tumors in two ways. I like food, so it could be like a meatball with the nerves going around it, spaghetti going around the meatball, or meatball with spaghetti going through the meatball. Astrocytomas, you have the tumor with the spaghetti, the nerves going through it, and that has implications for the resection. We'll talk about that. The rare exception is a juvenile polycytic astrocytoma, where you have the neurofibers going around the lesion. Those can be 100% resected. And just to show that the tumor infiltrates the spinal cord. So excision will result in destruction of the long fiber tract, so these tumors are incurable. As an example of an astrocytoma, highly, very exuberant enhancement. Low grades, you see the expansion of the cord and not quite as exuberant enhancement. Ependymomas are also 30%, and they're actually the most common gliomas of the lower cord and the conus. And again, a slight male predominance, and you can see the rest of presenting symptoms. They tend to have a central location with a hemosiderin cap, because they'll have some bleeding, and they enhance intensely. Here's an example of ependymoma, very centralized location, expansion of cord, very strong enhancement. You can have a myxopapillary ependymoma, which originates in the conus or in the phylum, and in this situation, you can see CNS dissemination. You can actually have metastatic disease with myxopapillary ependymomas. Now, can you distinguish between the two on an MRI? Usually, but not always. Both tumors have cyst. The length is not really significant, but ependymomas tend to be very, very well defined from the cord, whereas astrocytomas are less defined. Ependymomas are very central, whereas astrocytomas can be more diffuse within the substance of the spinal cord, maybe eccentric in location. You can have lipomas. You can also have vascular lesions like hemangioblastomas, and they're very vascular. You can see them in the surface of the cord. Angiograms can confirm that diagnosis. And here's an example of a hemangioma, and you see the bright enhancement with a lot of edema. You can also have cavernous angiomas, which are also vascular lesions and have a lot of microhemorrhage. We call it variegated popcorn appearance. You can see that in this image over here. And they can bleed if they're not removed. So if someone presents with a cavernous angioma, you have to proceed with resection. Other tumors, again, dermoids, epidermoids. This has a slight female predominance and tends to occur in the conus. And uncommon, you can actually have metastatic lesions to the spinal cord, which are well defined but very adherent to the spinal cord. Here's an example of a lung met to the cord, and that this will run. Let's see. And you can see that you see the tumor there, and you can see that it's very adherent to the substance of the spinal cord. And we literally have to go in, identify the plane around the lesion, and without overly manipulating the spinal cord, dissect free and remove that lesion. I thought I had control of this to move it along a little quicker, but as you can see, we're splitting the cord down to medial raphe. This is normal spinal tissue over here, and then this is the tumor right now. We're dissecting around the plane, and we'll eventually get around the tumor and remove the tumor. But the point of this is just to show how adherent it is to the neural elements. Okay, and again, the white over here is cord. All this over here is tumor. I'm going to move on for the sake of time. These tumors, though they're easily resectable because they are extant from the cord, they can oftentimes recur very exuberantly. I'll move on from this also. There's another movie just showing a resection of a met. But the important thing is that postoperatively, you see the lesion is resected, and in a very short period of time, 4 or 6 months later, it's back as if you never took it out in the first place. And these can be very difficult to deal with when they recur because they're very adherent to neural tissues. Let's talk quickly about operative management. And you really have to think about what you're doing and why you're doing it, because these tumors are surrounded by neural tissue and don't tolerate trauma very well, and they don't tolerate manipulation very well. So you have to be careful in finding the tumor, stopping before causing any damage, so doing an adequate resection but not causing any damage, and not being overly aggressive when you do the resections. There's been an evolution in resecting these lesions, going back as far as opening the cord and then closing, waiting and allowing the cord to basically, push the lesion out, kind of two-stage approach to it. And a lot of developments in resection of intermedullary spinal cord tumors are actually forged here at NYU by Fred Epstein, who's one of the first people to use the ultrasonic aspirator and also to use ultrasound to help identify the lesions. Actually, Gene Flamm was one of the first people to use the microscope for resecting spinal cord tumors. Here's some of your operative adjuncts that we use. There's some newer ones that we'll get into very quickly with the DTIs and the mixed reality. But basically, microscope, ultrasonic aspirators, and ultrasound, as well as monitoring. You can see that there's been a progression in imaging, and we're now using things like diffusion intense imaging as well as augmented and virtual reality. We'll get into that also. So here's a spinal cord lesion. Now with DTIs, we can actually see the spinal tracts. The tumor is right here. We can see the spinal tracts going around the lesion, and it gives us an idea as to where our safe zones are for resection prior to even doing the surgery. We can do this preoperatively, and it really allows us to look and see the lesion in its relationship to normal neurologic structures prior to undergoing our resection. You can then reconstruct it in 3D space. That's your tumor, obviously, red bad, green good, and the tracts going around it. In this situation, we actually remove the lamina in the same way we would do in the operating room, but we did it preoperatively using our virtual reality generators. And just another view of same. So it really helps, because where is the tumor in this situation? This happens to be a vascular lesion, so the tumor is where this black mark is the surface of the spinal cord, but it can be very difficult to delineate where the tumor is. We use ultrasound as a gold standard, and you can see the solid tumor, you can see cystic structures. Again, intraoperatively, here's a solid tumor, here's a cystic structure, solid tumor, the cyst of the tumor. But now we can actually use virtual reality and navigated reality. We can actually use the tracks, and you see the tumor is outlined in red, and you can precisely localize the tumor, and you can use this while you're operating to help you really avoid any neural structures. Again, same thing here. Looking from the surface, we actually have the outline of the tumor projected onto the spinal cord in our microscope, and you can see the volume of the tumor projected onto the spinal cord in our microscope in both the MRI in the situation. We can also switch over to a CT scan, and really helps you safely resect these lesions. Another example is same, really localize the tumor while we're working. The solid line is where we're working. The jagged line is at the depth, so we know how far we have to go in order to fully resect the tumor. And we do real-time navigation. So as opposed to using ultrasound localization, we're now using VR, AR localization. And resection, you have to cut the cord, the myelotomy, retract tumor away from the cord, and try and reduce the bulk of the tumor as best you can without manipulating the underlying tissue. And this is just an example of a bulk reduction of a tumor, rolling the tumor out of the cord, and then the resection cavity. I'll show a very quick video of that being done, and then we'll move on. This is an conus ependymoma, and that's looking at the ultrasound. And this is, now we're going to look at, that was the conus, look at the resection of a cervical ependymoma, done the old way using ultrasound localization. And you can see the tumor, mural nodule, there's cysts. And so looking at the spinal cord caudals down here, you can tell by the angle of the nerve roots, but this is the feet, this is the head. That's the midline raphe, which has been shifted over to the right by the bulk of the tumor. You notice the spinal cord is expanded. So we're just going down the midline in order to avoid the dorsal column to hopefully preserve the patient's proprioception. Once we do that, we'll incise down the middle of the cord and then remove the tumor. I don't have control of my video to move it forwards faster, but here we see me just incising the cord, and then we'll get into the substance of the cord, identify the tumor, and remove the tumor. So this is done the old way using ultrasound to help localize the tumor. Of course, there are visual aids because you see the width of the cord here, and this is normal white matter, and just below that will come into contact with the tumor. Okay, which is going to be the plane over there to kind of work yourself around the tumor. I want to move forward just for the sake of time to show how we do this today. This is an ependymoma with virtual reality. We can, before we get to the OR, we can do things like do the laminectomy, plan where we're going to go in order to resect the lesion. Once we get to the operating room, we can actually broadcast, project the lesion onto the spinal cord. You see us doing that here. We then are opening the cord very precisely because you know exactly where the lesion is. We're reflecting the duromata. Now we're going to open up the arachnoid. That first opening was of the dura, obviously. Now here's the spinal cord, and at the level of the pointer, the solid lines, we're projecting everything onto the spinal cord, and we know precisely where we are the entire time. The midline, the depth of the tumor, how much we need to take, and it allows us to move quicker. It also allows us to move in a more judicious fashion and more safely resect these lesions. And there's a tumor. You come to the tumor at the depth. So it's just an example of what we're doing now, which makes these a lot safer. And we can use these real-time navigation while we're operating. We can project these images, and with our various navigation tools, we can then resect the tumor safely. And we're using an ultrasonic aspirator here. Again, let me move on. So it's hard to fully resect astrocytomas because, as I said, it's the spaghetti going through the meatball. And other things are much easier to resect because it's the spaghetti going around the meatball. Lipomas is one true time a laser is actually useful in neurological surgeries, removing lipomas. Hemangioblastomas, again, you can get around these. They're very well circumscribed. They're also a dark color. They're easy to see. You see the lesion right here, popcorn variegated appearance. Here's another example of one. Localizing easily on the ultrasound. I'm not going to go through the resection just for the sake of time, but you can easily see the tumor is going to be right there where that black spot is, and it helps you kind of get down there. But again, the way we do these now with virtual reality localization, it becomes easier to find these tumors and safely resect them. Again, the tumor is going to be located right under where that black spot is, and the tumor itself, you can get a hint of it, is very darkly colored. This is a epidermoid tumor in the conus, but we won't show that. So let's talk about prognosis and adjuvant therapy. So the better you are going in, the better you are coming out. Recurrence depends, as you can imagine, on extent of resection, natural history of the tumor type, and histological grade. And you really have to remove as much as you can, but you can if it's infiltrating, if it's poorly defined from the cord. And total removal is actually rarely possible because a lot of these tumors are infiltrating. You can get a 50% recurrence at 5 years. Much better prognosis than ependymoma because you can usually resect fully. Again, you cannot fully resect an astrocytoma. Radiation therapy is controversial. We won't use it for low grade, but for high grade tumors, there's an argument to be had to use it, but radiation chemotherapy outcome is very unclear. In the future, we're just going to work more on our imaging modalities to help us more safely resect these lesions with greater confidence. You can see, fusing between CT and MRI, we have real-time intraoperative CT scans as well as intraoperative MRIs. Move on. In conclusion, on common tumors, MRI is the gold standard. These are your most common lesions. You can't fully resect an astrocytoma. And the road radiation chemo are unclear, and outcome really depends on histology, preoperative neurologic deficit. And I actually wrote length of follow-up. The longer you follow them, you realize they really do occur. And I'm into my work. Here's an intramedullary spinal Tony. Okay. Thank you.
Thank you very much, Dr. Frempong. That was a very thorough and interesting talk. We're going to move on to our next speaker. That's Dr. Olaverri. He's going to be talking to us about common primary and metastatic spine tumors.
Well, thank you very much for having me as part of this course today. I've learned a lot so far from the speakers. So I'm going to be speaking about bone tumors to follow Dr. Frempong's talk about intradural tumors. And we'll talk a little bit about primary tumors and perhaps more about metastatic tumors since they're much more common and more likely to be encountered by practitioners. So just to start, a few oncologic concepts in general. There are really three pillars of oncologic therapy. And anytime we're talking about a tumor, we have to decide which modalities we're going to use and which sequence. And it's really a combination of systemic therapy, radiation therapy, and surgery. Some tumors are amenable to surgical treatment alone. Others require a combination of things. And, the subheadings in each one of these lists continuously grows because, there are so many inventions and modalities that are being added every day. The goals of therapy for patients with tumors, again, they're fairly common, I suppose, when it comes to primary metastatic tumors. It's local control, making sure that the tumor doesn't become a recurrent problem, hopefully, and that's usually done with either surgery or radiation. Restoration or preservation of neurologic function and spinal stability. With that, we usually have pain control, and perhaps the main difference among metastatic and primary tumors is the fact that with metastatic tumors, our approach is really palliative. We're taking care of a focal problem in the spine, and it has to be done in the context of their systemic therapy and overall survival, which is more affected by their overall cancer care, versus a primary tumor, where sometimes we have an opportunity to actually cure the patient and prevent metastatic disease and really give them good quality of life and make this cured problem. What are the advances in spinal tumors? It's really the fact that a lot of work has been done about clarifying the indications for treatment. And there are some reasonably consistent treatment recommendations based on various tumor histologies and just different patient conditions. There are really significant advances in radiotherapy. Stereotactic body radiotherapy allows high-dose radiation in a very focal fashion. And then, of course, there's particle therapy, which consists of proton and carbon ion therapy. And then the surgical technique has evolved as well. We've really come to this consensus about incorporating radiation concepts into surgery and surgical concepts into radiation, leading to this concept of hybrid therapy, meaning that both rely on each other in terms of treatment success. Minimal access surgery, the use of neuronavigation, fenestrated screws have really been an important invention in the treatment of, I'd say, metastatic tumors primarily, and perhaps also in carbon fiber screws as well. I think the data are still evolving for that, so I won't spend time talking about that. And I think we have some reasonable guidance about quality metrics for cancer care as well in the spine. So I'll start a little bit with primary bone tumors. And, this is perhaps a long list and certainly not exhaustive of the more common ones. And, this really runs the gamut from, really benign tumors that sometimes can even be observed, like osteosteoma, to the more malignant tumors like Ewing sarcoma and osteosarcoma, and lots in between. We apply the Henniking principles to the spine, and these were developed for long bone tumors, but the idea is the same. It's important to know whether the tumor is going to be invasive or confined to a local capsule, and really what are the what's the anatomic extension of the tumor? Is it confined to bone only, or is it starting to abut or extend into the spaces outside of the spine? And in order to have a common language in terms of describing the anatomy of these tumors, we use the Weinstein-Borjani-Biagini classification, and this can be quite helpful in terms of surgical planning because there are various techniques for removal of these tumors. The preferred way for removing malignant tumors in the spine is en bloc, one that's feasible and justified. And so the techniques would be vertebrectomy, meaning removing the vertebral body as a whole, sagittal resection, when the vertebral body along with some of the posterior elements can be split, or posterior element resection, and of course variations of each one of these techniques. So as a case example, this is a 22-year-old man. He had back pain after weightlifting. Eventually got an x-ray that showed a thoracic mass, and with further imaging it was noted to invade the spine as well. Biopsy showed that this is a chondrosarcoma, and so a chondrosarcoma can run the range of different histologic grades. This one was on the more aggressive range, and there's some pretty good data to indicate that tumors such as chordoma, chondrosarcoma, when they can be removed en bloc, and of course this depends on the patient and really the morphology of the tumor, the size of the tumor, but when it can be removed en bloc, or this concept of Henniking appropriate surgery in the spine, patients certainly have longer survival and recurrence-free survival without local recurrence. So that's what was performed for this patient. Again, based on the classification, the patient had only partial invasion of the vertebral body, so it's a candidate for sagittal resection, and that's exactly what was performed for him. And he's done well for quite a few years without evidence of recurrence or systemic progression. Switching gears to metastatic tumors, there's of course a very long list of histologies that travel to the spine, based on the primary tumor of origin. But it's important and very helpful to have a certain common framework in the way of thinking about these tumors. And the NOMS framework is one of the ways of thinking about it, and I think it's the more popular way of thinking about it. It stands for the neurologic, oncologic, mechanical, and systemic considerations. And I'll spend a little time talking about these. But once again, the really important idea for both primary and metastatic tumors is the fact that this is a team sport, and a collaborative assessment is critical. And usually it's an assessment by a radiation oncologist, a spinal oncologic surgeon, and the medical oncologists, and perhaps interventional radiology as well, with follow-up and rehab. So what do these things stand for? I'll start with the neurologic. And the neurologic really depends on the extent of spinal cord compression and the severity of symptoms. I think the really important concept in the setting of spinal cord compression that is symptomatic, meaning the patient is losing ambulation, time is spine. We say time is brain when it comes to stroke, and perhaps the same is applicable to epidural spinal cord compression by tumors. And the recommendations are administration of dexamethasone, decompressive surgery of the spinal cord in the setting of neurologic deficit, and if the patient is unable to ambulate, this becomes a more urgent problem. And the sooner the decompression is performed, the more probable is the recovery. Fortunately, nowadays, MRIs are pretty common. So a lot of the time, these patients are diagnosed with spinal metastasis before becoming an emergency, especially in the setting of known cancer. Of course, that's one of the red flags that indicates an MRI for a patient with back pain. And so we can catch them before they start causing neurologic symptoms. And in that case, it really just becomes a radiographic diagnosis. And the important thing to differentiate there based on the MRI is whether these patients have low-grade epidural tumor, meaning it's either confined to bone or just starting to extend into the epidural space, or is the tumor, in fact, compressing or displacing the spinal cord? And that would be high-grade epidural spinal cord compression or tumor extension. Tumor histology, of course, matters. That's the oncologic consideration. And what really matters is how these tumors respond to systemic therapy or some of the conventional radiotherapy techniques. A review was done to look at how different histologies in the spine respond to conventional radiation, and we're able to dichotomize these tumor histologies into radiosensitive and radioresistant. So, things like lymphoma, myeloma, of course, respond readily to systemic therapy, and it's very infrequent that we need to actually do decompressive surgery for these. And most of the solid tumor malignancies that travel to the spine are classified as radioresistant because they don't respond very well to conventional radiation. So here's an example of multiple myeloma. There's clear evidence of epidural tumor here with compression of the spinal cord. And after 8 fractions of conventional radiation, the tumor has largely resolved in the epidural space and spinal cord is fully decompressed. Here's an example of prostate cancer responding in a similar fashion. So these are both radiosensitive tumors. On the other hand, something like renal cell carcinoma has traditionally not responded well to conventional radiation, but it does respond to a stereotactic radiosurgery or SBRT. And so, what's really the difference? Conventional radiation has been around for decades. And of course, this is just a way of shooting radiation beams all the way across the body to include the tumor. But in its way, it's encountering a lot of the healthy structures. But this is straightforward to plan. It's basically delivery of low-dose radiation multiple times, usually over the course of 10 days. And some tumors respond to that, while others don't. And that's why we have SBRT, or stereotactic radiotherapy. So here we're able to outline the tumor, that's the yellow outline, and deliver a completely ablative doses of radiation while sparing all the surrounding structures. But this does require more advanced technology and advanced planning. And it works extremely well. When SBRT delivered as a single dose high fraction radiation, the risk of recurrence was shown to be just over 2% at 4 years, which is a dramatic difference compared to conventional radiation. There, usually local control is numbered in months, and it's very dependent on tumor histology, while SBRT can really treat just about any type of spinal tumor very effectively under appropriate conditions. And this can be done in a single fraction, over multiple fractions, or even in the setting of radiation. Reports of over 80% local control have been made. So if you put it all together, the NMDO, the neurologic and the oncologic, most of the radiosensitive tumors, they respond to conventional radiation, and this can be done even in the setting of spinal cord compression. Radioresistant tumors do respond to radiosurgery, and when it's low-grade epidural extension or bone only, we can treat them with radiosurgery up front. But when there's compression of the spinal cord by a radioresistant tumor, we still perform surgery to be followed by radiosurgery for local control. So the role of surgery was, of course, established by the Patchell study, which was published in 2005. This is a prospective randomized trial looking at the outcomes of radiation versus surgery followed by radiation in patients with spinal metastases that were symptomatic. And the surgical arm did dramatically better. And the second argument, of course, is now in the age of SBRT, SBRT can provide local control, but it needs the appropriate conditions for that. And at least one of those conditions is separation of the tumor from the spinal cord and adequate space, allowing us to deliver safe doses to the spinal cord and ablative doses to the tumor. The third consideration is mechanical, and that's the second surgical indication. When somebody has mechanical instability, which in the context of spinal tumors, and is largely based on the classic white Punjabi definition, It's defined as neoplastic process associated with movement-related pain, symptomatic progressive deformity, or neural compromise under physiologic loads. And to facilitate the diagnosis, the Spine Instability Neoplastic Score, or SINS, was devised. And it really consists of 6 largely radiographic considerations with a score that ranges from 0 to 18, indicating stable, potentially unstable, and unstable tumors. The really important concepts are the fact that if the spine is unstable due to cancer, it's not likely to heal the way it does, for example, from a trauma, because the mechanism of injury is very different. And when we treat that tumor with radiation and chemotherapy, the bone healing potential is much lower. And therefore, we usually don't actually try bracing these patients. When somebody has mechanical instability, we should be thinking about how to stabilize them. But the good news is the ligaments are usually intact. So even some of the really bad looking fractures aren't as grossly unstable as some of the traumatic ones. Of course, we have a lot of different ways to stabilize. There's cement alone. There's percutaneous instrumentation and various open techniques. And then finally, the fourth consideration is systemic. What's the extent of systemic metastatic tumor burden and medical comorbidities? There's some really great web-based calculators that are available now. This is the SORG calculator, which has a pretty good accuracy and external validation. And it fairly accurately predicts survival at 3 months, 1 year, and 30 days. We actually looked at a very large population of patients, over 1,500 patients, to look at their survival and how it's changed in the last 20 years. And frankly, sadly, it hasn't really changed all of that much, even though we think that a lot of these patients have different systemic therapy options. And interestingly, histology continues to play a really, really important part in who are the good actors and who are the bad actors. And lung still remains a bad actor, so does colon and some of the sarcomas. Breast and prostate patients with spinal metastases tend to survive longer after surgery. Has the survival really changed for this patient population? It has, but very marginally. It's been improving by approximately 1% per year for the last 20 years. So really not that great. So clearly these patients are quite sick. And for the ones that did change, kidney, lung, and colon, the survival is still somewhat short. Kidney, of course, is the better survival out of these 3. Just a few examples how the technology has really changed what we're doing. So with SBRT, we don't have to do very extensive resections most of the time. So if we look at this patient with a solitary renal metastasis, probably 10 years ago, most would have indicated for en-bloc resection because this is a patient with expected long-term survival, solitary metastasis, so we're looking for definitive therapy. And that's what this type of surgery would look like, front-back operation for en-bloc resection, a very extensive reconstruction, whole day affair with extensive blood loss. On the other hand, now we have the ablative radiation. So we can actually treat the tumor without removing it and get durable local control. So we don't have to do surgery to remove it. The patient has a compression fracture with back pain, and we have prospective randomized trial data to say that kyphoplasty works quite well for these patients and provides rapid pain relief. And that's exactly what this patient got, outpatient kyphoplasty and outpatient signal fraction SBRT, and has been followed for the last few years with no evidence of local recurrence. The second example is separation surgery or hybrid therapy for spinal cord compression. So in a patient like this, where we have epidural disease, compression of the spinal cord, and a compression fracture, again, before we used to probably think about doing something front, back, decompressive, stabilization. But now we do separation surgery with the concept of basically removing the epidural tumor to make sure that the spinal cord is fully decompressed and that there's cerebrospinal fluid around it. And then the patient is treated with SBRT. And the idea is that I no longer have to go for 100% tumor resection to get tumor control. I'm going to really rely on postoperative SBRT for that. But with surgery, I'm just going to create optimal conditions for that, which entails space between the tumor and the spinal cord and the stable spine. And then work with the radiation oncologists to deliver SBRT. That's, again, the postoperative construct and showing decompression. This is the radiotherapy plan. And this works quite well. So 1 year follow-up for these patients after separation surgery followed by SBRT with high dose perfraction radiotherapy, the risk of recurrence was less than 10%. And then finally, just the integration of minimal access techniques into what we're doing. So before we used to have these really terrible looking wounds and very extensive reconstructions to be done by plastic surgeons. And now this type of thoracic surgery can be done with a few small minimally invasive incisions. And of course, fenestrated screws, they allow us to use much shorter constructs and really focus on the fracture without worrying too much about the extent of bone destruction at adjacent levels and even at the level that we're stabilizing. So this was a patient with an L3 metastasis, non-small cell lung carcinoma, and the radiation was started. It was conventional radiation. The patient was in the midst of radiation. However, the pain became so severe that they couldn't walk. They couldn't even get on the radiation table. They had severe mechanical radiculopathy and then required surgery. So, if we had to do this type of surgery using open technique in the middle of radiation, of course, we need plastic surgeons and still worry quite a bit about their wound complications. On the other hand, now we can do this minimally invasively, percutaneous instrumental stabilization, kyphoplasty, use one of the screw incisions for an expandable retractor to do a facetectomy and remove the pedicle, remove the tumor and decompress the nerve root. And then, of course, these incisions heal very readily. That's what intraoperative cement injection looks like when we do it all together, combined fenestrated screws and kyphoplasty. Navigation, of course, has really helped a lot with each step of this type of surgery. And we use it very extensively. And the quality of life improves for these patients. The quality of life improves after separation surgery for spinal cord decompression. It improves for surgery and stabilization of mechanically unstable spines. And of course, the more unstable and symptomatic these patients are, the greater the improvement in quality of life for them. So in conclusion, tumor type is critical in determination of treatment plan, and this is a team sport, and the treatment is to be determined by collaboration of surgeons and other oncologic specialties. NOMS provides a way of structurally thinking about metastatic tumors and making decisions. And the main advances that have changed the way we do things are SBRT, minimal access techniques. We have some pretty good quality metrics now. Thank you.
Thank you very much, Dr. Law, for that great talk. So just to the audience, you guys can ask questions through the chat. If there's no further questions, we're going to go on to we're going to go on to our break and then get started at 2:35 for our spinal deformity interventions.
If it's my last day on earth, I want to spend it with you.
Welcome back, everybody. We're going to enter the last portion of our spine comprehensive course, and this one is spine deformity evaluation. So our first speaker is Dr. Anthony Petrizzo, and he's going to be talking to us about the evaluation and treatment of pediatric spinal deformity.
Thanks, Dr. Jegede. So thank you so much for everyone staying on. Good afternoon. So I'll be discussing the evaluation and treatment of pediatric spinal deformity. Here's my disclosures. None of them are relevant for today's lecture. So pediatric deformity encompasses the entire spectrum of the disease, which can cause a portion of the spine or the entire spine and juxtaspinal regions to deform. So we'll focus mostly on idiopathic scoliosis because that's a major proportion of pediatric spinal deformity that we see. However, here at NYU, there's a lot of other forms of scoliosis and deformity that we also treat. In addition to scoliosis, we also treat other deformities that we see fairly commonly here, such as kyphosis, spinalisthesis, and deformities that occur after spinal tumors. My objective today, though, is to discuss the 2021 state-of-the-art evaluation and treatment. I want to review the proper evaluation for spinal deformity, and I also want to provide updated research on non-surgical management. It's not all about surgery, and we should be treating the kids as best as possible. And if that's avoiding surgery, that should be paramount. I also want to discuss the shortcomings of treatment and project how diagnosing and treating scoliosis can improve. So where are we in 2020? The final common pathway of the first 100 years of treating scoliosis is the same. We still ultimately treat progressive deformities with a long bony fusion of a once mobile polysegmental system. However, the alternative is leaving it alone and leaving the spine to its fate with cosmetically unacceptable, with the potential for pain and progression, and ultimately for severe curves affecting cardiovascular compromise and pulmonary function. So I would argue, is there a better way to do this? What would the Holy Grail be? I would argue that the Holy Grail would be finding a way to control the spine without having to physically go in and do something for the spine. So I'm sure you've all heard the old expression, you can't tell where you're going unless you know where you've been. And I think that's really important in understanding scoliosis. You see the picture here on the bottom is Russell Hibbs, who's actually the first to publish on a series of patients who underwent long uninstrumented in situ fusions, coupled with a long-lasting immobilization in the cast. The fellow on the right is Paul Harrington, who is acknowledged to be the first to use implants for scoliosis, initially for immobilization and later to support the fusion. These pioneers actually taught us a lot. Here's an example of a Harrington rod. Now, this isn't what we use nowadays. It's certainly a modified version. You see here basically a hook at the top of the construct and a hook at the bottom of the construct, and there's a distractor here, which would progressively correct the spine, but it would just hold it in place. The goal wasn't to fuse the spine originally, and then later it was modified to incorporate a fusion. And this started the path for the current treatment that we have of scoliosis surgically. And although there's been many modifications, the principles were originally taught to us about 70, 80 years ago. So what's the definition of idiopathic scoliosis? It's a lateral curvature of the spine with rotation, okay? For what we understand about the three-dimensional laws of spinal motion is if it's going to turn in one direction, it has to turn in another direction. So if the bone's going to tilt, it also has to turn in another direction. With scoliosis, that's rotation. And essentially, it's a torsional deformity. You'll see it's almost like wringing a towel. It turns, it tilts, and it bends. And we throw around the word idiopathic, but idiopathic scoliosis should only be considered the terminology after all other causes have been excluded. And in terms of the types of idiopathic scoliosis, there's infantile, juvenile, and adolescent, which obviously is given based on the age groups. However, there's also other deformities that we see here. The patient on the left is a C-type scoliotic deformity, which also involves the pelvis. That's something that we see with neuromuscular disease. And the child on the right, as you can see, is still skeletally mature. The triradiates are opened. And this is a neuromuscular curve as well. This is someone with neurofibromatosis, which also causes a deformity as well. So you can also classify the scoliosis not only on age, but with the disease that it's associated with. So if I'm discussing a curve with my colleagues and I say it's a neuromuscular scoliosis, that paints a picture of a large, long sweeping curve that involves the juxtaspinal region, such as the pelvis and potentially the head. There's also conditions that are associated with scoliosis, such as sciatic scoliosis, in which a patient is bending away from the neural compression as a way to try and relieve some of the symptoms. So as far as the cause of the idiopathic, well, obviously we don't have the cause, but there's a lot of research. There's been research going on for the past 100 years trying to help us understand what happens to these otherwise normal children. Genetic causes are debated. There is certainly research that correlates this. Because there's about a 30% chance of patients that have scoliosis also have a family history. However, the family history is not helpful in determining the magnitude or the risk for the progression. We also know the etiology and alterations of connective tissue. We examine these patients. We see a lot of them have ligamentous laxity. They have recurvatum. They have flat feet. They have laxity in their elbows and hands. We see that there's differences in the central nervous system, pulsatile flow of the cerebral spinal fluid, differences in equilibrium. We also see uncoupling of the growth of the spinal cord and the vertebral column itself. And that mismatch causes the spine to turn. And there's actually some really good studies showing that that's one of the leading causes of the scoliosis. However, they're all independently inconclusive. So the common consensus remains that it's still multifactorial. Okay. One of the most important things, just like everything else in orthopedics, the history and physical exam is paramount. How was the curve discovered? Was it discovered by the parent, by the patients? Was it from a school screening test? Does the child have pain, the neurologic symptoms? How about the birth history? Was there a problem with the birth? Was there a problem with delivery? Was there a delay? Was the patient premature? What's the developmental history? Did they meet all their milestones? What's the family history? When did they start their menstrual cycles? Where are they in their peak height velocity? Okay, structural exam. You get a lot out of the structural exam. This looks relatively normal. However, you see asymmetry in the lumbar spine here, not so much in the waist crease, but more in the lumbar spine. You see prominent of the scapula here, but not on the other side. Shoulder heights, very subtly, this is elevated on the right and not so much on the left. These are all suggestive of a fairly typical curve that we see with adolescents, but also look at the skin. Are there patches, hair tufts, midline defects? How are they balanced? Is their head over their pelvis? Is there any deviation? I also check a dynamic assessment. How well does the spine bend? How flexible is it? This is very commonly utilized by not only the orthopedists, but also by the pediatricians. And this is the Adams forward bending test, where you're essentially using a plumber's level to assess how much rotation is there in that spine. Because as I mentioned, when the spine tilts, it also rotates, and you're assessing the rotation. The rotation here, once you're getting about 7 degrees, it correlates with the 20 degrees on a Cobb angle, and it's something you should consider referral or at least obtaining radiographs. When we talk about curves, is it 20 degrees, 30 degrees, 40 degrees? That's based on the Cobb angle. So this is a angle proposed by John Cobb, where we assess the bones that are bent the most, and using a protractor, we measure that curve, and that number is what we dictate to be the magnitude of the curve. So once they're diagnosed with scoliosis, the main questions asked by patients, and this has been fairly consistent over the past 50 years. Is my back going to hurt? What's going to happen to my lungs? What's going to happen to the curves? Is my hump going to get bigger? Am I going to die from this curve? Okay. So backache, 46% of patients will complain of backache. However, we know from the earlier lectures that's comparable with the incidence of general back pain in the population. We do know that the lumbar curves have transitory shifts, and that can also give them a greater incidence of back pain. They don't have the ribs and the sternum as a buttress to protect it, and very often that puts more stress on the muscles and can give them more pain. However, we do know that the backache is really unrelated to the presence or absence of arthritic changes in the curve. Pulmonary functions, really common question asked by parents with scoliosis. It's not really seen to 100, 120 degrees. A stable 30-degree curve has no increased risk of pulmonary complications or risk during pregnancies. Psychosocial, okay, of course, that's a common question to these adolescents, during their teenage years. And what we do see in many of our conservatively treated patients is that they're unhappy with the appearance of their curves. And what happens with adolescent idiopathic scoliosis? They become adults, and that curve can also progress. This is one of the 48-year-old patients that I had who had two main complaints. One, she felt like she was getting shorter, and two, she was hating her curve and how her clothes fit. And that's not uncommon. This patient also had pain, and as well as progression, also ultimately underwent a fusion. However, this is a curve, this is another patient who I follow who has no symptoms of this, and she has a significant deformity. Typically, we tell patients that if it's untreated, it progresses at about 1 degree per year. The patients that we see on our service that get into trouble is when they start to get spinal stenosis or arthritic changes, as Dr. Goldstein had mentioned earlier, and then they start to get radiculopathy. Also, a subset of these patients that they will not be able to compensate in their pelvis for this deformity, and they'll have problems standing, walking, or maintaining an upright posture. Mortality, The mortality rate for scoliosis is comparable with that of the public. But however, there is an increased risk of morbidity mortality for thoracic curves greater than 100 degrees. And that's what we see in the earlier onset scoliosis, not so much the idiopathic scoliosis. The curve progression, and this is if there's residents or people who have to be prepared for tests, this curve is very helpful and it's very accurate. If a kid comes to me with a curve of 20 to 29 degrees and their risks are 0 to 1, they have a 70% chance of needing surgery and having significant progression. These are the kids I worry about the most. However, if someone comes with a curve less than 20 degrees and their risks are 2 or 4, the chance of them needing surgery is about 1 to 2%. So big difference in those curves. Predictive factors, as you would imagine, females, much higher rate of progression, larger curves, double curves. Risks of not progressing is people that are more mature, older age, postmenarchal, axillary hair, higher Tanner stages, risks are 2s, 3s, or 4s. Skeletal maturity, a lot of ways we assess that: iliac crest, the bone, the vertebral bodies themselves, the hands, the fingers. All those things help us figure out what's going on. But the summary, you measure the curve. If it's less than 25 degrees, you observe. 25, 29 degrees, we're treating in New York. 30 to 40 degrees, we're actively treating and bracing. Greater than 45 to 50 degrees, we start worrying about surgery. So again, if the curve is about 19 degrees and progresses, we treat it. If there's documented progression of 20 to 29, we treat it. If it's greater than 30 degrees at initial onset, we treat it, okay? And that treating is usually bracing. So what are the non-operative treatments we have? Exercise, we could talk about that. Electrical stimulation, limited role. Manipulation, very limited role. And orthotic treatment. So for years, the treatment is really focused on bracing or surgery. However, the Society of Scoliosis, Orthopedic, and Rehabilitation, or SOSORT, which was started about 2005 to obtain the best results of conservative care. This really helped us increase our understanding of non-surgical treatment. As far as exercise, there was a long-held theory within the Scoliosis Research Society that exercise really wasn't shown to affect the natural history. And that was born out of a study in the late 70s in which they studied 42 people. Only 4 out of the 42 actually exercised daily. Exercise treatment in the 70s, much different than it is today. And that study showed limited role in exercise. However, since then, there's been an evolution of a lot of different treatment principles for scoliosis, including Schroth, the scientific exercise approach to scoliosis, traditional exercise, posture education, and there's a lot of studies coming out to support that. Electrical stimulation, again, limited role. Bracing is something that certainly has been the focal non-operative instrument in terms of our treatment and trying to prevent the progression. The indications are really RISR 0, 1, or 2. And in the RISR stage is really important. Insurance companies, I've been getting more and more rejections without documenting what the RISR stage is. They want to know that this kid is skeletally immature with room to grow. And that's one of the indications for bracing. They have to have a curve of 20 to 40, still have remaining growth, and have a deformity that they consider acceptable, okay? Milwaukee brace, I still use it. I use it mainly to control my proximal thoracic curves. Obviously, as you can see by this, it's very hard to get the children to comply. The most common braces we use here is the modified Boston brace or a underarm TLSO. That's obviously the proximal thoracic curve has to not be involved or be acceptable. It's really for main thoracic curves and thoracolumbar curves. However, kids tolerate that well. They can put a shirt over it. It's very hard to see. There's a lot of other braces on the market, the Leon, the Boston, Wilmington, Charleston, Providence. Just you pick your territory and you'll find a brace there. In general, very good studies to show that the more you wear it, the better it is. I recommend 23 hours a day. And you don't just DC the brace when they're done growing. You actually wean them out of it. You follow their growth. And even when patients graduate from bracing, I still follow them. These are the classifications of bracings: nighttime bending brace, soft brace, part-time rigid brace, full-time rigid bracing. SOSORT went through a wonderful review article to try and differentiate the bracing and the different principles of bracing. And there's not really a strong consensus from the orthotists. You have to have an orthotist that you're comfortable with and that you trust. You have to follow them through with radiographs. I get an x-ray after the brace is fitting. This is a curve that was a braceable curve, but in the brace, little change. This kid went back to, this brace went back to the orthotist. I need to see at least 50% correction. I'd like to see 70% correction. Results of orthotic treatment. This has been something that's been studied over the past 70 years. There is initial improvement in brace, but gradually when the brace is discontinued, this gradual loss of correction, and they usually get to about where they started. So I have to stress to the families, the goal of bracing is not to make the curve straight, but it's to prevent progression, okay? And despite that, I do have kids that continue to progress. As far as operative treatment, there's a lot we could talk about. That's a lecture in itself. In general, operative indications are greater than 40 to 50 degrees in a growing child, not just a finished, stable child. I have to see progression in that curve, and I have to document it. In general, selected infusion levels, you want to fuse as much to include the entire curve, but not too much to allow for maximal spinal motion. And the levels of fusion performed are more critical than what you use or what type. If you're very interested in scoliosis, read about the Lanky classification. It helps you understand all the parameters useful in figuring out what to do for these patients. The approach, posterior is still our mainstay of treatment principles. At NYU, we do a lot of anterior. It gives us better derotation. For me, it does get curve correction for a single thoracolumbar or a lumbar curve. But the results are similar. There's studies that support each use, so you have to do what's most comfortable for you in a discussion with the family for which approach is better. Occasionally, we do anterior and posterior. But yeah, no, not all posterior spinal fusions are the same. Here's an example of a kid. This is an early onset scoliosis that's a growing rod construct. So this is a kid where we fuse the upper segment, we fuse the lower segment, and we use this telescoping collar that over time allows us to distract his spine to be in concert with his growth height. And the lengthenings are not big surgeries. The patients typically go home on the same day, and it's a 3-inch incision, which is well tolerated. Operative results, we get very good corrections. We're probably up to about 70% at NYU, 70% correction. This concept of 3D correction really helps our rotation, derotating. And there's a lot of techniques that evolve for that. We do know that we fuse kids, things can happen in adults. We can create a flat back. We could also create something called adjacent level disease, where the adjacent levels start to break down, and Dr. Protopsaltis will talk more about that. So, we've been focusing on the third dimension, which is, the derotation aspect of it, and we've really gotten much better at it. So we can put the spine wherever we want it. Now that we have the ability to do it, where do we put it? Do we focus on the SVA? Do we focus on the derotation? Do we focus on getting rid of the hump? Do we focus on maximizing motion? So the EOS really helps us understand where things go. And it's really important to understand the spine in a more global setting, not just the spine itself, but what's happening to the pelvis, what's happening to the limbs in space. And this is something that's born out of this research that I started, had born out of my interest in these two patients here, which I operated on in the same week. The patient on the left, I did a posterior spinal fusion from T5 to T3. Patient on the right, it's a male, also operated on from T5 to T3. I maximized their bending. This patient obviously can touch their toes. This patient is not even close. So why is it different? Same surgeon, same indication. Why is there a different outcome? So since then, we started following these patients with motion analysis as well as gait studies. And some of these patients, this is a patient I did a long thoracic and thoracolumbar fusion. Bending characteristics changed very little. So we started a study where we tried to assess patients undergoing posterior spinal fusion, whether they would lose motion in proportion to the number of fusion segments, which intuitively you would think. And what we found is the study was actually suggested that each individual has unique bending characteristics, which recruit different regions in the spine for forward bending. And individuals that depend on their spine to bend and not their pelvis, they're going to be more affected by posterior spinal fusion, which really brings this next topic up for discussion, because what I do find in fusions is not all these kids lose a lot of motion. And I think the ones that do, it brings more interest in considering tethering these people. But there'll be more to discuss in this in the upcoming time. Well, thank you for your time. I'm sorry I've gone late.
Thank you very much, Dr. Patricia. That was great. A very detailed overview of pediatric deformity. We're going to go on to the next talk, which is going to be early onset scoliosis and casting. Dr. Dara Lau will be giving us that talk. For the audience, please remember that you can continue to put your questions in the chat, and we'll ask the questions at the end of the panel.
You bring up the talk.
All right, I think we got you.
All right. Trying to. All right. Thank you for this opportunity today. Really, the goal of this talk is to look at early onset scoliosis and discuss the role of serial casting. And so no disclosures. And again, to really dive into the overview of metacasting for early onset scoliosis, I think it's important to touch on the subtypes of early onset scoliosis, also known as EOS, discuss the sequelae of untreated EOS, and also go into the indication, the timing of casting, discuss the techniques and the immediate effects of pulmonary function during casting. And of course, it's important to review the evidence of the efficacy and outcomes following casting. So early onset scoliosis is a very generic term in regards to categorizing scoliosis. It's essentially patients that have curves greater than 10 degrees that present less than 10 years of age. So that encompasses a tremendous subset of patients. This essentially encompasses idiopathic, neuromuscular, congenital, syndromic, all types of scoliosis. And the management of these patients can often be difficult given the significant growth potential that they have and the risk for curve progression. And this goes into the question, is scoliosis dangerous? It really depends on their presentation and growth potential. So early onset scoliosis is a very different subcategory of scoliosis compared to late onset, which is the adolescence and adult scoliosis. And as we know, cardiopulmonary compromise comes into play when you have curves greater than 75 degrees. And those patients that present early have that bigger risk of reaching 75 degrees. So when curves reach over 75 degrees, they have significant reduction in PFTs. Their vital capacity is less than 75% of predicted values. And when they reach over 100 degrees, their total lung capacity is about 50% of normal. And when they reach over 120 degrees of scoliosis, you start to see restrictive lung disease and right-sided heart failure. Now, unfortunately, there are patients who are mismanaged or left untreated and really should have been treated starting in infancy with casting. And even with idiopathic subtypes, these curves can progress pretty significantly and turn into quite debilitating spinal deformities. This is a case example of a 13-year-old with a diagnosis of infantile idiopathic scoliosis, was left untreated, presents at the age of 13 with this X-ray in hand. And as you can see on the clinical image here, he has a very severe kyphoscoliosis. His chest morphology is also quite deformed in terms of its morphology. And then as you can see on the X-ray, his left chest is hypoplastic, which results in severe restrictive lung disease and severe pulmonary compromise. So this is a case in which you want to prevent. And which further down the line for this patient's management could be less invasive. So really, standing x-rays here for this kid shows a kyphosis of 162 degrees, scoliosis of 147 degrees. So with this severe kyphoscoliosis, you have to define your goals of surgery or any kind of intervention. And number one is we want to halt the progression of the curve. We also want to give correction because of the severe cardiopulmonary compromise. We want to achieve a spinal alignment that's balanced. But for all causes, we also want to maintain neurologic function, because this patient presented to us, although with a very severe deformity, he was completely neurologically normal. And a way we do that is to apply traction. Traction allows us to minimize the morbidity, possibly decrease the neurologic risk, and maybe even perform a less invasive surgery. So this patient was placed on halogravity traction for 8 weeks with a goal of 50% of his weight. As you can see on the post-traction images, his kyphosis corrected quite a bit, but his scoliosis remained rigid with really no correction. This is also a good time to place a feeding tube to improve their nutrition status. But at the end of the day, this patient required a vertebral column resection at multiple levels. This is technically challenging and can be associated with high complications, but it's really the only way we can gain adequate correction of his deformity. And even under the hands of very experienced surgeons, complication rates are as high as 59%. You have high blood loss associated with it, average 1.6 liters, which turns out to be approximately 65% of blood volume in this pediatric patient population. In regards to intraoperative neuromonitoring changes, occurred in 27% of cases, which is an indication of potential neurologic compromise. And postoperatively, after undergoing vertebral column resection, neurological deficit rates are as high as 9.4%, which is almost 1 in 10 cases. Unfortunately, pediatric patients are quite remarkable, and 62% that do experience a neurological deficit return to baseline at the first 6 weeks post-op visit. And at 1 and 2 year follow-up, 91% of those patients do return to baseline and normal neurologic function. So that patient underwent a 3-level vertebral column resection, a T2 to L4 posterior spinal fusion. We can see that we gained significant correction of his kyphoscoliosis. He's well aligned in the sagittal coronal plane, but importantly, clinically, he also looks well. This is his pre-traction, post-traction, and post-surgical image. And then again, looking at the clinical image from the side, you can see that there's a significant correction in his kyphoscoliosis, but most remarkably, his chest cavity was normalized to someone that you wouldn't think has a spinal deformity. Therefore, it's really vital we screen these patients early in order to prevent such severe deformities. In any patient in which you're concerned about scoliosis, especially in infants, it's important to undergo that x-ray to make sure that they do or do not have scoliosis. And this is where the role of casting comes in. Now, metacasting is truly a full body corrective cast. Ideally, it's implemented in children less than 3 years of age. Smaller curves, more flexible curves tend to respond well to casting. And the indications for casting are usually curves greater than 20-25 degrees or have rib vertical angle differences, RVAD of greater than 25 degrees, which is really a representation of the degree of apex rotation. In regards to the technique, it's somewhat medieval, but effective. We utilize a casting table, usually a Risser table. You place them supine on the table with the arms out. You apply traction at the head and at the legs. You apply up to 50% of weight traction. Then you apply a force that derotates and translates the scoliotic spine. And really the goal of your post-cast correction should be less than 10 degrees. And this is more for idiopathic curves, as non-idiopathic curves tend to be more rigid and less flexible. And it's been shown that Cobb angles greater than 10 degrees following cast has less optimal results in the long run. This is the final product. As you can see, is truly a full body cast, extends from basically the top of the sternum down to the pubis. It's optional to have the straps. I think the straps are advantageous for upper proximal thoracic curves. Important part of applying a cast is actually the cutout that you see here anteriorly. The cutout is important because a lot of these infants or young toddlers have their respiratory drive secondary to the abdominal movement, in addition to the chest rise. So it's really important to accommodate their abdominal protrusion when applying these casts. One of the complications that you can experience when applying these casts is restrictive lung disease secondary to inadequate exposure with the window while making the cuts anteriorly. This is a case example of a 22-month-old patient presented with a right main thoracic curve of 52 degrees, quite flexible on physical examination. We initiated serial casting, as this is an X-ray of the patient in that metabody cast. As you can see, you gain significant correction, almost to zero, of the scoliosis curve. And then 1.5 years out following serial casting, this is the patient standing without a cast on, and you can see is the curve is essentially resolved and essentially cured from the standpoint of idiopathic curves. Now, there are some key technical considerations when applying a cast. There's good evidence that general anesthesia in infants or young children has negative implications in terms of cognitive aspects. And there are groups that are considering application of a cast awake without anesthesia. But most commonly, these casts are applied with the patient asleep with the use of an endotracheal tube. And the reason why the endotracheal tube is important is because it allows anesthesiologists to actually maintain control of the airway and control ventilation, because application of that cast could increase the peak inspiratory pressures, in which without an ET tube, you would have very difficult control of ventilation. In regards to the studies that have been published, when they are applying cast with patients awake, they are reporting similar radiographic correction, but this is really for infantile idiopathic scoliosis. These are very small case studies. Those patients tend to be older, they have lower BMI. So really the results of that is unclear right now, and I think most practitioners would perform this under anesthesia. In regards to direct pulmonary changes, now during casting, you're applying this force, this rotational lateral force, and this direct force results in restriction of expansion of the chest and abdominal wall, which decreases compliance. This directly leads to increased peak inspiratory pressures. And after casting, when the cast is applied, you have over 100% increase in peak inspiratory pressures. And like we talked about briefly, cutting the windows is essential for ventilation. And even after cutting those windows, you still have an increase of 32% after the cast is applied. The good news is that all lung function returns to baseline parameters following removal of the cast, even 2 to 3 months after. Although casting has been utilized for many years now, the evidence behind it is actually not so robust, and there's a lack of a randomized clinical trial looking at the use of casting versus bracing versus no conservative management. The best study we have now is a prospective comparative study in which they looked at 58 patients, 28 were casted, and 38 underwent bracing only. And these were comparable groups with similar curve magnitudes. What they found in their study was that casting was much more effective in being able to maintain curves less than 70 degrees. As you can see on this chart here, the patients that underwent bracing only had 83% of patients with curves greater than 70 degrees versus 64% of patients that underwent casting. He also found that progression would slow down with casting versus bracing, 4.4 degrees versus 5.8 degrees per year. And then in those patients that initially underwent casting and eventually transitioned to bracing, those curves progressed tremendously at an accelerated rate of 8.4 degrees per year, which really represents the effectiveness of casting holding these curves down. Now, in regards to successful outcomes, years down the line, in study looking at 50 to 160 degree curves for infantile scoliosis, they had 46% had resolution of the deformity, 34% maintained deformity within 50 degrees. And to my mind, this is actually ongoing success. So really only 20% had an unsuccessful outcome, which is pretty remarkable. And 20% progressed, underwent growth-friendly surgery. Now, 5 years down the line following casting, 49% maintain less than 15-degree curve. I think that's relatively good as well for a low-risk procedure. But the main conclusion of the study, and taking all of this together, is that the treatment of early onset scoliosis, especially in infancy, even if you get a cure with casting, is not truly finished until they reach skeletal maturity. Casting is not only used for idiopathic scoliosis, but all other subtypes, because early onset presents in all subtypes. And in regards to neuromuscular syndromic congenital scoliosis, those curves tend to be less flexible, more rigid. And according to studies that are out, even if you apply a cast and you're not able to gain any significant correction, there's evidence that even without a correction in the cast, 45% of those patients still have stable curves. So the cast is still effective despite not achieving any correction. 55% of them do progress and 43% require surgery. For congenital scoliosis, they did see correction, 70 degrees to 55 degrees in the small case series, and none of them required additional surgery over the 2-year treatment course. So casting is typically performed every 3 months to really accommodate the growth of the patient. And many parents ask if their child can have a break, essentially, a casting holiday for several weeks. And it's important to consider the consequences in stopping the cast, even for several weeks. A study looking at 90 patients compared 59 patients who had no holiday versus 31 patients who had a casting holiday. And they looked at the outcome of success, meaning less than 15 degrees at the end of treatment. And what they found was that patients that underwent casting without a holiday had a significantly greater incidence of success, whether you looked at this for all types of scoliosis or just idiopathic scoliosis. So really, if at all possible, casting should be serial, and holidays should be avoided at least for the first 18 months of treatment. And if you really need to consider having a holiday for several weeks, you may want to consider even utilizing a brace for that time, although the data for that has not been shown to be effective. Now we can see that, casting is quite effective on a radiographic standpoint and obtaining successful outcomes in curve progression and stability. It's also important to examine the health-related quality of life outcomes following casting. And it's interesting when we look at idiopathic scoliosis and syndromic congenital neuromuscular, because from the data that I've shown at this point, we know that idiopathic curves tend to be more flexible, and casting is very effective and maybe even a cure for those idiopathic infantile scoliosis. But according to this health-related quality of life outcome questionnaire, patients that undergo casting, have decreased baselines in nearly all of the subdomains in general, except for general health for idiopathic curves. But they continue to suffer residual negative effects, especially in the emotional subdomains. Now, non-idiopathic curves that undergo casting, they are shown to be less effective and maybe even offer the potential to delay surgery, but those patients actually have improved questionnaire outcomes compared to their baseline scores. So this is something very important to keep in mind when we're, discussing the risk and benefits of casting for our infants that we see in office. So in summary, early onset scoliosis is truly a progressive disease. It can result in significant medical morbidity, functional disability, and physical deformity. But I think early screening and appropriate measures can really help delay the progression of scoliosis until they're old enough for growth-friendly surgery. And in patients with idiopathic subtypes, this is a potential for even a cure for those patients and avoid surgery in the future. I want to thank you for your attention and for your time.
Thank you very much, Dr. Lau, for that very interesting and evidence-based talk on early onset casting. So we're going to move on to our next talk. For the audience, please keep the questions coming through the chat. So now we're going to hear about early onset scoliosis and anterior vertebral Tethering by Juan Carlos Rodriguez-Olaverri.
Hi, good afternoon. Sorry for the delay. We're in the OR. So why we like to, the point of the talk is a technique that we're using, trying to, the slides are not moving. Okay, now it's moving, okay. When we correct scoliosis, we try to, the standard goal is to do a fusion. But fusion means that you lose movement of the spine. So 10 years ago, they started experimental surgery called vertebral body tethering, that instead of going posteriorly, as you see the pictures, you go to the lateral side to your chest, and then you put screws, and then you put a cord, which is made of tetraphyllate, which is very flexible, and then we tighten and compress. The convexity of the curve and the concave part is free. The idea is to maintain flexibility and quality of life, and at the same time correct the curve. And ideally is that the patients with a lot of growing left, you can still do the case and let them grow from one side, because the other side, the convexity side, is tethered or is like tensioned. This is not a new thing. It was done based on the Euler-Bogman principle, that bone under more pressure will grow slower and denser than bone not under stress. So when we do knees and to make it longer or shorter, we do that principle of the Euler-Bogman. So what's the rationale of doing this instead of a fusion? So fusions have many years of follow-up. So we know that depending on the level we finish, we get an adjacent level degeneration. Maybe your sagittal compensation is not good. Hypothetically, the spine mobile is better than a fused spine. And opposed to fusion, we cannot be undone. This pressure doesn't prevent you from any future treatment option. So the good thing about this, when I talk with the parents, is that the worst case scenario, you always can go back to a fusion. The advantage is with less invasive, the spine can continue to grow, therefore most often allowing for a corrective of the curve. The spine can continue to move and bend, allowing the patient to experience more comfort and freedom of movement. Being a one-time surgery, for the most part, no bridges are burned. Future treatments can be done, and you have other options. And hospital stay is almost the same as a fusion, but the patients move more, and like when they leave going up down the stairs and flexing the spines. This is a nice article about comparing the vertebral body tethering in the thoracic spine to see if we correct the sagittal profile, and the paper proved that it corrected. That's a picture from the paper. There are some other studies that we have about complications in the standard of gold, or is the gold standard, sorry, or is the posterior spinal fusion. This is a nice study done in Shiners in Philadelphia, showing that tethering versus fusion, as you see in the pictures, so the tethering one really bends like the pre-op, and the fusion one doesn't bend that much. And then rotating the torso, you see how much they rotate when they have a tether compared to the posterior spinal fusion one. So to evaluate the patient, we use the standard scores to know how much growing left, because depending on how much growing left, we do more correction or less correction of the curve, because we're gonna play with the growing of the spine. This is the classification, is from 1 to 8, depending on the physis. You have less than 1, 2, 3, 4 is immature, so they have a lot of growing left, and 5 to 8, you have mature spines and you have less growing left. And then we combine that with the all research staging, who measure the curve progression too, but not as reliable as the standard scores. And the research for correlates with completion of spinal growth in girls. In boys, is not as reliable, as you know. So for the classification, we classify immature patients as research 01, or Sanders less than 4. That means that if I'm gonna correct the curve, I know that whatever I got in the OR, for example, 15 degrees, is gonna continue to grow through to the growing of the patient. But if it's a mature patient, I know that whatever I get in the OR is what's gonna be at the end. There's a lot of published in literature right now. The SRS meeting, which is the more important deformity meeting in the world right now. Last year were 16. This year were like 21 podiums and 4 round tables of discussions about what is better to do, a fusion or tether. So right now we are doing a lot of studies and data collecting to see if this worth to do this technique or not. This is the surgical technique. As you know, we go laterally to the spine. We check with the fluoro, we mark our levels, and we do a small incision in the lateral part of the spine, dissecting latissimus and going to the ribs. And then we put staples and we check it with fluoro, and then we navigate it down to the screws. It's very important to be doing now navigating, because as you see, this is a classical paper by Dan Sugato in Texas Scottish Rites. When you have a scoliosis, the aorta is rotated and close to the spine, so we have to be careful when we put the screws there. And when we put the high screws like this one in T4, T5, you have the hemiasicus vein there. So even though it's a minimally invasive technique, but it's not, the exposure is complicated. If you don't do it right, you can have problems. But so far, it's been saved. The technique is you push down and then release some cord, go to the other side, capture the cord, counter torque, and insert locking cap with a provisional capture. Then you apply tension using compressor until desired correction is achieved, and then the final tandem locking cap to hold the correction. This will be repeated to adjacent levels. How we plan it with link classification depending on A or B. We throw a midline from the sacrum all the way up, and the last vertebral body who is dissected or touched, it will be my end vertebral body to put the screws. In Linky 2, the same thing. This is a 12-year-old immature patient with a 70-degree curve. Right now, she's around 25 months, and she is doing very well, no breakage. Sometimes you have 2 curves, and you have to combine one screw from one side to the other screw on the other side, as you see in that image. This is an example. So you have a double curve, 57 and 44. Linky C, the line doesn't touch any of the vertebral bodies. These are the clinical pictures. And this is the correction with a good cyto profile. And this is what she do at 3 months. The video is at 3 months. The picture is at 1 year post-op. And it's doing pretty good. This is another example of a double curve, but this time it's left-sided. Usually the idiopathic curves in the right side are in the right side of the thoracic, and this girl was in the left side. So the anatomy is a little bit more complicated to do because we got the aorta and the heart. We got the gout reduction in both planes, and she's 1 year post-op. And this is the video she sent me 3 months after she was doing. She was in the park and she wanted to try out her flexibility, so I did this jumping video. There's another girl. It's a bigger curve, but the trick about this girl is that it's very flexible. So if it's very flexible, it's a good indication for the cord. It's not flexible, it's not a good indication. We get a 12-degree correction. She's 2 years post-op, and she's the video, I'm sorry, this is the video at 3 months. And this is another patient. This is more mature with a bigger curve, even though we get a decent correction in both planes. She's 27 months post-op, still no broken cord. And she do this. This is a 3-month video. So at 3 months, they already can do these things. This is another one. This is 15-year-old girl, mature one, was a swimmer. And at 5 weeks, she sent me this video. 3.5 weeks, she sent me this video swimming. So she started training, and she could do whatever she wanted with no limited in quality of life after the surgery. This is another example of things that can happen with this surgery. The cord breaks. It breaks 5% of the time when you put double cord, almost 30% of the time when you put a single cord. The revision rate for double cords is around 3%, and the revision rate for one cord right now to latest is being around 45, 48%. So we revise it here, we fix it, and she sent me this video dancing at 2.5 weeks post-op, and she's the one in front here. So I had to call her mom and say, stop, it's good that she's fine, but not at 2.5 weeks. She had to be more calm. But we also are starting doing in the early onset curves, because like Darryl said, the percentage of complications with the growth-friendly implants like Robin rods, magnetic rods, Sheila, or Vectors are very high. And this 8-year-old girl who got 24 castings before the surgery. And as you see, this is 10 days post-op, but at 6 months, she already corrected a little bit more. So the idea is that we can get her to 10, 11 years old, or we can do a fusion, or we can continue and change the cord. And this is the video of her playing at 2 weeks post-op. So right now, I'm doing this for 3 years, for almost 4 years now. But I think the only way to know if this really works or not is doing studies and doing research. So we're doing here a lot of studies in NYU with the data. We find out the site alignment conclusion that was correlate post-operative images, and it was better than fusion. The fractional curve was better than the fusion, but the fusion was a longer follow-up than the vertebral body tethering right now. I've been here a year and a half, so we need to wait to see longer follow-up. We did a derotation study to see if we derotate the curve with the cord. We find out right now that standing post-op and CT scan that we derotate, we have to wait to see 2 years if the derotation is maintained. And the other thing we did is we opened the thoracoabdominal area, and there's a lumbar plexus, and we want to know if there's any injuries. And right now, 13 patients only have some numbness. We don't have any motor function problems, and we need to continue to study. But it's very safe to do a thoracoabdominal anterior to the psoas approach in this type of patients. Complications, out of 70 patients, we have one screw that we have to revise, 2 pleural effusions that were drained in the office, non-neurological, 1 hemothorax because the screw was rubbing on the diaphragm after 4 months of post-op, and infection from a patient that was sent to me to revise who got 5 surgeries before. And this is another patient, one of my first patients. She's 5 months post-op, and she started to practice at 2.5 months, and at 5 months she competed in this meeting, and she had the 3rd prize after 5 months of surgery. So, but sometimes, you cannot do the cord, then you have to go back to the gold standard, and this is an example of 2 big stiff curves. And, I did a fusion because I think it was a better option than a cord. Not all the patients are candidate for doing vertebral body tethering. And these are the corrections. The patient is happy, but this patient is not a good candidate because of the size of both curves. And she's 3 years follow-up. It's doing well. So what are we going to do from here? Well, we need to continue to do long-term outcomes. Right now, we need to do more movement research about this really You have more movement in thoracic spine with the fusion versus thoracolumbar and thoracic. The technique have to be much better. There are only two systems in the market, and then I think they're gonna have to improve right now. And we had to talk with family and tell perspectives and risks and benefits, and tell them where are good candidates, where are not, and be honest and tell them you need a fusion or you need a cord. And we're gonna continue with data collection, registries, and complication data collecting. NYU is in the pediatric spine study group. They have more than 200 BBT cases, more than a year and a half that we put in data in. So in the next 2, 3, 4 years, there's going to be a lot of data coming up. I think we're still in the learning curve, and but things I think is going to get better. Results are better because indications we're learning from mistakes, and what we thought were good, no, they were not that good. So the indications now are better, and the results are better. So thank you so much, and sorry for late.
Thank you very much, Dr. Rodriguez, for that great talk and all the clinical videos. So we're gonna finish out at this point with the chief of our division, Dr. Protopsaltis, giving us a talk about adult spinal deformity, and then we'll go into our questions and closing remarks.
Thank you very much. Can everyone hear me okay? So I'm going to be discussing adult spinal deformity, and I just wanted to thank all the participants for staying till the very end. Sorry that we're running a little overtime. So adult spinal deformity is a complex set of conditions. It can range from adolescent idiopathic scoliosis patients who become elderly and have now worsening of their deformities. It can be patients who've had fusions and they weren't fused with enough lordosis in their lumbar spine, or they were flattened out or had too much kyphosis in their thoracic spine, and as a result now they have deformity, or they kyphose distal or proximal to their fusions, which is also very common. And so all these different treatment pathologies need different and tailored treatments for the deformity. So as an overview of the talk, we're going to talk about why measuring alignment is very important and all the various parameters that we use to assess deformity. Then we're going to talk about how important it is to determine flexibility of the deformity, because it impacts how aggressive we need to be with our surgeries. And then finally, we'll discuss a little bit about results and outcomes of operative and non-operative treatment of spinal deformity. We'll round it out with a discussion of complications from the surgeries, which can be considerable and sobering. So first, measurements. Why is it important to measure? And the reason is because these measurements have been proven to be correlated to functional outcome and disability. And so, looking at these patients, they can't stand upright. They have significant disability because their effort and muscle effort during their life is considerably more than someone who has good posture. And so when we think about parameters, there are pelvic parameters, spinal curvature parameters, and global alignment parameters. First, let's talk about the pelvis. The pelvis is a really important part of the spine. It's really the base, the foundation. It was called the pelvic vertebra by a very renowned spine surgeon. And it really sets the table for the rest of the spine, the alignment of the spine and the curvatures of the spine. So it's really the link between the spine above and the lower extremities below. And there's 3 parameters we like to measure, and they're related by this equation: pelvic incidence equals pelvic tilt plus sacral slope. Let's talk about pelvic incidence. This is probably the most important parameter, and the pelvic incidence is really the shape of the pelvis, and it determines the shape of the spine above it. And this is something that spinal surgeons can use to understand, as patients degenerate and they lose their lordosis, how much lordosis they've lost. So it's almost like a parameter we use to be detectives to dial in the right alignment. This parameter is aligned from the femoral heads to the sacral end plate and then are perpendicular to that end plate. And so that gives you the angle of the pelvic incidence. And then that parameter is not affected by positioning of the patient. It's kind of one parameter in all different positions of life. And actually, it doesn't change a whole lot over the course of one's life. So we call it morphometric. And if the pelvic incidence is small, like 38 degrees, which would be one standard deviation from the mean, which is about 55, then the spine shape doesn't need to be as curvaceous, whereas a pelvic incidence that's very large needs more curvature in the lumbar spine. So low pelvic incidence, less lumbar lordosis, less thoracic kyphosis. High pelvic incidence, more lumbar lordosis, more thoracic kyphosis, more curvaceousness. Next parameter I think that's important is pelvic tilt, and that is a parameter that determines how much compensation the patient is undergoing. This is the classic article that introduced that parameter. And basically what it says is that as the patients compensate more, then they need more compensation in their pelvis. They rotate their pelvis back for a larger deformity. And that's associated with disability. The more they're retroverting their pelvis to compensate for their deformity, the higher the pelvic tilt is, the more disabled they are. And again, this is that line from the femoral heads to the sacral end plate, but now the angle subtended by a line to the vertical. And as you increase your pelvic tilt, that line, you can see the pelvis rotates back. That's a compensatory mechanism. And that's where patients, how patients compensate, but they need to have good musculature around their legs and their pelvis, and they need to have good hips. If they have a lot of arthritis or hip contractures like this woman, they're not going to be able to retrovert their pelvis. And these are patients that really aren't necessarily deformed in their spine. They're just contracted in their hips. This is often people that are bound to a wheelchair or like to sleep in lazy boys or hospital beds instead of flat on their backs, which can be a real problem. You can see this woman doesn't really straighten out. Finally, there's a sacral slope, which is the least important of all the parameters in my opinion, but it's related to the other two with that mathematical formula. The more someone retroverts their pelvis, the flatter the sacral slope is, the smaller the pelvic incidence is, the flatter the sacral slope is, the more pelvic incidence there is, then the higher the sacral slope is, the more vertical the spine is. And this has implications, as this study shows, for mechanisms of how people end up with spondylolysis, whether there's a shear mechanism or the nutcracker mechanism in a high PI patient versus a low PI patient, respectively. Spinal curvatures. Lumbar lordosis needs to match the thoracic kyphosis. Thoracic kyphosis needs to match the cervical lordosis, and we call that the chain of correlation. Finally, global alignment parameters. The sagittal vertical axis is a plumb line from C7 to the back of the sacrum. The sagittal vertical axis has been shown to be correlated to disability measures, and patients can be sagittal backward or sagittal forward. Usually in the elderly deformed patients, they're significantly sagittal forward. And all these parameters have been coalesced into what we call this SRS Schwab classification. And those were pegged to disability measures and proven that as the parameters get worse, patients have more disability. Newer parameters like this T1 pelvic angle help you understand the deformity of the spine separate from compensation. They're also correlated well with disability measures. The problem with SVA is that you always have to think about whether or not there's compensation. You can't just say, okay, that patient's leaning forward significantly, because like we said, if the hips are contracted, there's no pelvic tilt, the deformity may not be as great as you think it is. Whereas with the T1 pelvic angle, you're not fooled by a hip contracture. You can measure the alignment of the spine separate from the pelvic compensation. Finally, I think it's important to tailor corrections to elderly versus younger people. Like the woman on the left shouldn't be should be straighter actually than the man on the right, who's more elderly and frail. And this is proven in studies like this that kind of give us a target for different parameters based on age. As the age increases, maybe you don't need to correct the patients as much. And what's at stake here is if you overcorrect people, make them too straight, make them look like their normal peers in their alignment when they stand, then you can get catastrophic proximal junctional failures, and then you need to do revision surgery, which is a real problem. And people are now recognizing that that alignment needs to be tailored also to the pelvic incidence. We talked about how it affects spine shape, but it also affects actual alignment itself. And the T1 pelvic angle increases as pelvic incidence increases, just as it does also with age. And so this paper showed that there can be optimal targets that aren't quite as straight as normal people are when they stand and walk, that you want to make patients fuse to. And it makes sense because these patients all have to do various activities like play with their grandkids on the floor and stand up and take walks, and they have to have one alignment that fits them. And that's the challenge for the surgeons. But just as an illustrative case, here's a 76-year-old woman. She's got a high pelvic incidence. And as a result of an overcorrection, you can see how much kyphosis she has at her cervical thoracic junction. That TPA of 21 might be appropriate for a pelvic incidence of 55 in like a 65-year-old, but for someone who's 76 with a pelvic incidence of 90, it's catastrophic and leads to real problems and pain. Whereas this lady who's 67 has a high pelvic incidence as well, but was not overcorrected. Her TPA is 34. She stands upright with no mechanical complications. Deformity flexibility is important. You want to do FlexX films or have them lay down in an MRI scanner and a CT like this paper showed. You can increase lordosis just by looking at how flexible they are passively sitting in a CT scan. And that increase in lordosis compared to standing is something you're going to dial in with surgery. And maybe you don't need to do a 3-column osteotomy when a patient has open discs and can increase their lordosis by 23 degrees just passively on the table. And even if there's a fusion, there can still be a fair amount of flexibility. Like you see here, the lordosis increased 5 degrees. And Larry Linke and colleagues did a study that showed that about 50% of patients are flexible and 50% are not, even in the unfused population. And their lumbar lordosis can increase after anesthesia and you place them on the table. Maybe you don't need to do the 3-column osteotomy you're prepared to do when you went into the surgery. And surgical tools, there's different osteotomies we do. In increasing grade, this classification shows you from the smallest osteotomy, just removing some of the facet joint, to the largest osteotomies where we're removing entire vertebral bodies. We can destabilize the spine and correct them. And so what about outcomes? Well, we have this paper that talked about non-operative treatment for spinal deformity. And when the deformities are large enough, there's not going to be a huge improvement with non-operative treatments. But in the select group of patients, there can be some improvement of 15%, which is not horrible. So non-operative treatment is always the first thing that's attempted. And then when patients realize that they're spinning their wheels and not getting anywhere, then usually we convert to operative treatment. This paper compared operative and non-operative treatment in 326 patients and looked at their leg pain response to treatment. And you can see that the non-operative patients are in red, the operative in blue, and if their leg pain improved, the bars go towards the left. So you can see all the blue bars on the left, which is improvement in leg pain, and all the red bars on the right, where the leg pain is either staying the same or it's getting worse. And the same is true for pain scales, Oswestry Disability Index, for back pain. Back pain and disability decreased more significantly with the surgery than non-operative treatment. This study tried to randomize patients to operative and non-operative treatment, but there was a lot of crossover, which is one of the limitations. Essentially, it's a case control study like the last one. And you can see the disability measures improved significantly in the operative cohort and not in the non-operative for the SRS 22 as well as the ODI. But complications can be significant: instrumentation failure, dural tear, neurodeficit, proximal junctional kyphosis, deep wound infection, often leading to revision surgeries. And who are the patients most at risk? The ones who are more depressed, have higher BMIs, more comorbidities. Baseline, they have worse deformities. Those are the ones that end up with the worst outcomes in the end. And so trying to optimize the patients before surgery, control diabetes better, quit smoking, improve the BMI, those are things that can be done prior to surgery. And that's what these protocols and these researchers have advocated, to have high risk multidisciplinary conferences to optimize patients before they undergo these big surgeries. And now there's also predictive modeling where we're looking to predict who's going to do well. And you can look at pseudoarthrosis, disability measures at 2 years, whatever you want. And a computer can help you understand which patient is more at risk for having a bad outcome. And that's what these kinds of analyses do with AI, artificial intelligence. You can pretty much peg the patient that you're seeing to another patient who's had a similar problem and has had a similar surgery that you're planning, and understand what that outcome is likely to be. And just finally, a quick case: 62-year-old woman with chronic back pain for 30 years, bad scoliosis, 8 out of 10 pain, chronic narcotic use. Prior to surgery, I asked her to, do more exercise, lower her narcotic dose, which she did. And then you can see the sagittal and coronal alignments are poor. T1 pelvic angle is 43. She should be closer to like 25. Bad SVA, a lot of pelvic retroversion. So she underwent the surgery intraoperatively. I confirmed that I got the target that I'm looking for, and Postoperatively, she's standing with a T1 pelvic angle of 26 degrees, which is significantly improved. She's no longer compensating with increased pelvic tilt, and she's happy with her overall final outcome. Thank you very much. I'm going to turn it over to our moderator. Thanks all the participants for staying till the very end.
Thank you very much, Dr. Protopsaltis, for a great talk. So we're in the question and answer portion of this. Thank you again for everyone who participated in the audience for hanging in and listening to this great course. So the first question that we have is there benefit to treat with a brace prior to 19 degrees?
Can you hear me?
Yep.
So it's a great question. And that's something that patients ask me very often because, you know, you get these curves and very often there's a positive family history and patients and their parents are uncomfortable just doing nothing. You know, you have a curve and it's 19 degrees and you say, well, I got to do something. What can I do? And the initial studies on bracing really show that there's the biomechanical principles of bracing is to try and modulate what happens to the curve. So there needs to be a certain amount of biomechanical force on the curve to be able to provide a roll. So I will on occasion brace somebody under 19 degrees, but the studies really don't show a lot of support. Unfortunately, a lot of times, you know, what we're doing is we're treating the family. And, you know, when patients are worried and there's a lot of angst about it, you know, I'll put them in a brace and start the treatment. I'll slowly wean them up. But biomechanically, there's little roll in less than 20 degrees.
Thank you for that. And the second question is, do you evaluate hip and hamstring flexibility separately from spinal flexion pre and postoperatively in your forward bending study? I think that this was referring to Dr. Patrizio's talk when you had two patients that were fused from T5 to L3 who had different ranges of motion.
Yeah, thank you for that question. You know, so this is a study that's you know, that's very interesting to me, and it's something that you know, that I've been curious about. You know, very often patients ask, you know, I'm going to have a rod that's about, you know, 2 feet long in my back. Am I going to be able to move? Am I going to be able to put my shoes on? And, you know, when I first started practice, you know, we didn't really have a good answer. It was always like, well, yeah, of course you're going to be stiff. You're getting a rod in your back, you know, but yet I would find that some patients were stiff and some were not. So I've been trying to assess why some of them bend better than others. And, you know, I was alluding to the pelvis in the lecture, but, you know, obviously there's a lot more to it, as whoever had asked the question, you know, was keen on. Hamstring flexibility is important. Hip flexibility is important. Ligamentous laxity is important. All those things play a role. And I'm trying to figure out which ones play a more important role than others. So yes, I do assess it independently, but I'm still not sure which ones are of principal importance.
Great answer. The last question that just came in, I think it was directed to Dr. Protopsaltis. I have a patient who I'm treating postoperatively for a C3 to C6 fusion. This fusion was done to extend her neck or keep her head in fusion when her postoperative cervical muscles are fatigued. She postures with extreme amount of lumbar lordosis and mild thoracic kyphosis. Does this sound like this is due to the pelvis?
So if I understood correctly, the patient had a C3 to C6 fusion and now is having difficulty extending the neck?
It seems that, and having issues with standing with hyperlordosis and thoracic hypokyphosis. If that makes
So
sense.
it's common for some patients to develop a dropped head or paraspinal muscle dysfunction, especially after a posterior approach to the spine, especially if they're elderly, they have sarcopenia. There's some other factors that can be associated with it, like Parkinsonism. And with weakness in the paraspinal muscles of the cervical spine, those patients kind of droop their head down. They have increased kyphosis at the cervical thoracic junction. And then to compensate, their hyperlordose their backs, and they flatten out their thoracic spine. In some cases, they may or may not turn their pelvis a little bit to help with the lumbar lordosis. And in some cases, it's a retroversion, and in other cases, it's actually a little bit of an anteversion. But they're just trying to change the angle so that they can look straight ahead. That's not a pelvic issue. That's entirely a paraspinal muscle issue. So I'd put that patient in physical therapy. I'd have them do exercises where they lay back on their back and push back into the bed, into the pillow. And if they can do that 3 times a day with 20 reps, that can usually help them. But they need to try to maintain as much passive motion and extension as they can, or try to improve that as much as possible by leaning on their back, even though that might be uncomfortable for them in the beginning.
All right, I think that's it for the questions. I'm going to hand it over to Dr. Protopsaltis for closing remarks.
All right, everyone. Well, thanks so much for participating in our comprehensive spine course. I'd like to thank all the presenters for their efforts and sharing in their expertise. It's been great. And finally, to the participants, hopefully we'll see you back for our next course. And please feel free to give us any feedback that you think will enrich the experience of the course. Thank you very much. Have a great weekend.